Good morning, everybody. Thank you very much for coming today. It's very delightful for us to see this conference that has been organized by the Iraqi Australasian Medical Association. A lot of the faces we see here today are actually our community leaders of the profession and all around Australia. So it's such a great pleasure to have everyone here today. I'd like to start by acknowledging the custodians of the land, the Aboriginal people and the First Nations of Australia, and we pay our respects to their elders, past, present, and into the future. And we would like to also thank the Macquarie University Hospital for this partnership to make this happen today. Also, we recognize the sponsors, Hologic, Douglas Pathology, and Osteointegration International for their sponsorship of the event today. We also thank the accreditation that was given by RACGP and the 6 CPD points that goes towards the GPs who were recognized today. If you are a GP and you would like that to be, the accreditation forms is available in the registration desk at the front. Just some house rules. If we had an emergency exit, then please proceed to the parking, which is just behind the building there. If we need any toilets, then we have toilets at the other side of the same floor, or there are more toilets downstairs. And if anyone needs disability access, there is a lift that needs someone to help you to get into. Can I ask everyone please to turn off your mobile phones or put it on silent? Thank you very much for that reminder. It's very important to mind as well. And can I now welcome Associate Professor Ahmad Alrubaie, the Secretary of the Association, to give his remarks.
Good morning. It's really refreshing to have all this number of colleagues to a medical conference on such a lovely Saturday in the post-corona era. I would like to welcome you all to our medical conference. Special welcome to our colleagues from interstate, particularly from Victoria. The conference is a continuation of series of medical conference. We were arranging under the title of Medical Committee in the Iraqi University Graduate Forum for several years. I think we got 7 of the annual medical conferences in a different setting from currently up until Corona era. And this is a continuation, but under the title of the Iraqi Australasian Medical Association. and this will be the first conference under this title. We called this conference the International Medical Conference in a first attempt to have a conference which is open to colleagues from outside Australia. We have an impressive response to the initial ad, to the extent that we deactivated the link for registration from overseas, from our colleagues overseas, because the number was big enough that the whole function room might be occupied by them. And we were worried that there would be no spot for them. Then we realized that getting a visa to Australia is something difficult, even compared with the European country. So none of them managed to get a visa to this conference. The conference is designed to accommodate the needs of our general practitioners, colleagues, and hospital trainees on the line of updated knowledge and practice in three main fields, which includes common gynecological disorders, common orthopedic disorders, and the management of obesity and overweight from all aspects through presentation by experienced specialists. All of them are Iraqi, by the way, and all of them are members of our organization. This conference wouldn't be possible without the great effort of a very dedicated team, which includes 12 and now 13 of our colleagues who are presenting today, and you will meet them throughout the sessions. The conference management committee, which includes our colleagues Dr. Basim Al-Ansari, Dr. Artin Arzivian, Dr. Alia Lalusi, Dr. Media Elias, Dr. Hussein Sinid, Dr. Bushra Alrubaie, and Dr. Mustafa Rida. I would like to thank them all. Thanks and appreciation are extended to Macquarie University for its support, with a special thanks to Bernadette Robinson and Lara Watling for their great help in the RACGP accreditation for the conference and for the purpose of the CPD points. I would like to thank our sponsors, Douglas Henley Moyles and Hology and Post Integration International. I wish you a fruitful and enjoyable time today. Thank you.
So we will start our first session, which is common gynecological problems, and we will have Dr. Batul Nadeem as the moderator, and she will be presenting. She will introduce the presenters, and she will introduce their bios one by one. She comes with more than 25 years experience in her field with subspecialty in ONG ultrasound, and she's very well recognized name in the profession. So welcome her.
Thank you very much for the lovely intro. Sabah al-khair, assalamu alaikum, good morning. I have the privilege to present the first session of today's gathering, which is the gynecological session. I hope it will be informative to all of you. Our first speaker for today is Dr. Jumana Faraj. Dr. Faraj is a graduate from Baghdad Medical University in the year 1995. She completed her specialist obstetrics and gynecology training at Liverpool Hospital and the Royal Hospital of Women in 2011. For her advanced training, she undertook a fellowship in endoscopic gynecology and in medical imaging. She is currently staff specialist at Royal Hospital for Women, working in both gynecology and medical imaging department. She is also a VMO at Prince of Wales Private and North Shore Private Hospitals. Dr. Farjo had a special interest in endoscopic and robotic surgery, and she is part of pelvic floor and urogynecology unit at Royal Hospital for Women, as well as the benign gynecology services. She also has a great interest in outpatient hysteroscopy, and in particular the case of diode laser in outpatient clinic, and has worked on establishing that service in the hospital in the last 6 years. Dr. Farja is also a training supervisor for the College of OMG and is regularly involved in teaching and research on the Medical Student University of the New South Wales. Now, Dr. Farja is going to present to us the abnormal uterine bleeding. Thank you very much.
Good morning, everyone. Thank you, Dr. Nadine, for the introduction, and thank you for the Iraqi Australasian Medical Association for organizing this diverse meeting. I was initially was asked to be a moderator for this session, but due to sort of last-minute change of the meeting plans, I became a presenter. So I was, within a short notice, asked to give this talk, and I chose the abnormal uterine bleeding as it has a quite great relevance to both GPs and specialists. The main focus of this talk will be on the clinical care standards that has been produced or published by the Australian Commission on safety and quality in healthcare that was published in 2017. So, am I correct, or I closed it? So, abnormal uterine bleeding happen in women in different stages in their life. It can happen in the premenopausal stage as well as the postmenopausal stage. And the types of bleeding that can happen in the premenopausal women is ranging from intramenstrual bleeding, postcoital bleeding, to a heavy menstrual bleeding that I will be focusing on today. So heavy menstrual bleeding is it's a quite common problem in women in their reproductive age group. It happens in about 25% of women, is usually associated with quite sort of disabling or affecting their quality of life. So a menstrual cycle is a quite personal experience for most women, and it's really hard to compare or define that sort of problem for most women. A lot of women consider it as a normal sort of thing that they have just to carry on with. In definition, the heavy menstrual bleeding is a blood loss of more than 70 to 80 ml per cycle, but that's really, as I said, hard to define. So we assess it or gauge it based on the effect on their quality of life. It can also be associated with abdominal pain or dysmenorrhea, which can happen in 50% of women with heavy period, and this also have an impact on their quality of life. A heavy bleed can lead to iron deficiency anemia, which can affect the women's general well-being. So the causes are diverse, and the FIGO classification system using the palm coin definition, which is like structural, dividing it into structural and non-structural causes. So for structural causes, you have the discrete pathology that can be found on ultrasound or diagnosed on histopathology, and things like an endometrial polyp or fibroid, malignancy, or hyperplasia. And then you have the non-structural causes, which are harder to identify on imaging. And these are things like coagulopathy, ovulatory dysfunction, endometrial pathology, and iatrogenic causes. Very important to when counsel the patient, to explain to them that often there's more than one pathology at one time. So removing a polyp or resecting a fibroid will not solve their problem, and different modalities of treatment should be considered. So the national or the clinical care standards, which is produced by the Australian Commission on Safety and Quality in Healthcare, were introduced because they identified in that review that there was a quite significant inequality in the healthcare provided to women in different regions in Australia. And the aim of these clinical standards is to provide the least invasive, most effective form of treatment, considering the women's choice and their desire for fertility. The Commission found that we still do more hysterectomies than compared to other sort of developed countries around us, like New Zealand or the UK. And there is also a quite significant variation between the mode of treatment that's offered to women in different regions in Australia. So they found that there was a 6.6-fold increase in the rate of hysterectomy in regional areas compared to cities or remote country. And then there is also significant increase in the endometrial ablation rate in cities compared to regional and rural countries. So they published 8 standards of care sort of recommendations, and I'll take you through them individually. So the first one focuses on proper assessment and diagnosis. So very important in any sort of patient assessment is the history and obtaining the right information, and there's a quite sort of standardized questionnaire we ask the patient about their menstrual history. As I said before, it's assessed based on the effect of the bleeding on their quality of life and if they have any other associated symptoms. The symptoms related to the non-structural causes like the bleeding disorder, polycystic ovarian syndrome, and thyroid disease should be addressed. Risk factors for endometrial cancers should be assessed, especially by the GP colleagues, because you will want to have these patients looked at and investigated sort of promptly. So women with high risk factor for endometrial cancers, like women with polycystic ovarian syndrome, obese patient, diabetic, people on tamoxifen, are all at high risk, and these women will require prompt investigation, and also the type of treatment that can be offered to them has to be more definitive treatment. You want to stay away from like sort of ablating the endometrium, which then make it harder for them in the future to be diagnosed if they would have developed malignancy. Cervical screening history is very important, and like sort of abnormal pap smears and cervical cancer can present with abnormal bleeding. And then you want to understand their sort of sexual and reproductive story and their future desire for fertility to gauge and decide what sort of treatment you will offer these patients. Physical examination and investigations are very important, so focusing on like sort of basics, general appearance and vital signs, abdominal examination, palpate for big fibroids and bulky uteruses, bimanual vaginal examination, and the cervical screening. Always with women with bleeding and any women with sort of reproductive age group, you have to exclude pregnancy. And then look for iron deficiency anemia, and organize all the other relevant blood tests to rule out any non-structural causes. And then we will focus on pelvic ultrasound later when we address one of the other standards. So informed choice and shared decision making is one of the statements that they produced. And the aim is to try to engage these women in the decision making regarding the choice of treatment. It's not always they have like sort of to tell them that you have to have a hysterectomy or you have to have this option. You have to offer all options, and they have to choose from these options. When you do that, you have to focus on what risks and complications involved with each procedures, and what are the success rates in each of these procedures. You have to consider all sort of cultural and religious factors and their desire for future fertility. A lot of women that walk into our rooms have misinformation about what treatment they are going to undergo. So they already have a preformed ideas, and that comes from different sources. It can come from Dr. Google, and I put this picture of women chatting because that's the most common thing. They come and tell me that my mom, my friend, my sister, whoever, not considering the big picture and not considering individual patients. The first most important thing is to discuss this misinformation and try to rectify it. So the next quality statement was about initiating treatment, and that comes from the GP colleagues. So initial treatment is always medical. And while we're waiting for further investigation, we can always do something about the heavy period. So this sort of type of treatment will depend on what sort of problem these women are having. So if they have irregular heavy period, if they have painful period, if they desire contraception, and also you have to discuss the side effect and the success rate of each of them. So the most common pharmacological options are either non-hormonal, which is like non-steroidal anti-inflammatory drugs, and they are quite helpful if the women also have dysmenorrhea, but they can reduce the heaviness of the period by about 20%. If you combine it with tranexamic acid, that's about 40 to 60% reduction in the heaviness of the bleeding. The hormonal options, and the most common one, is the long-acting IUD or Mirena, and there's a sort of a baby version of it called Kyleena. And then you have the combined oral contraceptive pill or the progesterone-only pills, and they are not commonly used to treat menorrhagia, but there is a new type of progesterone-only pill called Slinda, which has been quite helpful as well. Then you can use cyclical progesterone, and as gynecologists we prefer Provera, but a lot of GP colleagues like Primulu. Then you can also offer the injectable long-acting progesterone like Provera, but you can't use it for extended period of time. You sort of try to minimize it to a short period of 1 to 2 years to reduce the risk of osteoporosis. This is a topic that statement I like because I trained in ultrasound, and quality imaging is quite sort of important in all aspects of gynecology. So it is done to investigate for structural causes and to exclude malignancy. It ideally should be done between day 5 to 10 of the cycle to obtain sort of a thinner endometrium, and you can then identify pathology easier. And you assess for all different aspects of the endometrial thickness, appearance, vascularity, polyps, fibroids, and also for things like adenomyosis and adenomyoma. So this is a picture of a woman in her 30s with menorrhagia, the scan done, and it was reported as normal. But two important things I would like to look at that image and understand is where is this woman in her cycle, and if this was done in the second half of her cycle, probably that's a normal endometrium. But if it was done straight after period, that's a thickened endometrium. Also, I would like to put color Doppler on this image to see if there was any vascularity within the endometrium. The same patient, if you put a bit of saline in and you do a procedure called the sonohistogram and you put color Doppler, you will find that this was not a normal endometrium, and it had polyps and it had blood flow in it. The fifth one statement is about the use of IUD, and this is quite important because IUD or Mirena IUD are a game changer in gynecology. It sort of changed gynecology a lot because it's not only a contraceptive, but also it's being used for all sorts of reasons like menorrhagia, dysmenorrhea, and all other reasons. So it can be used for all women in all age group, regardless of their parity. Can be put in an outpatient or in theaters. You sort of, any women in the reproductive age group, you want to screen them for STI, and you have to talk to the women about side effects. And the most common thing is the bleeding and the pain that happen after the insertion, which can last a few days, few weeks, few months, but it will eventually settle down. We often ask women to wait for 3 to 6 months to assess how well they do with it. It depends also on the size and the shape of the uterus. So if you have a big uterus, it might not be suitable. If you have a septum or a bicornuate uterus, it might not be suitable. The sixth quality statement is about specialist referral. So when to refer if you're concerned about malignancy, and if you have pathology identified on ultrasound, and when you failed medical treatment for 6 months. So there is all these other alternative treatments that we can offer women. So this is a polyp, and the polyps are quite common. There's all sorts of reasons why they happen. They are rarely malignant. They're most commonly benign. And we treat them because if they present, mostly they're asymptomatic, but if they are big enough, more than 1 centimeter, if they're multiple, and if they're giving symptoms, we treat them. This is a picture of polyps. And fibroids are most common pelvic tumors, and they're quite common in women. Again, they're mostly asymptomatic. And there's a classification system for fibroids, depending on where they are in relation to the uterus, and there's all sort of risk factors for it. If they were symptomatic, the most common symptoms they give is heavy period. They also can give bulk or mass effect pressure on the pelvis, bladder or bowel problem, and they can impact fertility depending on where they're located. Again, all this assessment, ultrasound, sonar histogram, looking inside the uterus, doing a hysteroscopy, and MRI if you are planning sort of complex intervention surgery.
1 minute.
Sorry. So hysteroscopy for removal, all different options. This is MyoSure. Hologic is sponsoring the tour. So MyoSure is a morcellator. So it's used to mainly, I personally prefer using it for a large, bulky intracavitary fibroids, and it sort of chips it in small pieces and suck it out. Then you have the laser, which I sort of use a lot in outpatient, and it has its own advantages and limitations. And this is the laser. So it cuts and burns at the same time. And it can pass through a very small scope. It has its own benefit. Then you have all other different fibroids that's in the wall or outside the wall. It can be managed surgically, laparoscopically, robotically, whatever people prefer. Then we have endometrial ablation, which is a destruction of the endometrium and can be done in an old-fashioned way using a resectoscope, or can use devices like NovaSure. And the NovaSure, this is the sort of demonstration of how the NovaSure works. And it has its own sort of limitation or contraindications. If you have infection, if you want to preserve fertility, it's not a good option in postmenopausal women, or if you have a large cavity. Very important option is the endometrial ablation, because a lot of women are requesting it in the city or where I work. They have, very important to know that it only reduces the heaviness of the period. It's only 20% chance that they might not have a period again. The last statement is about hysterectomy, and it can be done all different ways: vaginal, laparoscopic, robotic, abdominal, total, subtotal, where you leave the cervix or take it out, take tubes out at the same time, remove ovaries depending on the age and the risk factors, and we have to address all the risk and complications. So when you apply these standards of care and when you counsel the patient appropriately, you will find most women will be happy to the sound of no more or less period. Thanks a lot.
Thank you, Dr. Jumana, for an interesting talk. Thank you. Now I will present our second speaker for today, Dr. Media Elias. Dr. Media is going to give us a talk about an update on hormone replacement therapy and perinatal testing. So Dr. Media has finished her training in various institutions in Victoria and in New South Wales. She obtained her fellowship from Royal Australian New Zealand College of Obstetrician and Gynecologist, and since then has been working as a consultant obstetrician and gynecologist in both public, Western Health, Sunshine Hospital and Private Hospital in Melbourne, at North Park Private Hospital in Bandura, Western Private Hospital in Footscray, and St. Vincent Private Hospital in Werribee. She has a special interest in colposcopy, advanced laparoscopic surgery, endometriosis, menopause, prolapse and pelvic floor repair, and high-risk pregnancy. In addition to all of the above, Dr. Media has the following roles. She's an examiner for Australian Medical Council. She is a training supervisor for the Royal Australian and New Zealand College of Obstetrician and Gynecologist, and she's a former discipline leader and examiner of the medical students at Notre Dame University. Please join me in a warm welcome to Dr. Media.
Thank you so much, and good morning, and sabah al-khair kulkum. Thank you so much for the invitation. I feel really honored and privileged to present in this very nice conference, and lovely to see you all. And special thanks to, Dr. Ahmad Alrubaie. We don't have to forget his massive work to put this together and bring us all here. I've been given 2 talks and time limit of 20 minutes, so I will try my best to fit in 2 big topics. The first one is about aneuploidy screening in pregnancy, and what can we offer in that field.
Yep.
The main objectives of the talk will be to be able to educate patients regarding their options for prenatal genetic screening, including the benefits and the limitations of the test, and also to be able to explain the meaning of the prenatal genetic screening results and then the next step. The main two questions that most patients walk in asking is, my baby normal? And doctor, can I please have the Down syndrome test? The most common chromosomal cause of birth defect and intellectual disability in both children and adults is Down syndrome or trisomy 21. And this is why most lay people focus on it. And it accounts for about 52% of all major chromosomal conditions currently detected through prenatal testing. And as we know, the prevalence of Down syndrome screening has direct relation to the maternal age, and we can look at that curve and see that rise of the curve depends on the maternal age, and that rise starts from the age of 37. But truly that the curve will start curving up from the age of 35. So that's why we call it as maternal age from the age of 37 in obstetrics, because of that increases. And the options for aneuploidy screening, we have 3 main tests. The first one is the combined screening, where they have the blood test done at 10 to 11 weeks, and combined with the ultrasound scan for the NT between 11 and 13 completed weeks. It has a detection rate of 75 to 85%, and it allows early morphology detection of any fetal abnormalities. The second trimester screening will have less detection rate of 70 to 75%, and we can do it later in women who miss the first trimester screening between 15 and 20 weeks, but they all need and must have a dating scan for that to be done. And the newest one is the non-invasive prenatal testing using cell-free DNA. That has much higher detection rate of 99.5% and can be done anytime from 10 weeks, and it must have a dating scan to allow any information about possible abnormalities. The cell-free DNA, which I will focus on a bit more, we know that cell-free DNA are short fragments of DNA released into the bloodstream through the natural process of cell dying or apoptosis. And during pregnancy, the mother's blood contains cell-free DNA both from her own tissues and also from the fetus through the placenta. And about 2 to 20% of total cell-free DNA in maternal blood is placenta, which is what the test is mainly focused on. The fetal component of that is known as fetal fraction. The main three trisomies that get tested on the NIP test are trisomy 21, trisomy 18, and trisomy 13, and also look at sex chromosome inequalities and microdeletion. And if the woman chose to have the NIP test or the cell-free DNA testing, we know much more about it now than before. It was started in 2013. It has very high sensitivity and specificity rate, and it is the best screening we have now for Down syndrome. However, the cell-free DNA is currently more expensive than other screening. It has no Medicare or private health insurance rebate. And clinicians should inform the availability of the test as an alternative, not a combination of the other screening tests. And if the woman chose to have the cell-free DNA testing as a primary screening, they still should be offered the 11 or 13-week scan or the NT scan for early detection of any major abnormalities. Because 50% of very early abnormalities can be detected with a good quality scan. And combination of cell-free DNA with the maternal serum screening test is not really advisable because it increases the false positive rate and does not increase the detection rate. But also it will add more cost. So when is the NIP a good option? It's a good option for advanced maternal age. It's a good option when there is an increased risk in the first trimester screening test and in women who have had previous trisomies or they basically just want to do it. When it's not recommended and when the woman really wants a definitive answer, I want to know 100% sure if this baby is normal or not, it doesn't give us a definitive answer because there might be other chromosomal abnormalities that are not tested. When there is clear abnormalities on the scan and it is not going to give us or add anymore, we will need diagnostic tests. And when the risk is clearly very high, more than 1 in 50 on the serum screening test, then we should not add another test, but also the time delay with another testing before the diagnostic test. So in summary, the advantage of the NIP test or the cell-free DNA is an excellent detection rate, has low false positive rate, it can be done as early as 10 weeks, it's not invasive, and it gives us a clear cut. But it is expensive, it is non-diagnostic, it's still a screening test. Positive test result will require further confirmation with diagnostic tests and does not screen the entire genome, and we also can have failed result from low fetal fraction. So if we have a patient walking in, she's pregnant with her first pregnancy, really wants to have the test done, but then we receive the test and the test result says that the test has failed. What do we tell the patient? We know that this is the test limitation. It can fail in about 1 to 8% where there is no result reported. It doesn't mean it's abnormal, it's just no result will be reported. And in those cases, 50 to 60% of that can be redone by a subsequent redraw, and the performance of that will depend largely on the fetal fraction. The factors that can affect the test result is the gestational age, the maternal obesity, and the chromosomal abnormality presence. What about in multiple pregnancies? All multiple pregnancies, twins, triplets, and above need to have a first trimester screening test for chronicity and for early fetal morphological abnormalities. In twin pregnancy, cell-free DNA can be done and can be offered with appropriate pre-testing and also the mention of the slight increase in the test failure rate. It can also mention or give us an indication about fetal sex, but if there is a Y chromosome present, then it will not be able to say both babies are males or when. If there is a pregnancy with triplets or high order of pregnancies, then the main screening for chromosomal condition should be performed by the first trimester screening in addition to the other markers. Take-home messages that the NIPS test is not diagnostic test, it's a screening, and abnormal results still require confirmation with diagnostic test. There is currently no Medicare or private health refund for the test. It's an option for the women who will be able to self-fund the test on their own. And pre-test counseling is very important about the test limitations, the results, and the further steps if the test is positive. And due to public health awareness now, most of the patients walking in and they're actually asking us about the test before we mention it. The screening should be an option that's mentioned to all women in all ages, not just in women with older women. And cell-free DNA has excellent sensitivity and specificity, but it has its own limitations. And all testing, as well as the cell-free DNA, should be voluntary. So it is not a must that the patient should go for it. And a good quality scan is really important in that matter. And the next test is not recommended in the presence of any structural abnormalities, and a good quality scan will ensure that. Once the test is being formalized, then we should have a clear pathway for the patient of what is next. If it's positive, with a further consult. Thank you.
So I hope I was on time.
Yeah, excellent. On spot.
Great.
The next talk now takes us to the other end of women's menstrual life, which is menopause. So this topic is about hormone replacement therapy, and I really try to make it a little bit easier for us all in the 10 minutes. And the two main objectives would be to refresh our memory and strengthen the basics of hormone replacement therapy and clarify the risk, benefits, and also clarify some myths around hormone replacement therapy. Menopause is cessation of period or menstruation, 12 months from the last menstrual period, and the average age in Australia is the age of 50 years. Perimenopause is that period transitioning to menopause that has a wide range of symptoms, but really it can last for many years, from the age of 45 to 55 years of age. The premature menopause is when menopause happens below the age of 40, and that accounts about 1% of women. And early menopause is when it happens at around the age of 45 or less, and about 5 to 20%. These are the symptoms that we try to control and treat. So lucky for all the men in the room that they don't know what we're talking about most of the time. But we treat these symptoms mainly to avoid the 7 stages of menopause. It is challenging because 1/3 of a woman's life she goes through menopause, so there is more also with post-cancer patients survivors. They had breast cancer or oophorectomy, and they have early menopause surgically because of that. Quality of life is important. Often this requires multiple visits. We're all busy and we are on time restriction. The main hormone replacement therapy that we use is estrogen, the progestogen, which is used as an endometrial protection to avoid endometrial hyperplasia, and testosterone that we use sometimes. These hormone replacement therapy are truly effective and probably the only way of controlling the menopausal symptoms, and also has benefits for bone production. It comes in variable preparation of different doses, types, and routes of transmission. In terms of safety of hormone replacement therapy, the 3 main areas that we need to cover: the risk of thromboembolic disease, risk of heart disease, and risk of death. And we need to discuss with each and every patient each time we see them for hormone replacement therapy. And the 2 main regimes are estrogen and progesterone combined, or estrogen only in women who have had a hysterectomy, because we don't need to do to add progesterone for endometrium. The benefits of hormone replacement therapy, the main one is to control the symptoms, improve bone density, and reduce the risk of fractures. It will also reduce cholesterol and reduce the level of diabetes. And it does not add into the weight. But if we take the risks one by one, and if we talk about how much is the risk of thromboembolic diseases, we use combined estrogen and progesterone regime in an oral form, tablets,
then the risk of thromboembolism or blood clots doubles. Sounds scary when we tell the patient that we're doubling the risk, but we are really, the true added risk is 1 case per 1,000. So the actual risk is not very high. Yes, it's doubled, but it's not very high. The risk of heart disease, estrogen and progesterone combination, does not increase if it started within 10 years of menopause. Estrogen only may provide some protection. In saying that, hormone replacement therapy should never be used to prevent heart diseases. That is not an indication at all. The risk of breast cancer, there is no increase in hormone replacement therapy use, and risk of breast cancer if it's used for 5 years or less than 5 years. Combined hormone replacement therapy use, the risk can increase after 5 years, but again, that risk is only by an added 1 case per 1,000, not a major increase. And that risk can be reduced by careful selection of progesterone component, and we use natural or the high progesterone that will not increase the risk of the breast cancer. And estrogen only will not increase breast cancer, so for women who have had an hysterectomy. Risk of stroke, there is no increased risk or added increased risk of stroke for hormone replacement therapy users in women without any underlying other causes like smoking or high BMI or alcohol intake. Local symptoms, many genitourinary symptoms, will be treated with topical treatment, and that's the only way of controlling the topical symptoms. And we don't have to add progesterone in that case for endometrial protection, as topical use will only affect the serum level very, very little. Can it be used for over 5 years? It is possible to continue hormone replacement therapy after 5 years with proper consultation and individualized assessment. And women with early menopause, less than the age of 45 or 40, they should continue their treatment up until the age of 50 for their benefits. Tibolone is unique and slightly different. It has estrogen, progesterone, and also androgenic effect. It also does not increase the risk of breast and density, and also we don't need to add progesterone with it, so it's a one-off treatment. And it does not increase the thromboembolic disease. Like any other medication, hormone replacement therapy will have side effects. The main ones are headaches, breast tenderness, fluid retention, bloating, nausea, and mood swings that the woman will initially have in the first few weeks. Most of the time, these symptoms settle with ongoing use. When do we stop it and how do we stop hormone replacement therapy? Two choices, either by suddenly stopping the intake or gradually reducing it. Reducing the hormone replacement therapy gradually will have lesser effect on the short-term symptoms, but really no long-term effect either way. Take-home message is that hormone replacement therapy is more effective treatment for menopausal symptoms, and improve quality of life and sexual function, and improve joint-related aches and pains, and sleep cycle, and also vaginal atrophy. For the majority of women, the benefits will by far outweigh the risks, and if it's used or initiated below the age of 60, and consider the risk and the benefits as per individual base, and aim to commence the hormone replacement therapy within the first 10 years of menopause, and consider transdermal preparation or gel preparation to reduce the risk of thromboembolism rather than oral intake. And there is no evidence that increased breast cancer risk with the use of vaginal estrogen, so it can be used safely. The feedback from the patient we get when they happily control their symptoms is that they finally, the someone listening to them, their symptoms were controlled, they have better quality of life, and they all acknowledge that yes, this is a condition unique to women, but nobody can ignore the big portions of men and their role in our problems. Thank you.
Thanks, Dr. Media, for a very interesting topic. I'm sure it will raise lots of questions, which we will have time for it after we finish our last presentation. Our next speaker will be Dr. Ahmad, who will give us an update on endometriosis. So, Associate Professor Ahmad Mahmood is a consultant obstetrician gynecologist in Northwest Sydney. He holds position at Blacktown Hospital, Northwest Private Hospital, and Macquarie University Hospital. He completed his undergraduate medical degree at Mosul University and his specialty ONG training in Egypt. He has done further international training in advanced robotic and laparoscopic surgery and has developed a special interest in endometriosis and pelvic floor reconstruction surgery. Associate Professor Mahmoud is a senior member of the Sydney Western Area Pelvic Surgeons, SWAPS, which is a highly sought-after program that enables trainees to train further and improve their surgical skills and knowledge. He is committed to teaching and supervising junior colleagues and also trains doctors internationally in Thailand and Iraq in advanced robotic surgery. Please welcome Dr. Ahmad.
طبعا هذا أنا لما كنت شباب. Thanks for everyone. Thanks for attending. The actual presenter for this talk was Dr. Haider Najjar from Melbourne, but in the last minute he couldn't come, so we had to make some changes. And my talk went to Dr. Farjo, and Haider's talk came to me. So last night I was just going like crazy trying to get my head around. So we thought. بس أنا زرعت شعر. Okay, can you hear me? Okay. So Dr. Haider Najjar's talk was about endometriosis and fertility. I had a talk which was very long, so I thought I'll use his talk for the sake of time. So learning objective is to learn about signs and symptoms of endometriosis and adenomyosis, understand the limitation and gold standard of diagnostic tools, management of endometriosis and adenomyosis, including multidisciplinary and holistic approach, impact of endometriosis on the fertility and its solutions. So theories about pathogenesis. So we all know that it is multifactorial disease. There's no one knows exactly why endometriosis, what's the reason of endometriosis. The most common theory is retrograde menstruation. There are some other theories like altered mechanism. Other sources include stem cells, mesothelium, lymphatic or vascular dissemination. And also there's a theory about pre-menarchal endometriosis. So there's some theories saying that someone has had endometriosis even before they start having periods. Or some genetic causes, which none of them is proven, to be honest with you. Incidence, to be honest, endometriosis is most common than we think. It's actually very common. And the more I see patients, the more I see people coming with different symptoms that it may raise the suspicion of endometriosis. So people aged between 30 to 34 most likely to receive this diagnosis, and the incidence is 1 in 9. On average, it takes about 6.5 years to be diagnosed. Because people go to the GP with heavy period pain going to the legs, pain going to my back. They get treated with different diagnoses until they reach to someone who raised the index of suspicion for endometriosis. And it's recognized by NHS as it is top 20 most painful conditions in the world. Signs and symptoms. Probably our GPs in the room and other specialities also know that it has the most common symptom is the pelvic pain and period-related pain like dysmenorrhea, and affects people's daily activities and quality of life. Deep pain during sexual intercourse called dyspareunia, period-related cyclical GIT symptoms and painful bowel movements, which we call dyschezia in our medical language, period-related cyclical urinary symptoms, and hematuria with period time if they have bladder endometriosis. Infertility in association with one or more of the above or none of the above symptoms. So basically, sometimes patient comes, they can't fall pregnant, and when you investigate them, you find they have endometriosis, which is causing infertility, like blockage of the tube, but they don't have pain, no pain. So it's very weak disease. So And as we said, symptoms can vary from none to severely disabling pain. No good correlation between severity of symptoms to severity of the disease. So you might find a lady has stage 4 endometriosis with no pain, or someone have very superficial endometriosis, they have severe pain. Symptoms may correlate with the site of the disease. As we know, endometriosis can present anywhere. Sometimes in the lungs, sometimes in the brain, sometimes under the skin. And for example, if someone has cyclical hemoptysis or cyclical pneumothorax, can raise the suspicion of endometriosis. And also if it's under the skin, you might find there's a lump which is getting bruised and thickened and tender every time they have periods. So what to do? As we know, go to basic history, examination, investigation. History is type and timing of the pain, cyclical pain, as we said, severity and how it affects the quality of life, how much analgesia they take, does it affect the fertility, and when you examine, so if it's very obvious endometriosis, if you do pelvic examination, when we call it bimanual examination in the gynecology, you might find the uterus, we call something called cervical motion tenderness. When we push the cervix, it's very tender. And you might feel nodules or tethering around the uterosacral ligament in the posterior fornix, or you might find a mass, which can be endometriosis in the ovary, endometrioma. Ultrasound by well-trained ultrasound doctors like Dr. Juman or Dr. Batul can be helpful comparing to the general ultrasound places, because they know where to look for endometriosis, the nodularity in the uterosacral ligament, or they can look into the endometriosis in the pelvic sidewall. That's why when we refer, we always refer to tertiary units, not like a normal ultrasound. They do gallbladder or shoulder and stuff like that, so they don't need to be trained like Dr. Fajr or Dr. Nadeem. They are trained specifically for this. Other imaging can be helpful. It could be MRI, especially if you want to look for presence of nodules or bowel involvement, especially between the rectum and posterior cervix, which is called rectovaginal fascia, and you can see that there is a nodule there, and that will be helpful for surgical planning. As a gynecologist, when we have grade stage 3 or stage 4 endometriosis involving the bowel, we need our colorectal colleagues to be there so they can help to clear the bowel so we can do our part. Tumor markers like CA125, it's non-specific and it's not recommended to do. If you do it, it will show you it's a bit high, but it's not going to help you. And when to refer patients. Consider referring patient if they have severe, recurrent, or persistent symptoms, signs of endometriosis on examination, and signs of endometriosis on ultrasound, or adenomyosis, endometrioma, and symptoms of DIE, which is deeply infiltrating endometriosis. Initial management is not effective, not well tolerated. So if you are a GP and someone coming with a pain and heavy period, and you give her the pill, you give her non-steroidal, you give her all these basic, and then still not responding, then probably that's time to refer to a gynecologist. Or someone for fertility, refer for pregnancy and fertility planning, and usually endometriosis treatment need multidisciplinary team, especially if it is advanced stage 3 or 4 endometriosis. We might need urologist, colorectal, or upper GI if it is under the diaphragm. So this is some pictures. This is so this is a normal uterus, normal ovary, normal tube. You can see this is the pouch of Douglas, left uterosacral ligament. This is all normal, right ovary, left ovary, So this is the pouch of Douglas, and this is the rectum here. When this is obliterated, that's considered advanced endometriosis. And this is the normal cavity of the uterus. This is, you can see the pouch of Douglas here has superficial endometriosis, and there's superficial endometriosis in the right ovary here, small black dots, red spots, and here everything is, the pouch of Douglas is blocked with severe disease. And here's the right ovary, left ovary is stuck to the left uterosacral ligament. You can see the difference between this and that. This is look very messy. Again, there are some photos here. We have this dark area is endometriosis in the left pelvic side wall, and this is after it's resected. Here again, it is, you see, causes scarring and damaging to the peritoneum and can infiltrate deeper and deeper. And this is after it is excised. It's empty. Staging, stage 1, stage 2, stage 3, stage 4. So the more superficial it is, it's less staging. And the more deeply infiltrates, the staging go higher and higher, and then starts adhesion and destructing the organs surrounding, like it starts nodularity from the uterosacral ligament, goes into the ovaries, and then involves the bowel, then involves the bladder, and it's not cancer, but it can start destroying locally, damaging the surrounding tissues. Adenomyosis is another topic, but it is related to endometriosis. It's called the bad cousin of endometriosis, because instead of the endometrium going outside of the uterus, it is infiltrating into the wall of the myometrium, causing thickening of the wall of the uterus, which means every time they have periods, they have pain. It also can cause dyspareunia and also heavy bleeding. And it affects 20 to 30% of women. And also 50% of people also have pelvic endometriosis when they have adenomyosis. It's estrogen dependent, same like endometriosis, flares up with the estrogen. Diagnosis of adenomyosis, there is no universal classification for the diagnosis. At least with the pelvic endometriosis, we do the laparoscopy, and we can confirm, and we take biopsy. But when it is in the wall of the myometrium, you can't dig into the myometrium and take a biopsy, especially if they are still premenopausal and they want fertility and kids. So we can also only suspect. But again, our ultrasound colleague, they are very good at telling the signs of endometriosis, which include Venetian blinding, heterogeneous looking, and globular features. And this is, you see the ultrasound showing thickening wall of the uterus, and this is the MRI. See that the endometrium is in line in the middle, and the posterior wall of the uterus is thickened, and I think it could be adenomyoma. I don't know, Juman, what do you think? Yeah, it's small like adenomyosis. Management, so we have medical treatment and surgical treatment for endometriosis. So it's usually, it depends on how bad are the symptoms, so we need to tailor according to the individual needs and the preferences and priorities in terms of pain and fertility. Simple analgesias a lot of time could be enough, like paracetamol and non-steroidals. Hormone therapy can reduce pain and no permanent negative effect on fertility. That's what always they ask me, doctor, if we put Mirena, can I have babies? Of course you can. It's not going to affect. If I'm going to have a pill, I'm still 17, is it going to affect my fertility? It's actually contraceptive, and it is when you stop, you are fertile again. So the good news is the hormones work to shrink the endometriosis. Other treatment is GnRH agonist and antagonist used in the setting of deeply infiltrating endometriosis, pre or post-op. So if someone, in my practice, I excise the endometriosis, I put Mirena in, and I assess them in 3 months, 6 months time. If the pain is existing, I'll add some more oral progesterone, and then I assess them in another 6 months. If they are not still responding, my GnRH agonist will be my last resort. I'm going to just jump into it because it gives them menopausal symptoms, because it stops the ovaries from working for 6 months. So they get hot flushes and side effects, headaches, hair loss. Non-pharmacology treatment like behavioral, psychological medicine, lifestyle, exercise, relaxation, mindfulness, complementary medicine, acupuncture, TENS machine, herbal medicine. I don't know how much it works, but you know, people try it. Allied health, physiotherapy, pelvic physiotherapy, especially if they have dyspareunia and bladder and bowel symptoms. Surgical management, the aim is to remove any endometriosis deposit and to normalize the anatomy with minimal tissue destruction, especially if the fertility preserved. So we try to, if the ovaries are stuck to the pouch of Douglas and the person is, the lady is infertile and she's going to IVF clinic, so we as a gynecological surgeon, we try to mobilize the ovary, move the bowel out of the way so the IVF person can do egg collection vaginally for the patient. There is ablation versus excision of endometriosis, and so either you burn it or you take it, cut it. There is a lot of debate whether excision is better than ablation. I personally think excision is better. Laparoscopy is preferred way of diagnosis and treatment, has a short recovery. I added this line to Hyder's presentation. Also, robotic surgery provides 3D vision and has better access if robotically trained gynecologist. Severe endometriosis involving bladder or bowel may need multidisciplinary approach. As I said, we need the urologist, we need the colorectal surgeon to help us to mobilize the bladder or cut incision from a bladder. Our insurance doesn't cover that. And also for colorectal to help us to mobilize the sigmoid, the colon, and I don't know whether you heard of the kissing disease, kissing ovaries, when they come with endometriosis to the middle and they're stuck and the rectum is in between, and we need the colorectal surgeon to help us with mobilizing the bowel. Primary surgery is very important because the outcome may be increasingly poor with subsequently performed serial procedures. So if someone has endometriosis, it's better to be done the first time, to excise as much as you can of the disease, because the scarring happens for the next time, then it becomes difficult to find the planes. So recurrence of endometriosis is high. 40 to 50% of patients will become symptomatic and 30% will need another surgery in 5 years. In patient not wanting immediate fertility, consider hormonal suppression immediately. As I said, excise the disease and put some hormonal suppression. And also always talk about fertility, testing of fertility. If you think you've done extensive disease, probably it's better to do AMH level before and after of to check for egg reserves. Egg freezing, another option if you think you've kind of damaged the ovary with the treatment. Surgical treatment of adenomyosis, difficult if fertility preserving, required mainly symptoms management. So adenomyosis, as I said, it is in the wall of the uterus. It's an endometriosis in the myometrium. So it's not like peritoneal endometriosis that we can remove. Sometimes there is a adenomyoma that forms in the myoma, which looks like a fibroid, which looks like round, and then becomes a problem when you want to remove it, because you're going to cut into the myometrium. Endometrial ablation that Dr. Juman talked about for heavy period to reduce bleeding, but not, this is of course for someone who doesn't want fertility. If they have menorrhagia, you want to reduce the heavy period, but you will
burn the endometrium, but the myometrium is still painful. Every time they have periods, they will have the cramps. So in short term, the best solution for adenomyosis, in my opinion, is hysterectomy or Mirena. If they respond to Mirena, the Mirena will give progesterone locally into the myometrium, and it will relieve the symptoms. If Mirena doesn't work, I think hysterectomy is the best. GnRH suppression, but you can't use that a long term, is usually 6 months, and hysterectomy, as I said, as a definitive treatment for adenomyosis. This is a thickened wall of the uterus, and then when they cut it, it is adenomyoma, and they sutured it. As you see, it damages the wall of the uterus. If fertility required, in this case, probably she needs cesarean section because the wall of the uterus is already weakened, and they might have a rupture of the uterus if they have a baby. Take-home message, 1 minute. It's common, early referral is important, history of examination and pelvic ultrasound is important, treatment needs to be individualized and need according to the need of the patient, age, symptoms, fertility, desire, and work and family. And this is just a quick video showing you how this is the uterus, and see how it is. This is called chocolate cyst. The ovary is stuck to the back, and this is the kissing ovaries. There's ovary on the other side after separation. Left big endometrioma. This lady wants to fall pregnant. So this is, we're normalizing the anatomy to prepare her for IVF surgery. And I'll just show you that it's a thick endometrium like chocolate cyst that we call it. This is going quick. So this is the ovary stuck to the pelvic sidewall. It's very messy disease, and that's the rectum here. There's the ureter underneath. We put something called ICG in the ureter to identify the ureter. I've done this surgery with Dr. Colorectal surgeon, amazing one. His name is Walid Barto. Anyone heard of him? Any GPs know Walid? If you need a colorectal surgeon for endometriosis, it's Walid. Okay, hold on. But let's give him.
Thank you very much for this comprehensive reviews. I'm sure there were lots of very informative information in there. Now, our next speaker is Dr. Salwan Al-Salehi. He's going to give us a talk about pelvic floor dysfunction, urinary incontinence, and pelvic organ prolapse. Dr. Al-Salehi gained his primary degree in medicine and surgery from Baghdad University in 1992 and received extensive experience in medicine and surgery working in various parts of the world. After completing his general obstetrics and gynecology training in New Zealand and Australia, Dr. Al-Salehi received formal training in urogynecology and pelvic reconstruction surgery at the Royal Women's Hospital in Melbourne. Dr. Salehi occupies the position of the head of the unit of urogynecology department at the Royal Women's Hospital in Parkville since 2016. Dr. Salehi has a special interest in laparoscopic and minimal access surgery as well as robotic surgery in pelvic reconstructions and urogynecology. Please welcome Dr. Salehi.
شكرا بتول على الانترودكشن، وشكر خاص لأحمد للأورجنايزنج الميتينج. يزيدني شرف انه انطي التوك هنا. بس قبل للتعريف، لان هوايه ناس actually ما يدرون شنو يعني يوروغاينيكولوجيست، وهذا طبعا هذه مشكله عامه. اليوروغاينيكولوجيست هو سب سبيشالتي يجي ورا 6 years of doing gynecology، تسوي another 3 years لانه تحب انه تعدد نفسك اكثر. و it's specifically about the pelvic floor support and pelvic floor complaints. Please feel free to intervene and ask me questions halfway through. This is the learning objectives of the talk. Pelvic floor dysfunctions comes into the 4 functions. So overactive bladder, urinary stress incontinence or urinary incontinence, and pelvic organ prolapse and fecal incontinence. This is simplifying everything in between. To start with, the bladder overactivity or overactive bladder, or used to be called as urgency or urgent incontinence, it's a very common conditions, very common conditions. This is an international check on how often it happens for men and women, and can occupy up to 1 in 3 in women in different parts of the world, and internationally is about 1 in 3. In terms of how much risk factors can work around the suspected occurrence of bladder overactivity or epidemiological risk factors for them is falls into age. However, that age is actually slightly irrelevant nowadays, because you can actually pick it up as early as 18. In our case, pediatric urogynecologists or pediatric urologists actually can pick it earlier, and as late as actually as the 90s. The occurrence of pelvic organ prolapse, as well as the neurogenic diseases, comorbidity, BMIs, lifestyle choices, all actually contributing factors to not causations, but actually making things worse for those women. In terms of caffeinated beverages, alcohol intake, all add into the bladder overactivity issue. And one of the first recommendations is for them to moderate their level of intakes of caffeinated beverages as well as alcohol, because they all contribute to the bladder irritations and function. It's a bit of a important subjects and very delicate subjects to broach, because the ramifications is a bit extensive. It starts by women having to have poorer quality of life when it comes to incontinence and prolapse. That causes them to reduce their physical activity, that lead to to psychological outcomes, to be isolated, as well as as increased weight, which goes back to feed into the bad functions of the pelvic floor. So all in all, we need to break the cycle at some stage, and one of breaking the cycle elements is to ask the question, do you have a problem controlling bladder or bowel? Management classifies based on the American Urological Associations back in the earlier decade is first line therapy. We have to talk about the bladder diet, the bladder trainings, pelvic floor muscle trainings, using the easy steps to start with. This is and the second line of therapy, which is the medications for bladder overactivity, and only the last ones will be the surgical or PTNS or Botox or interstem pacemakers for the bladder. The reality checks regarding that is not so people have to suffer for extended period of time before we say to them, yes, you can have the final solutions. It's literally is built based on the health funds that has the health economy. No one would like to come and use while they had the symptoms and the debilitative symptoms for about 20 years, they don't want to spend another 6 months here or 6 months there in order to get to here. But the health systems and the health fundings is disabled by the amount of the number of patients can attend to that, and therefore this is created to accommodate for everyone. And unfortunately that goes without saying in Australia as well. To start with, preventions, there aren't a lot of preventions to work with it, other than education. Keep educating, pick up the early signs and symptoms, as well as address them, and let's not be scared to talk about bladder health anymore. Lifestyle changes, weight loss, it's intimately related to the bladder functions, and some studies suggesting reductions of bladder weight by 5 to 10% may reduce symptoms by 70%. It complicates everything else. It's not make or break, but it is regarded as actually as a grade A recommendations that actually please lose weight before actually we start on more extensive treatment, because it will help you on a longer term. It reduces the amount of interventions and reduce the amount of actually of potential use of pharmacological as well as surgical. Pelvic floor muscle training. Contentious issue. It's important to endorse. How much does it make a difference? It's like many things with needing to be enforced with the intentions. It's like when you ask patients actually to quit smoking without the intention to quit smoking. You can say quit smoking or use quit programs till 2030, but it's not going to happen unless they're motivated. Having to find patients that motivated to do pelvic floor exercise may benefit. It doesn't benefit. It doesn't actually change the outcome to a major extent, but actually it may improve the outcomes with available treatment. So it does have role there as for advanced cases, but at the same time it does have role for the grey area patients, which actually they don't have very severe symptoms. All what they need is re-educations and reinforcings of those pelvic floor muscles. The things actually is sometimes the flip side. Physiotherapists would say it's like working on your biceps. It's not like working your biceps at all, because the attachments of the muscles for the pelvic floor, it's nothing to do with the biceps. The biceps, by definition, is two heads. The pelvic floor is probably about 36 attachments in one location only. So therefore, it does not work in the same way. In order to not to make the patients feel very disabled by that notion, just say actually do as much as you can, and actually we'll pick up the rest. In pregnancy, there are some reports suggesting that actually endorsing pelvic floor muscle trainings in the first trimester up to the second and third trimester and the first 6 months after the delivery, it may improve their general outcome. Unfortunately, it doesn't prevent their general outcomes beyond the first 10 years. If that doesn't work, then we talk about medications. What do we want from the medications that works on the bladder overactivity? We want the perfect medications. Easy to take, less side effects, more compliance, and great efficacy. Unfortunately, that medication doesn't exist. The first line of medication is the anticholinergic medications. Some of them the oxybutynin, which is it is non-specific. It's a horrible medication because it dries everything, and because of the availability of the number of of receptors everywhere. The more recent, when I say recent, means in the last 15 years, is the darafenacin, sulfenacin, because it works ideally on only M3, but they don't. They work somewhere else as well, and that's why they do have the side effects. Not as bad as the oxybutynin, and it's better for specific options. I find them to be very useful for the very younger generations, that pre-childbirth era, that they regulate the bladder, re-endorse how the bladder works, and retrain the bladder medically, and usually in good circumstances and good kind of communications, they stop medication after 12 to 18 months. And then there was the Betmiga, which is it is a bit of a kind of a IKEA moment when they started to look into the beta agonist receptors to force the bladder to relax. It's been around in Australia for around about 10 years. In Japan and the US, it's probably about 15 to 20 years. Comes in different strength, 25 and 50. The TGA suggests that we have to always start at 25, but normally it does not work until 50. Major side effects is interactions with with blood pressure, and the labile blood pressure, not the mainstream chronic blood pressure. The ones that they have uncontrollable blood pressure may be you need to consult the physician if you want to put them on it. But you can give it for people who have closed angle glaucoma, because it doesn't work the same way as the other medication. And then the Botox, which is fantastic in every shape, form. The Botox only for the bladder. I don't do it for the face or anything else. But if I have a penny for every time a patient said, am I going to look younger? I said the bladder will, but not everything else. But the Botox really works very, very well. As you know, it's a botulinum toxin that actually a botulinum toxin that works on the receptors of the acetylcholines, and it blocks the receptors at the urotheliums, and it replaces the receptors. So new receptors has to be generated by the system in order to go back to how they were. Injections is actually using a special needle. This needle is terrible needle, but recently the good needle, which is the Alrubaie needle, which has the specific guide to how deep you go, because where you want actually between the urotheliums and the muscles, and you don't want to be inside the muscle because of actually extravasations into the blood system, and at the same time it doesn't work as well. So at the urotheliums the depth is 2 millimeters. And as a standardized, I only use 100 international unit. The urologist, we all know the urologists, they're heartless. Actually, they give 200, 300. I'm joking, of course. But in our titrations of dose, if you use 100 and repeat it every 12 to 24 months, you reduce side effects, you increase compliance, and provide efficacy. Evidence behind repeated doses of botulinum toxin is very encouraging, and you can use it 20, 30 times. Unfortunately, 2.5% of populations may develop antibody against it, so after they develop that antibody, it becomes less and less effective. Luckily, we have other options, including electric stimulation. So electric stimulations, there are the external electric stimulations or the internal electric stimulation, if you like. The external is called the PTNS, which is the percutaneous tibial nerve stimulations. That's done in the outpatient setting. So we put acupuncture needle and you attach it to a stimulator, and the stimulator is graded, and you do sessions, half an hour sessions for 12 sessions. It's heavily subsidized by by Medicare. Normal cost of those sessions used to cost about $210 to $280 sessions. Now it's subsidized to the extent of the out-of-pocket for the patients $30 only. However, they have to be committed to 12 sessions once a week, so that's 3 months. Unfortunately, 85% of patients don't show any response to it until the 11th or the 12th session. So they have to stay the long haul until they find out whether this is going to work or not. Once it's done, and it is effective, and there are some studies that suggest that it is effective, and certainly more effective than some of the tablets, and definitely more effective than only bladder trainings or pelvic floor muscle trainings. Then you put them on maintenance dose and maintenance treatments. The first one is for 2 months, and then after that once a month for 6 to 12 months. It's very acceptable by patients. They like it more because they don't have to be hooked to anything. It can have some possible side effects. One of the weird ones is they do have very rare occurrence of cellulitis from 1 injection of acupuncture, which I find very weird, given that people, acupuncture therapists, they use about 25 of them and they don't get cellulitis. How does that happen? I have no idea. Anyway, last but not least for bladder overactivity is the use of the sacral nerve modulation. It's been around for about more than 30 years. It's been TGA approved for bladder since 1996. It's been approved for fecal incontinence since 1992, I think. It's very interesting concept. What it does it has 2 stages. The first stage is you introduce the lead, which is a tined lead, into the spinal space, which is S3, S4. And that work on stimulations. You use 2 weeks for trial, and that's dictated by Medicare. You have to have a trial because that is very expensive. It's about $23,000 for the health funds. So they want to see at least 55 to 60% improvement before you go to stage 2. This is the latest. I just implanted the first one in Victoria about 4 weeks ago, and that's the rechargeable version of it. It's the size of a USB, literally the size of a USB. You put it under the skin. So this is, as you know, actually is the same ones for cardiac, and you can actually feel them or see them for people actually with cardiac. This one is rechargeable. I'm not sure if there is rechargeable for cardiac or not, but this is rechargeable. You put a belt on it for 30 minutes every 10 to 14 days and recharge it. And the total number of years you can actually continue using the same battery for is about 15 years. So much better than this, because actually this has to be replaced every 4 to 6 years, depending on the use, but this one is about between 10 to 15 years. Very intricate procedure, but it's a life-saving procedure for a lot of patients. And the youngest patient that I put it for is 26, and the oldest patient is 89. The 26, she had no life prior to this, and since then she had normal bladder functions and normal activity, and like nothing's happening. All of the leads, as well as actually as the IPG became MRI compatible since 2021-22, and July 21 is the I think July 21 or 2. Those 2 years would blur. So I think over the last 12 months at least, every one of them is actually compatible with MRI. So you can put them for people who need MRI on a regular basis. It wouldn't have any interference. There's some evidence. This will stay with you guys, so if you want to have an access to the presentation, I have no problem, for interest of time. I put painful bladder syndromes because there's a lot of ignoring factor when it comes to complaints to GP about painful bladder syndrome, especially in the younger patients who started to have recurrent urinary tract infections since became sexually active, and they go with years and years of antibiotic and casual antibiotic and recurring antibiotics without anyone asking, could that be interstitial cystitis? And the diagnosis is actually maintained by a cystoscopy and hydroextension, with or without a biopsy, and then the treatment, which I think changed the game dramatically, which is hyaluronic acid. Again, this is not for the skin, as L'Oreal advertises for the skin, but this is not for the skin, this is for the bladder. So that actually makes a huge difference to the interstitial cystitis, and I saw it firsthand how it does repair for the lining. The next step is actually the stress incontinence. Stress incontinence, they used to say if you have to choose to have incontinence, which no one does, but you should get stress incontinence. Why? Because it's very well manageable. Up until became very controversial of how you treat it, and then we enter the mesh issue, which I'll mention very briefly, just for the sake of boredom. So stress incontinence is the stable bladder and inability to control the leakage of urine, uncontrollable leak of urines on the start of increased intra-abdominal pressure. So that becomes very intricate when people actually look into urodynamics and they see the bladder pressure goes up. That means this is a stress incontinence. It's not. It should be a stable bladder with uncontrollable leak due to increased intra-abdominal pressure. It's by definition, it's a weakness of the neck of the bladder.
1 minute.
I'll exceed that by a couple of minutes. So this is not a solution. It's advertised and everywhere in the public. If you have little bladder leaks, use a pad. Using the pad is not a solution. It's, if anything, is the start of the problems. And then we'd say, so you would say surgery. So yes, the surgery is the solution. So the surgery is, there are 4 endorsed surgeries. The sling, which is like in certain media is like you're saying the devil's name or Voldemort, bulking agents, birch copper suspensions, and pubovaginal sling. So I'll just mention it very, very quickly, and please feel free to ask me after this if you want more explanations. So the birch copper suspensions used to be the gold standard in between 1965 all the way to 1999. It's by pulling the neck of the bladder at the level of the mid-urethras with using 2 permanent sutures. I stressed on the fact permanent sutures. Dissolvable sutures do not work. There is only one study, used 35 patients with dissolvable sutures, and they said it is the same, but it's not the same. and that lifted and sutured to the ligamentum of Cooper through the access into the space of radius. Does it work? It does work. Efficacy probably between 67 to 85%. Unfortunately, it doesn't work beyond the 10 years mark. It can have side effects. One of the main side effects is voiding dysfunctions up to 10% in the first 6 months, and as well as actually can cause posterior vaginal wall prolapse by definition, and it can cause bladder overactivity by up to 25%. Now, I won't bore you with that. Sling. It is the single most successful inventions when it comes to actually urinary incontinence in the history of urinary incontinence or surgery. Why? Because there are over about 4 million women around the world actually who have them, and even though that people actually said, oh, it causes erosion, it causes this, it causes pain, which it does. Those are all correct, but they are used by the wrong people for the wrong persons and did it very wrongly. How it works is actually it is substitute what it's called para-urethral ligaments. So whenever the bladder necks mobilize under the effects of the pressure, it's stopped it from leaking. Its efficacy is about 89 to 90% even after 25 years. The risk of exposure, or what they used to call it erosions, is about 1 to 5% depending on the patient. Diabetics, smokers will have more likely to happen. It works. It really, really works. The problem about it actually is it was underestimated by a lot of people, including the companies that sold them. It's a simple procedure. It's not a simple procedure. It's a very delicate procedure, and I used to kind of run cadaver workshop, and I used to say to specialists actually, if you get to the level that you think this is very simple and everyone can do it, you should stop doing them, because they're not. Anyway, other procedures, I think, and again, you can access those. Bulking agents. Bulking agents like a filler. People will say, actually, you use Botox for the bladder, you use hyaluronic acids for the bladder, and you use filler for the bladder. What have you left to the plastic surgeons? No one will see it, but this is a filler that bulk up the neck of the bladder in order actually to reduce the leakage. It used to be microplastic, which is this, doesn't exist anymore. This is a water-soluble polymer that it's very efficacious, cheaper than the macroplastics, works really well, especially for limited activity patients. Last but not least is fascial slings, which is when we take a sling-like object from the rectus sheath and put it as a sling. It's an extensive procedure, it's very successful. It's usually dedicated for someone who's tried everything under the sun, nothing's worked. Second, it's high morbidity because it can cause voiding dysfunctions by up to 25%. It's certainly used for people who had radiation therapy, people who had multiple surgery before, or injury to the urethra. This would be a very good procedure. I'll just mention prolapse very quickly. It's a very important subject actually to ask the patients, because in associations with urinary bladder functions, because it is intricate to that. And having to address the bladder symptoms without addressing an existence of a prolapse means you haven't done a thing. So that's why it's important actually to look for it, examine, and as well as actually be mindful that the patients actually do have it. It's present in 98% of women with vaginal birth. It can still exist with people who have cesarean section, as we know from one of the prolonged studies that cesarean section only protects you for 15 years, not more than that. You can use pessaries for different reasons, and you can use surgeries. Surgeries are simple vaginal wall support, apical support, or the mesh surgery again. The uterine conservation surgery is something that's very close to my heart, because I really believe in it, and it actually addresses the prolapse dramatically. And it is very, very successful. We have 78 patients in a study that we followed for 7 years, and they had 93% success rates after 7 years. It's outside the scope of this talk to talk why, if you lift the uterus, everything else will fit in place, because 60% of the vaginal wall prolapse attributed by the uterus. So people who address the vaginal walls without addressing the uterus, they're missing out on 60% of the prolapse. Sorry, I'll finish. Yeah. Heterosacral ligament suspension is a new surgery that I'm doing in at the Women's, and I have two of my fellows actually doing PhD on it. It's a new harvesting of the heterosacral ligament internally and repositioning it in a different place. So far the result is very good, but we're presenting it in Aokaby in the Netherlands next month. Those are gadgets only for people who are interested in it. Different types of gadgets available. Old procedures do exist as well, which is like alpacliosis. I talked about the mesh, so this is for your own reference. The only thing I want to say, there's a lot of talk about Asia syndromes or autoimmune disease to do with mesh. That's never been proven related with polypropylene mesh and continue not to be proven. And my fellow and I, back in 2019, we did a systematic review looking into every single mesh procedures done since the existence of mesh. The Asia syndromes or the autoimmune is dedicated for the silicone used in the breast implants, not for the mesh, but people in the public and in the media try to actually put it exactly as the mesh. Still has not been proved, and we reviewed over 6,000 studies, and not one of them has actually have used the reference to it. And having colonoscopy versus having a polypropylene mesh has no difference in terms of your immune system. Sorry, there's a lot of things to talk for 20 minutes. Apologies. There are some cases for your interest afterwards if you want to have a look, and if you have any questions, please let me know.
So thank you very much, Dr. Salwan, for this very lovely talk. I'm sure you would have loved to listen to most of it. Can I ask our speakers, please, to come here? If you can sit there, please. And the floor is open for questions. We have 15 minutes if anybody would love to ask any question.
Still, questions to media about the HRT with the breast. So the progesterone you're using to protect the breast or
just to ask to protect the uterus from proliferation and hyperplasia and cancer. So if the woman has a uterus and you put her on hormone replacement therapy, she should be on both estrogen and progesterone. The estrogen is to control her symptoms, and the progesterone mainly is to prevent endometrial proliferation.
So that is a must to be used in women who have a uterus.
So my question that the HRT,
other one for
the person they don't recommend it at all because of the hearts or whatever stimulating first. I just would like to know how safe have you said 1 in 2,000 cases? Any more or less to give us more assurance that we'll try the HRT, we're not going to do one case if it's cancer. It will be devastating to.
So in women with breast cancer, and if their breast cancer is ER positive, so they have receptors of estrogen and progesterone in their breast cancer diagnosis, those ones I won't put them on hormone replacement therapy unless I consult the breast surgeon. Because if they do have receptor positive, then they should not be on any hormone replacement therapy. That is a very different identity. We're talking about women with no history of breast cancer and they require hormone replacement therapy.
Even if it's a family?
Even if there's a family history, as long as there's no personal history of breast cancer, then their risk will increase by 1 in 1,000 if they use it for more than 5 years. But if there's personal history of breast cancer, I won't put them on hormone replacement therapy without consulting with their breast surgeon.
Can I please ask to present yourself before the question, please?
My name is Dr. Rafeq. I'm a GP from Abingdon, Melbourne. A question about fibroids. Do we need any follow-up for fibroids? And another question to Dr. Media too. You said menopause is 12 months of no periods. As far as I know, it's 2 years if you're under 50 years of age and 1 year if you are over 50 years of age. Is that right?
By definition, as far as I am aware now, known. It's 12 months from cessation of the last period.
Thank you.
What did you ask, sorry, about the fibroids?
Fibroids, do we need any follow-up? Do they ever change to malignance? Do we have to do some follow-up?
So they don't, benign fibroids, they don't change to malignant, but sarcomas can look like a fibroid. Therefore, if you find someone with unusual presentation with suddenly growing mass or a new finding of a sort of enlarging uterus, heavy bleeding, it's recommended that you actually follow it up to confirm that the mass is not rapidly growing or not changing in appearance to make sure that there is no underlying cancer.
So how long before?
I would recommend like anything between 6 to 8 weeks follow-up or about 2 to 3 months, like after the first ultrasound.
Thank you.
Sorry, just to read about one of bariatric was also breast surgeons. Going to media, I've been asked a lot. I like HRT because the woman will go on yearly ultrasound and mammogram, so that will increase the pre-detections. So it's only when you treat this diseased breast, then we have to discuss it further about HRT. But it's very safe. Don't be afraid using it, provided you're going to counsel your patient that they're going to have yearly mammogram and ultrasound. So family history is not very important. Thank you.
أحمد الرباعي. سؤالي للدكتور سلوان. طبعا ممتنين احنا لكل البرزنترز والبرزنتيشن كانت رائعه. دكتور سلوان احنا عندنا بالجاسترونترولوجي cases of chronic or idiopathic constipation, where when we do the nuclear study, the cause is not in the colonic dysmotility or inertia. The cause is what we call it obstructive defecation, which is pelvic floor dysfunction or sphincter dysfunction. Now, for those, we recommend pelvic floor exercise and biofeedback. But our at least would data indicate this is not very effective. How effective these techniques in cases of urodynamic failure?
Very good question. The specific obstructive defecations in relation to, like, it's a very kind of extensive subject. One of them actually is, for example, I saw patients who's never had been pregnant before and never had vaginal birth, and they have a posterior vaginal wall prolapse. Displayed by obstructive defecation. So it started as a constipation, they developed syndromes, and made it to chronic constipations, and then they developed like they have lacking of supportive tissue and the back wall of the vagina. Obstructive defecations, when it is very well diagnosed by MRI proctograms or with the existence of a rectocele, which is the posterior vaginal wall prolapse, and get corrected, they have fantastic results surgically. Especially when it's combined with physical examinations and suggested that this is a rectocele. When there is no rectocele and they have obstructive defecations, it becomes a bit of a tug war between the gastroenterologist and the urogynecologist, because we say it's not our problems and they say it's not our problem. But in the existence of a rectocele, as well as a proof of having obstructive defecations in the last 7 to 10 centimeters of the gastrointestinal tract, the effect of the surgery to correct the prolapse is very, very effective. I didn't find the pelvic floor exercise very effective.
So just going back to the fibroids, is there any value in doing LDH? Like I see some specialists, like when they detect fibroids, they do lactate dehydrogenase. Any value in doing that?
No. I would not recommend doing any tumor markers if you are not concerned about cancer, because they can get they're elevated in many other conditions, and it creates a lot of confusion. If you are concerned, refer them to the gynecologist, they will work them up, and they will decide which tumor markers to organize.
And you said you leave about 6 to 8 weeks interval between the first scan and the second scan.
If a patient presenting with menorrhagia, you send them for a scan, they have a new findings, I will repeat the scan to confirm that these are not progressive findings.
And if after 6 weeks,
I will leave a little bit, it depends what the symptoms are. I will leave like sort of more towards 8 to 12 weeks for fibroids and assess again.
And if that scan comes not showing any changes, that's it.
Then
There's
that's
no
it.
need for
Yeah, but you will need to address their symptoms and find exactly what's going on. So if it's heavy bleeding, address that. If it's pressure symptoms, address that. If they have a big uterus that's causing pressure on the bladder, causing problem with the bowel, I will address all of that. Pain.
Sure, thank you.
Mohammed Jaiba, upper GI surgeon, Wollongong. Thank you for the panel, very nice and informative session. 2 questions, one to Juman. In terms of management of the fibroid, is there any update or role related to CT-guided embolization of the main or part of the branch of the uterine artery? And the second question to the panel, we do receive lots of referrals about liver adenomas, which is ideally in young ladies being on OCPs for more than 10 years, and whether we resect or not, they have to stop any estrogen-containing modality. If they're still interested in more contraception and not willing to go into the male ways of contraception, is there any way to advise them about that? Thanks.
So for CT, it's sort of embolization of the vessels for the fibroids. It's a very well-known procedure. And the downside of it is that it should be done for women who do not seek fertility anymore. So a lot of the fibroid presentations are for women who are still willing to have their fertility option preserved, and it's not recommended in that setting. If a woman chose to proceed with like sort of embolization of the vessels, that's a very reasonable option. They just need to aware that there is a risk of failure and they might need a hysterectomy eventually. It shrinks the fibroid, so it's very suitable for women who are perimenopausal. I can answer you about the question about the pill. You can use alternatives like the IUD Mirena progesterone, which doesn't have estrogen. Am I right?
I was going to add also other progesterone-only contraception, like Depo-Provera injections 3 monthly, or the pills, progesterone-only pills, either Macquarie or Convenor. So there are multiple options for progesterone-only. Copper IUD, they don't want any hormone at all, so there is no medication.
My question to Dr. Ahmad. Very nice presentation. I would like to have your opinion about the use of Visan in endometriosis, the medication.
Yes, I frequently use it, as I said, after excision of endometriosis. I put the Mirena in as a first because it works locally, progesterone, and it's very effective. After 3 to 6 months, they still symptomatic. Symptoms are still bothersome, so I will add Visan. I ask them to come back in 3 to 6 months, and if its symptoms are controlled, then I'll continue on the Visan and Mirena in situ, like 2 agents. And I'll continue like that for a long time. 2 milligrams. Yeah, 2 milligrams. And the Zoladex as a last resort. Yeah.
Thank you very much for all of
Can we aim at having 10 minutes?
Okay, thank you very much everybody for coming back in on time. So our second session is going to be about orthopedic disorders, and this one will be moderated by Professor Mudarris. Yes, Mudarris, sorry. He is very well-known figure for everybody here, I think. He's a professor of Macquarie University of Orthopedics, also a professor of Notre Dame University. He is an honorary professor at Sydney University School of Engineering. He's also the head of orthopedics and sports sciences at Macquarie University. And of course, we all know about his great leading pioneering of orthopedic surgery, especially in the knee restructure and the hip restructure. Please welcome him with me.
Thank you very much, Bassam. Sorry, I'm just recovering from a virus, so my voice is not going to be the best. Okay, so I'll talk briefly about the advancement in management of knee disorders. I do have financial disclosures, and these are my financial disclosures because I participate in design and manufacturing of several medical products. So I just want to announce that we are very proud to have a short stay program up here at Macquarie University, which is an initiative that is very unique, and it's kind of transforming medicine in Australia the way we knew it, and hopefully this model of care will open a window for many other centres to follow through, because that's the future, where healthcare is becoming more partnership between health groups and medical professionals to improve the quality of care for their patients and facilitate their recovery. So Macquarie is in the leading forefront of this advancement. So I'll start very much into the analysis of knee disorders. So you start with an X-ray, and a lot of the time I get patients coming to see me with this view, or now more often I get a patient coming to see me with knee disorder with an MRI, not even an X-ray. But we often miss what's going on with the rest of the patient, and this is a classic patient that presented to me with this deformity, and he had knee pain. He's coming for me asking for a knee replacement, and the treatment path for him was completely different because he didn't need a knee replacement. He had leg limb discrepancy, he had rotational malalignment, and he had significant deformity at the proximal end. So I ended up doing corrective osteotomy for him rather than doing a knee replacement, restoring his alignment. He never needed a knee replacement. He may in the future progress to having knee replacement, but not necessarily anytime soon. He's very active. Though he's in his 70s, when he goes to the gym, he runs, and he's moved on with his life. So a lot of the time we have focused on the area of interest where the pain is, while ignoring the patient as a whole. So the way we analyze and we look at a patient is as a whole. So we kind of run more comprehensive assessment for a patient, especially with lower limb, and it is vital to assess the patient from many aspects, because and mainly in a three-dimensional configuration and aspects, because that will give us more accurate assessment of the deformity, the structure of the limb and the joints in the lower limb, and give us an idea, a better idea how to manage their deformity. And a lot of the time, patients come to us with this kind of look on their leg. They're either straight, or they are knock-kneed, or they are bow-legged, and very commonly they all have pain in the knee, but their pathology is completely different. And when you look at the valgus, varus, malalignment, no one is the same. We all grow differently, and we all grow to some degree of deformity. No one has equal level, no one has the same rotation. As we grow in utero, our limbs forms, and as a result of that, that will give us the shape that we grow into, and that can be affected by the injuries that we sustain throughout the growth period. So people, we are all at risk of arthritis, and arthritis affects us above the age of 40. It's more commonly in women, more commonly with obesity and previous trauma, and certain ethnic backgrounds have higher risk of developing arthritis. Arabic population have very high risk of developing knee arthritis, less so hip arthritis. When you look at the African population, they get more arthritis in the hip. Japanese population, they get less arthritis than the rest of the world. while Chinese patients, they have more knee arthritis, which is very interesting. Anglo-Saxons, they get at both ends, unfortunately. Hip and knee arthritis is very prevalent in this population. And as you can see, we are living a lot longer. Throughout, there has been 2 jumps in the human population growth, and that is in 1850 with the Industrial Revolution, and then with the invention of or the discovery of penicillin in the 1950, there is another jump, and now it's expected that we will live to 100 years very soon. And that's because we're eating healthy, we're breathing healthy, and we are treating our heart conditions and diabetes much more effectively. So the factors that affect the outcome of a total knee replacement depends on 3 elements. It depends on the patient, and the patient is kind of a constant factor. Because it does, you get what you get, and you get the sick patient and you get the healthy patient, and they act differently. So it's not every knee get the same results. But the variable factors are the surgeon and the technology that you use, and that's where we can improve. The surgeon can improve with their techniques. The technology always gets better with time. When you get a patient, as a common presentation, they are a 40-year-old male coming to us with a medial meniscal injury. That's a very classic referral that I get into my practice, and a lot of the time they get surprised with the answers that we give them, because they're coming in expecting to have a knee arthroscopy or keyhole surgery to shave the meniscus off. Or they get a 25-year-old female with pain in the front of the knee. Or you have a much younger person coming with a meniscal injury or a dislocated patella, or you have an older, more senior female coming with both knee pain, or you have an older male coming with or brought by his wife or his children, forcing him to come with because he seems to have becoming less and less functioning lately, and he doesn't want to get out of the house. And this is the common presentation. Patients have severe arthritic changes in the knee, and usually the answer is a knee replacement. Knee replacement is the 25th most successful procedure ever invented in the history. Hip replacement is the 2nd most successful procedure after cataract surgery. So they are very good procedures, but are they good for everybody? Definitely not. And when you look at the trend, you look at total knee replacement, majority of patients who have arthritis get a knee replacement as a total knee replacement. Some patients get partial knee replacement or half knee replacement, and revision surgery is being very stable throughout the years from the National Joint Registry. And when you look at the growth of the National Joint Registry, you can see during COVID there has been a slight drop, and this is from the Australian Joint Registry. You can see the trend is going up and up. So we're getting a lot more joint replacements every year in New South Wales. And when you look at the graph, you can see that this line over here, which is the green line showing robotic surgery, is picking up dramatically. And people are using one or more sources of technology, and there are many factors that drive surgeons to do that. The main legitimate factor is because they believe in this technology and they find it more useful for their patient, but there are other factors that drive people to use technology, such as marketing, which are not necessarily, has an effect on the patient. But what's reflected clearly in the Joint Registry, which is a blunt tool because it's it takes a cross-section from every single joint replacement done in Australia, and you can see that the trend is clear that robotically assisted knee replacement is doing better, especially for the younger population, which is the harder group. And when you look at this, this figure shows it very clearly. You have the blue and the green lines are both related to the age group, and they are performing better than the non-robotically assisted technology. So what is a robot? A robot is a tool that we use. It has an arm, and that arm comes and helps you to have your cutting guides in more precisely positioned on the limb. It is like any kind of gadget as used with. It's not like robotic surgery using gynecology or in urology, where the surgeon operating the robot from a distance without them being involved in the surgery. This is not the case with robotic surgery in orthopedics. The robotic surgery in orthopedics, the robot do the positioning for you, but you have to be doing the procedure. And certain robotic assisted surgery can do some of the cutting for you, but you need to be involved in the case. So we're not as advanced as doing robotic surgery where you can operate from home or from a different city while the patient in somewhere else. Having said that, it does involve a lot of preoperative planning and data entry into the robot, what can be analyzed, and that adds a lot of level of accuracy, because after all, it's more carpentry. It's all about cutting a shape in space to high accuracy levels, basically. So basically, you get landmarks from the limb, as you can see over here, and then you analyze these landmarks, and then it all comes on the screen in front of us, and we check the position of the object, and then the robot put the knee replacement for you on the computer, and then you assess where you want it to sit, and the goal is to get the joint line at the same level that it was, or where you predict, and you get ligament balance, you get patella tracking properly, and you get the mechanical axis accurately positioned. And all these numbers get spat at you from the computer, and you have to analyze it very quickly as you're operating. And with time, you learn how to do it very like a second nature, and it becomes more easy to do, and it's not that hard. One main advantage of doing this is that you can minimize your instrumentation, because this is the only instruments that I use for a knee replacement, as opposed if I use a different kind of technology, like old instrumentation technology, you'll have 3 or 4 more trays, and that reduces the cost, reduce the time, increase efficiency, and reduce the risk of contamination. So there are advantages of doing this, where it does help us in improving the outcomes. And then you have additive kind of information that you can help on the long run, where you can monitor the patient after all. So we're all spying on our patients now, where we hook them up with gadgets that will monitor their activity level. And you can see this is applied in many aspects of medicine, including cardiology, where people who have pacemakers or defibrillators, the cardiologists from home know that their patients, if they are having any problems. Now, but is it the only solution? No, it's not, because a lot of pathologies come in to us where they don't need a knee replacement, and I'll show you the vast majority of our patients that come in can be prevented from having a knee replacement. And this is very important because as GPs, for example, as the first line of responding to injuries, when patients walk in, they get to deal with patients coming in with anterior knee pain. It's very common, or patella dislocation, or a medial meniscal tear. All these pathologies, if they are overlooked, they end up with a problem that could have been avoided, which is arthritis. So if you look at the gait of the patient and they walk funny, like how many of you have children that have pigeon toes? And this is a major problem, because that indicates that these young kids have rotational malalignment, and they need to be corrected. That doesn't mean that we need to correct every single rotational malalignment, but if they become symptomatic, they need to be corrected. Because the mechanics of the knee joint is very, very critical to be very accurate. You need the alignment properly working. At the same time, you need the patella that goes in the rail of the trochlea up and down accurately and not derail, because that will lead to abnormal forces going on the patellofemoral joint and end up with basically wear in the patella and then friction and later on arthritis. And you can see there's a classic example where you see patients have ligamentous laxity, hyperextension, valgus malalignment, the patella is tracking abnormally, and in the past this used to be treated with physiotherapy and end up with arthritis. Well, now you need early intervention. You can realign these patients, do a corrective osteotomy for this patient, relieve their pain, and improve their patella tracking, and maybe prevent them from having a knee replacement in the future. And the patella is the evil here. It's always, especially in females, patellofemoral disorder is very common, and if you can rectify that early in the days, you can prevent a problem. And it can go from the hip, where their femoral inversion is high, or the femoral torsion is high, or you have a lateral hypoplasia of the femoral condyle, you have valgus malalignment in the knee, you have external tibial torsion, or tibia that is valgus, or metatarsus adductus. And all of these can play a role in changing the forces in the knee and resulting in arthritis. So arthritis doesn't happen just because of an aging process. A knee should, cartilage should wear evenly, otherwise. If it is tracking well. And you can see here, look at the whole patient, okay, and look at if there is a significant injury, that's a different question, that's a different matter. But if it's repetitive, frequent minor injuries that lead to pain, that means there is something wrong with the biomechanics of this limb. And as a result of that, that can be corrected and prevented. So it is uncommon to see post-traumatic injury and instability in the knee because injuries heal. But it is very common that people have minor traumas that result to instability. And you can see this is a classic example of this patient with a malalignment in the leg. And as a result of that, any kind of simple rotational force can lead to this patient having significant patellofemoral maltracking, and as a result of that, repetitive ligamentous injury and ending up with severe abnormality. You can see these are kind of different presentation of patients. That's a severely pigeon-toed patient that will end up with serious problems in the future if it's not corrected. While on the other hand, and you can see in the kid, his patella is pointing inward, his foot is pointing inward, while his leg is straight. While this lady, the foot and the patella is pointing forward, but her leg is both significant, not significantly. And this is a classic example of how the patella can J-track. So by simple observation to these patient pathology and alignment, you can diagnose them very easily and make an assessment without needing of running through extensive investigation, MRI scans, etc. And the solution can be simple. Always examine the patient, look at them, okay, see how much they rotate with their leg, because it's very important to look at the abnormality, and it's very clear to assess it and identify it and treat it basically. So this is all what I mean, we do a lot of 3D modeling and 3D scanning with the technology that we have available to us now, because all these images, the engineers with a special format of materialized can 3D reconstruct the limb and put it to us. And there is a lot of work that we do in conjunction with engineerings and now, where we can look at the structure very carefully and assess it very accurately, and and able to correct the malalignment. And there are things that you can do in childhood where you use certain measures like these growth control plates, where you allow the one part of the body to grow while the other part is holding off, and that can correct the alignment with time and prevent future problem.
2 minutes.
Yep. Well, pretty much done. And you can see this is a classic example of how 3D modeling is done, and can be presented to the patient very clearly. And it's very good when the patient understands their pathology, so they can be part of the treatment and part of the solution for their problems. Thank you very much.
So our next speaker is the Associate Professor Yasser Al-Khatib. He's an orthopedic surgeon with a particular clinical interest in hip replacement and revision surgery, knee replacement and revision surgery, and the management and the treatment of trauma and sports injuries of the hip and knee. He has obtained his medical degree from the University of New South Wales in 2003 after successfully completing his training. Dr. Khatib was awarded fellowship of the Royal Australasian College of Surgeons 2011, and then he went to travel to Toronto, Canada for a fellowship in hip and knee surgery. Can I jump over it? And then he's now a senior clinical lecturer at the University of Sydney School of Medicine, Nepean, and is actively involved with undergraduates and postgraduate students.
Thank you for that warm introduction. I'm going to actually something, but thank you, appreciate it. Okay, so good morning, thank you for being here, and thank you for the invitation to speak to you about management of conditions around the hip. And the aim here is to have it at a very broad level. Essentially, as a general practitioner, what can you do to have an idea about what's happening around patients who present with hip or buttock pain? Okay, so the hip tends to lend itself to this kind of approach, because if we consider a few factors, we can narrow down the diagnosis of the conditions that we're dealing with. Hip conditions tend to categorize themselves very nicely based on age and location of pain. And if you take into account a few other symptoms, then we're pretty much home. It can be daunting to think about all the potential differential diagnosis that can come around the area, but essentially if we think about common pathologies that happen in certain ages, we can narrow down what's happening, and then we can also consider pathology particular to the hip itself or pathology around it. So for example, in infancy we worry about issues with dysplastic hips leading to dislocation. In childhood it's more a vascular necrosis of the hip, which is known as Perthes disease, and then in adolescence we start to come into patients who are more active, so we worry about issues with slippage of the femoral epiphysis. In early adulthood we tend to encounter issues with arthritis, labral tears, and what's known as femoral acetabular impingement. And of course, as we progress through middle age, we start to get more conditions related to tendinitis. And of course, in older age, we start to see arthritis more commonly. So if we look at the child, and that's the first thing that we'll talk about here, and is mainly related to developmental dysplasia, which is still something that is picked up in general practice, especially with infant screening tests like the Ortolani and Barlow test, where essentially you're assessing a child for a clicky hip or a clunky hip. And of course, it tends to be more common in firstborn children, in females, especially if they have a family history of the same occurring in previous siblings, or if there was a breech presentation. And it's important to pick this up because early detection can lead to rapid treatment, and of course, missing a condition like this can lead to lifelong consequences. In terms of the investigations, it really depends on what stage of development we've picked this pathology in. So early on, the hip joint itself is mostly cartilaginous, so it's not really a lot of point doing x-rays. We tend to diagnose using ultrasounds. They have a look at the coverage of the hip. And then as the child becomes older, there is more ossification of the hip center, and you can see here, for example, there is a difference between one side to another. We can see that the hip kind of looks like it's in the vicinity of the sternum, whereas this hip is obviously more outside. And there are a bunch of little radiological markers that we can look to see if a hip is inlocated or not, but essentially that's what we're looking at. And does the hip joint look like it's in place? And of course there are other tests that are more, I guess, invasive, especially in a child, like an MRI scan or an arthrogram. They're mostly used by surgeons because they do require a general anesthetic in that age group. So if we're looking now at an infant, let's say between the ages of 2 and 10, who presents with hip pain, and the vascularity can be compromised around that area, leading to what we call Perthes disease, which is essentially interruption in blood supply to the femoral head, and that of course leads to fragmentation and remodeling around the hip joint itself, but unfortunately it doesn't remodel in a normal position, so that leads to hip pain, thigh pain, stiffness, and eventually shortening as the head starts to collapse. As the child grows into adolescence, we start to worry, and they become more active, we start to worry about things like split capital epiphysis of the femur, where essentially the top of the femoral head, which is a point of weakness because it's still, there is a developing growth plate over here, which is cartilaginous and soft, tends to fall off the hip, essentially like an ice cream falling off the cone. And it tends to displace posteriorly and inferiorly, and of course that's associated with pain, a limp, and can affect the patient later on, and we'll come to see that in a bit. In adults, it's a little bit more useful to ask about where the location of the pain is, and there are 3 typical locations: anterior pain, lateral pain, and buttock pain. Typically, the anterior pain tends to be more intra-articular pathology related, and there's this classical sign that a patient comes to tell you when you ask them where is the pain. They'll put their hand around their hip like that, and you know that's more related to hip pain, and we tend to call that sometimes a positive C sign. They're telling you exactly where the pathology is, and they've done half the job for you. And sometimes the pain can be radiating down to the thigh, and we start to worry about issues related to the hip itself. So we went through some of the childhood conditions. Of course, if the hip recovers from a childhood condition, it may not heal in exactly the same position, and you may develop little abnormalities around the hip, such as development of a little bump around where the head joins the neck, or abnormalities in the development of the acetabulum, which is the cup part of the ball and socket joint, and that can lead to abnormal contact forces between this part of the bone and this part of the bone. You can imagine that flexion and abduction or adduction can tend to cause impingement in that area. Now, of course, between those 2 bony surfaces and around the hip, there is this structure called the labrum. The labrum essentially seals off the hip joint and becomes a bit of a seal of the joint and a little bit of a cushion. So, of course, if that's caught in between 2 abnormal surfaces, you're more likely to get a tear. And labral tears are common, especially in middle-aged young adults and middle-aged adults, especially in females, especially with new onset exercises or repetitive activities. Patients tend to describe a popping or a clicking noise, a catching pain, and pain getting out of a chair, so extending up from a flexed position. Labral tears are commonly around the anterior and superior part of the labrum. A lot of them are incidental and sometimes aggravated. So if you just have an MRI scan of somebody who has a vague history and you get a labral tear, it's not necessarily the labral tear that's causing it, but there may be some aggravation, because you'll start to see this more commonly as people are accessing MRI scan for initial investigations. It's common in certain sports, and the mainstay of diagnosis here really is with an MRI scan. And as MRI scans have become more of higher quality in terms of imaging, MR arthrograms, where dye is injected into the joint, are becoming less common. So you can see, for example, in a hip like this, it's not completely spherical anymore. There is a bit of a bump around this area, and you can see how this and this can impinge together, leading to damage of the cartilage or the labrum in between. Of course, another common reason for sudden pain, and this is a more acute, more sudden, more painful condition, is avascular necrosis. And just like Perthes disease is interruption of the blood supply in the femoral head in the child, avascular necrosis is its equivalent in an adult. But the big difference is a child has a lot of healing potential, growing and remodeling, whereas an adult is pretty much done for growing and remodeling. So all you get now is death of the bone that supports the cartilage, which then leads to collapse of that bone, which then leads to a dysfunctional joint with collapse of the cartilage. It is a common condition. It accounts for about 3 to 5% of hip replacements in Australia, and it's common with increased alcohol use, steroids, so steroid prednisone medication in long term, high cholesterol, and then other conditions like radiation or chemotherapy. And patients will come in and they'll tell you exactly on what day their pain started, so it's very sudden, they know about it and it's very sore. And it's the usual kind of algorithm for investigations. Initially we start with a good set of x-rays, followed by an MRI scan. X-rays can show you a lot of features, but you'd have to examine them carefully. So for example, you see a little crescent sign where you get a little bit of a white line that develops underneath the cartilage, and that usually is a sign of bone collapsing around that area and remodeling, so you get nice new sclerotic bone, except it doesn't give you the adequate support for the cartilage anymore, so the cartilage over it becomes essentially like a gyprock wall on a wall that's full of termites. It doesn't really work very well. And of course, if you did MRI, you'll see where the area of bone necrosis is, and that's the zone of collapse. So unfortunately, that's not really reversible, except if you had a small area of involvement. So in that case, you can try to stimulate healing by doing what we call a core decompression. And maybe you'll appreciate a few drill holes through this area. And this is where we've tried to drill the hole, essentially to stimulate some bleeding into it, decrease the pressure inside the bone, and allow it to regenerate some new bone. But you can only do that in small areas. You can only do it when there isn't collapse. So for example, we see over here, we don't really have a big crescent sign. We don't have that white line that was visible in the last x-ray. And of course, if it's beyond that, then we're looking at arthroplasty, and arthroplasty is hip replacement generally. And as Munjid said, it's a very successful operation. It's the second most successful operation after cataract in terms of restoration of function to patient last century. So it was named as the operation of the century. And hip replacements tend to do really well, even with the older models of hip replacements, and technology has changed a lot. But even with the older models, about 90% of them tended to survive over 17 years. So they do reasonably well, especially in particular pathology. So you can see that not all hip replacements tend to survive the same. Osteoarthritis tends to happen in older adults, less, I guess, functional demand, so the chance of revision is lower. And whereas we look at something, for example, like avascular necrosis or osteonecrosis, and it's slightly higher. So it does depend on pathology. And of course, more recently, there have been a lot of new surgical approaches that essentially have aimed at decreasing the acute recovery phase, so less pain acutely, early discharge, early mobilization, early rehabilitation, as Munjid has shown, very similar to what's happening with the knee. And you can see that recovery is shorter and quicker, especially in the first 6 weeks. The overall survival doesn't tend to change much, but the earlier recovery is a lot better. So we don't have patients walking on frames anymore. They tend to be fairly independent by 6 weeks, able to do most things, walking around with little limp. So that has advanced significantly, and pain itself reported after surgery has definitely changed. Okay, so that was a general view of anterior hip pain. And the next common thing is lateral hip pain, and this is more of a middle-aged female kind of presentation, because there's increased incidence of what we call trochanteric bursitis. So bursitis is just a fluid-filled soft tissue structure that tends to line joints and muscles and allows them to function with minimal friction on the overlying skin and soft tissue. And you can see with a lot of repetitive activity, so up and down stairs, or exercise, or general activities of daily living, you can get irritation in that area. You get tendinitis of the two main muscles that support your hip, which isn't actually the gluteus maximus, that's more just for show. It's the muscles underneath it, the gluteus medius and minimus, that stabilize the pelvis with every step you take. And so if there is tendinitis or a tendon tear, then you are likely to experience limping, pain, and then inflammation around the area, which can commonly get diagnosed or misdiagnosed as isolated trochanteric bursitis. Usually bursitis is a sign of what's happening underneath rather than the problem itself. Of course, there are many other structures around the hip, and one must not forget to exclude nerve compression as a source of pain, especially with the lateral femoral cutaneous nerve that comes straight out of this area and can cause pain and numbness around the lateral aspect of the hip. And diagnosis sometimes is complex, but other times it can be as simple as performing a Tinel's test, which is percussion along the course of the nerve, and if that reproduces the symptoms, then you've pretty much made it. Common signs that I'm sure most general practitioners would know: Trendelenburg sign, where if you have failure of the abductor mechanism to support the pelvis is no longer level, so it tilts. And of course, if you're tilting your pelvis with every step you take, then you have limping, you have pain, it puts pressure on your back and can exacerbate your symptoms. And then the other examination tests over here are more isolating where which part of which muscle is involved, because there are a few muscles around the same region, and physios tend to be really good at doing that because they have a keen interest in their anatomy. And management, again, is to exclude arthritis, exclude the dangerous stuff. So it tends to be arthritis, fractures, metastases, cancers, that sort of stuff. Ultrasounds are commonly used in general practice, and you pretty much universally get one diagnosis, which is trochanteric bursitis. It seems that everybody has it, but really the benefit is limited. MRI tends to be the mainstay of diagnosis here because it tells you if there is tendinopathy, if there is a tear of the tendon, if it's come off the bone. Commonly, this is treated with corticosteroid injections. However, when you examine the evidence, it actually is very sketchy around corticosteroid injections into the area. And to be honest, if you compare them to physiotherapy alone, they are probably equivalent in the longer term, so 3 to 6 months onwards. There is treatment that's called shockwave therapy. To be honest, I don't think that's commonly used over here. Some physiotherapists tend to use it, but essentially what you need is to strengthen the muscle, treat it as if it's tendinitis. Core strengthening exercises tend to work, but you need to modify the activities to avoid the activities that are causing soreness. Surgical repair is sometimes possible, especially if a tendon is completely torn and displaced from the bone. And physiotherapists will commonly tell you about posterior buttock syndrome or posterior or deep buttock pain, and will diagnose issues like piriformis. Piriformis is a muscle that is intimately related to the sciatic nerve. The sciatic nerve can pass through it or can pass around it. So you can imagine that if you have tendinitis or traction of this muscle, which is an external rotator of the hip, then you can get irritation of the sciatic nerve. And that can commonly be confused with sciatica, can be commonly be confused with lumbar and spine pathology, and I'm sure Dr. Ali will talk to us about that later on. Ischiofemoral impingement is also one of those syndromes that you'll hear about from physiotherapists. But most of the treatment for these conditions really is with physiotherapy and activity modification. I've tried to stay to time. Thank you very much.
Thanks, Dr. Katim. Now we're going to have Dr. Ali Ahmad. Of course, I like that.
Yeah. So, look, my name is Ali Ahmad. I'm a spine surgeon. Currently I work at the Alfred Hospital. I do trauma orthopedic surgery at the same time. I do spine and also work at the Austin Hospital where I do mainly spine. And my private practice is called Momentum Spine, which I see my private patient. So I finished my orthopedic training program in Baghdad Medical City in Iraq, and then I come to the Australia here to do a spine fellowship at Royal Adelaide Hospital. This is in 2007, and then after that I did the orthopedic training program in Victoria. Then I did the spine fellowship at the Austin. Then I went overseas to do a spine fellowship at Washington University in St. Louis, Missouri, and then came back. So I just wanted my talk today is about aging spine, and at the end also I will talk about what the new happening in the spine for a period of time. So what is the aging spine? The spine is the optimal functional age for the spine is between the age of 15 to 25. After 25, everything go aging. Regardless, every one of us have aging spine. The spine is just aging due to the load. So what happened when we 30s, we start having a problem like this bulges and this touch the nerve, and you see people with this age, they come and present it to you with a sciatica, which is pain in the back radiated down the leg, and this is the common presentation in those age group. And then when we reach into 50, what happens is we start having facet disease, we start having more of a back pain and leg pain, and because of when you have a disc bulge and degeneration, what happens, the disc height will really collapse, and then the facet not lining up anymore. They're not congruent, and then you have wear off. Whenever two surfaces not parallel, you will wear off. The 90 to 95% of the population, I call them the favorable ankylosis of the spine. They have a favorable outcome. They have ankylosis, but then they don't have symptoms, or they have a back pain which is tolerable and they could manage. So this is the favorable outcome. 5% of the people have unfavorable ankylosis or degeneration. When they start having stenosis, which is central stenosis, or spondylolisthesis, or even the more advanced, which is the deformity, which is the high end of the spine problem. So we come. This is a stable ankylosis. All of us, like when we pass 50, will have spine like that. So there is a lot of arthritis everywhere, but we're still, like, the facet is okay with no nerve rotation. We're still managing and pushing it through. Then when progressive collapse happens, we have a spondylolisthesis, and then we start have a foraminal stenosis, and then a neurogenic claudication. Whenever we walk, we have to sit down, and this is the unfavorable type. So this needs a treatment. And then if we push through, then we end up with deformity. We start getting like tipping over and really not able to maintain our like position or our alignment. So what the clinical presentation of patient with back pain? Normally they present you with a lower back and also radiculopathy. This is the common presentation you will see. Look, lower back is a bit difficult for me to manage. If you ask me how many patients you operate for a lower back, I really would say the finger of this hand, a year of back. And I tried everything, throw everything on them, and if it doesn't work, then back pain. Because it's like you operate on those one, you just trade one back pain and you give them another back pain. So trade pain with pain, and then so you try everything before you operate on those one. The problem is when this becomes radiculopathy, and then you see the patient start what they call it, reduce their walking distance, modify their activities. They use the car more than they walk. So you see them in the shopping center. The first thing they look for is the trolley, because they want the trolley because they bend forward, and this gives them a bit of release of neurogenic claudication, because more space for the spine to the nerves when they bend forward. And then after that they push through, and then when they end up with weakness, some unsteadiness, and they fall, multiple falls, and this is classical history. And if they still they don't have a treatment for that, they will start have postural problem. They're tipping forward and they can't really maintain their position, and then the ultimate they will have like bowel and bladder symptoms, and all is like a consequences of not treating their condition. And you see here, this is the cone of energy. So the spine is really, if your head, in the center of your head, over the center of the pelvis, over your center of the feet, this is energy efficient. Patient walk without needing any muscle to contract or anything. when you tip forward, the problem is the back muscle try to bring you forward. And if you do this, then those muscles will get fatigued at the end of the day because they all the time they're contracting and they will have upper back pain. Or if they don't do this, then they do even flex the hip, flex the knee to try to bring the head backward, and then they will start having arthritis in the hip and the knee. So it's all going bad from there. So examination, you examine them, you look for like a weakness in the leg. Also, you look for any sensation, sensory loss. You have to document this one. And the most important is the posture, because when they come to you, they look like the posture is okay, but when you ask them to really straighten the hip and the knee, they will go forward. So this is also important, and then you try to address that one. Plain film really hardly used. I mean, it's good to follow up fracture to see the alignment is maintained. Apart from that, it doesn't really give you any information. I don't use them at all in my practice, to be honest, unless post-op to check the implant and everything and follow up, but it's not really used. The most important thing is to get X-ray of the hip. If you're in doubt whether the hip or the back, get X-ray of the hip, because a lot of cases you think it's the back, but they have hip arthritis. And this could be tricky. So even get an X-ray of the pelvis, look at the hip, make sure they don't have arthritis. CT scan useful. It shows you the bony anatomy, plan your surgery if we need it later on. You see this patient has spondylolisthesis and also degeneration L5S1 and spondylolisthesis, which means the spine move forward. You can see here the spine is moved forward compared to the one below. And also it also, when you have a previous decompression, you see where is the hole they created in the spine and you plan your surgery. So CT is a good investigation. The most important one is the MRI. So the MRI show you the changes. You look at this. This is a normal disc if you look here, when you look at the MRI. So it's black at the back, black at the front, and it's gray in the middle. This is a normal looking healthy disc. You see that one, getting a bit changed, like black. When they black, they mean it's degeneration now happen. You see this bulge here, same here, and there here, even lost height. You see when the disc of the height of this disc compared to this one. When they lost height, mean the facet not lined up, and then they have mechanical back pain. You look here the same. Here a bit this bulges, and when they have this extent of bulge, it really touches the nerve and give you radiculopathy going down the leg. And this is the symptoms you have. When you refer patient to me, really, you refer the patient for surgical care is they have low back pain with radiculopathy, mainly. If they're just back pain, I mean, you try to, either you or me will do physiotherapy, will do injection, some pain medication. Refer him to pain specialist is better than refer him to a surgeon, because this have to be all done than surgery with a mechanical back pain. And even the aim of surgery is not to cure the back pain if it happens, is just make the back pain is more tolerable that he could function with. And then the other indication that they have back pain or and radiculopathy with the neurology, like they have foot drop, so this is an indication to send. Any mechanical back pain which you try to treat, you send them here and there, you send them pain specialists, physiotherapy, hydrotherapy, they done all these and no management, no improvement, then this one also you refer to see if there is anything we could help with. Back pain with deformity, the spine have scoliosis or kyphosis, whether a coronal problem or as a sagittal problem, so this one also you send, and also spondylolisthesis, because spondylolisthesis, although they are sometimes they don't have leg pain, they tend to progress with time. Even degenerative one, they tend to progress with time, and it's better we know about him early and know him before anything. And also deformity, progressive deformity, they can't really function, they can't do their normal daily activities, and they medically well people, then this could benefit possible from surgery. I mean, this all depends on a lot of tests we do later. So what changed since the operation? I remember growing up as orthopedic surgeon at Baghdad Medical City, helping Dr. Sabhan Khdairi and Dr. Ahmad and also Alrubaie. At that time, we do all back surgery all the time, one after the other, 5 a day in Baghdad Medical City, and all of them posterior surgery we do. But then now things changed since then. So there is, you could approach the spine from really back, from the side. You could approach it from the front, just mainly retroperitoneal approach, and then you access the spine depending on the problem. However, till now this is going all around. But then, if you ask me, I really do mainly posterior spine surgery. The guys I work with in WashU, on Washington University, they invented the anterior approach to the spine, but they said, we're not doing any anterior anymore, we just do posterior, because our skills in doing posterior surgery is so good. We could remove vertebra fully without needing to open the front. And also the consequences of going from the front, like you're going to open the chest, you see the line, you see the heart, it's all good and nice. But then this is consequences. The patient have a pleural effusion, have chest infection, it's all have a problem. And also you do the abdomen retroperitoneal, they have hernia, they have a problem. So if we don't have to, we don't go. But I go anterior approach for one thing is like is a burst fracture. Those bad fracture, car accident, they come. Like this patient, for example, is one case I brought. So this patient, 28, he have a car accident, high speed, and then he neurologically intact. But most patients, although they report neurologically intact, they will have a bladder and bowel symptoms due to S2 and S3 injury, which is very common. But during the trauma and the trauma setting, when you have them in a trauma assessment, you can't really test for bowel and bladder. They have the catheter anyway, so it's really later on it declares itself. So you look at this one, burst fracture, severe retropulse fragment going posteriorly. And if you go from the back, you go from the back, the nerve will be here and all traumatized, dural already trauma, and then you're trying to fish this fragment from the back is really cause a lot of harm. So those one I do anterior approach. And the anterior approach, I put the patient to the side, I use a table which break in the middle, and then you just find out this fragment here, you see here, this is the fracture, you can see it here, this here, and then here is everything removed. So this whole space, so you remove it, retroperitoneal approach, and then you, after I remove it, I just put a rod and a cage, this cage, because otherwise if you remove the vertebra, they will collapse, so you put cage to support it, which is just a spacer if you like, and then you put the rib just to achieve fusion and a lot of bone, and then flip the patient on the back and fuse it from the back. So you do a construct like that one. It's also preserve movement above and below. And if you see here, you see that patient, the same patient, but the fragment is gone from the back, and you see here a lot of bone to stimulate fusion around this area. The posterior approach, as I said, is the main approach. We call it working horse for spine surgery. So see, example, how we do. What is the common presentation come to us? A disc bulge with radiculopathy. That type is the best patient you could have. Is radiculopathy going down the leg, because with those patients, when they come to me to the clinic, I normally try to get them, if they don't have radiculopathy and not in severe pain, you give them injection of the nerve root and send them for physiotherapy. However, if they recur and they keep coming and stop them, is really, I have a low threshold offering a microdiscectomy. The reason is a safe operation, take about 40 to 45 minutes you do this operation. You're not changing the patient who he is. You're just making a small hole in the spine using microscope, removing the disc, free the nerve. And this will never go back. So it's just, there's no point leaving the disc there, and they have significant functional improvement. Different from fusion. Fusion, when you fuse the patient is different. When you have a fusion, mean a segment of the spine not moving, mean you move the one above and above more to compensate for the fusion, and this results with the progressive more fusion with time. So this one, you give him injection, nerve root, you send him CT guided, and see how he respond with the physio. If not, improve microdiscectomy operation and use the microscope just to clean up the nerve. And they really have a good functional outcome, unless they are have a secondary gain compensable, like sometimes ward cover, and they always tend to have pain and keep going. Yeah, this is different. So when you see this one is a bit different. That one, you see here wear and tear. There is not only a disc. You see there is a facet disease. There is a ligamentum flavum here. You see hypertrophy. So this is a different. You can't just do microdiscectomy and expect that one to get better. So that one you have to do a bit bigger. Like you have to decompress the spine. You have to stabilize the spine and do fusion, unfortunately. But this one also, you tried everything. You tried whatever possible. But hydrotherapy, physiotherapy. Look, as a spine surgeon, at the end of the day, the first consultation with the patient, you know this patient will need surgery or not. But it's better for the patient and for yourself to try everything else, because even the patient, if he end up with a little bit of pain, he said, look, I tried everything. I tried physio, tried hydro, tried injection. It didn't work. Then I come to surgery. accept it better, and yourself also. If you have infection, unfortunately, you feel guilty because why I should have tried this, I should try that. So it's better to try everything. But first consultation, I know this patient will need surgery or not, because it happened over and over. So this patient, see, I sent him for injection. But that one different. You do epidural, not a nerve root injection, is epidural injection. Here you do this one, and then see if it doesn't improve, then you do the operation. So what the other new things? Navigation, robotic. I believe strongly in navigation. I don't like the word robotic in the spine, to be honest. And the reason navigation is like, because when I was in Washington University, we look into the screw placement. They do routine CT scan after every patient having surgery. And we look at the freehand technique, putting the screws all freehand, about every 10, if you put 10 screws, you have 3 screws out. So it's 74% accuracy. So this screws is dangerous. You put it medially, going into the nerve. You put it wrong, lateral, you go into the arteries, the aorta and everything. So it's not really, so it's not acceptable to have a 74% accuracy. While in navigation, is almost 90, 95%, up to 99% accuracy. And this is, we're talking about best hand, like a spine surgeon, like Lawrence Linky, Dan Rowe, and those people. So you have to use navigation nowadays. And I think in 5 years, if you don't do navigation, you are risk of litigation. Robotics, so what is different? Navigation is you use image guidance, like CT scan, come out around the patient and help you to do an accurate placement of the screws. While robotic, it's the same thing, but then the robot put the screws. I rather put myself screws under navigation because I could use my experience. When things doesn't make sense, I could stop it and I check again. While robotic, you just press the button, is going that way. You can't really change it midway through, so there is a risk, which I think is unacceptable to me, although a lot of people do like a good job with robotic. So I don't have, myself, I don't do them, but people could do them accurately. So this is what happened. The patient come, this is one of the cases in Warringal Hospital in private I did. I have the C-arm, so this is the patient asleep. The C-arm, which is the CT scan, come over the patient, take a scan, and there is a, you see here, this is the tracker. So this is correlate the 3D position of the spine. And then is my fellow here. You see here, you could place the screw accurately. See how it's nice, like anyone could put screw. You can see here, you can put it in the bone, you're not damaging the nerve here, you're not damaging the vessel. You see the vessels here? It's accurate and you can see the level of screw placement. So it's quite useful. And this is, you see here in the pelvis, it's so accurate across the sacroiliac joint. You see it here up to, you could put it really nicely and accurately and safely. The second version is to do 7D. Like this, you do a pre-op CT, the patient not asleep, you pre-op CT, and then you use what they call it like a facial recognition, if you like, something similar to that. When you expose the spine, they take a picture and then they correlate and you place them. I like the first one more than that one, to be honest, and I use them 100% navigate all my spine. And this is, will give you the picture, and then when you do with this technique, this is how you put the screw. So it's quite accurate also. Yeah, and you see, I just want to go, yeah, some cases like this one have a disc bulge. He went for a discectomy somewhere, and then they have a look like a dural tear or something, and then another disc bulge. Then when they come with the second disc bulge, you can't really go and do a microdiscectomy again. Half of the disc already removed in the first operation. The second, you remove the half of the disc, then it will become like bone and bone. You will never be happy. So in this case, it's called fusion.
2 minutes.
Yeah, fair enough. And this is another case. You see how the navigation is helpful. This is like osteogenic sarcoma. You see in the top of here, referred to the I looked after him at the Austin from St. Vincent, and you can see here, when I did the fusion, you look, if you don't do it navigation, this is a 5 millimeter, and you put 5.5 size, and you put in 5 millimeter screw. How you could get it accurate in C1? So it helped you a lot. And this is the same patient after the operation when you have a radiotherapy. Yeah, this is the same thing, and you do fusion. So this is, I want to talk about that one. This is the high-end things, deformity. Unfortunately, the scoliosis, when you have someone like that, it's really the high-end problem, because everything, different from children. Children with scoliosis, everything going for you. Adult with scoliosis, everything going against you. It's like similar. You have a distal radius fracture in children, even if they are 70-degree angulated, you will take an X-ray in a year, you will see completely healed in a straight position, because the body of the children, like they try to heal and remodel, while the adults, if there is injury, they tend to degenerate, which is work against you. So here you work against a stiff spine in children is a flexible spine. Here the spinal cord tolerance is low. The children have very good tolerance of the spinal cord, and also the bone quality is good, because to correct this deformity, you need to put a screw to move the spine. The bone quality is not good, the children is good. So it's everything, but then you have those patients come to you, you have to do something about them. You can't just leave them, they can't function, they can't walk, they are healthy otherwise. Then either you place them into nursing home or you do operation. I do really about 5, 6 maybe of those a year, because they're expensive. The implant costs a lot of money. They stay in hospital long. They go to ICU. I don't do them in private. I do them in public. I do them Austin normally, and sometimes the Alfred. I have fellows to look after people. I have a big team, few registrar and physio to pack up, an ICU back up. So they need a full system. See this before, how bad the spine, and you see then they need neuro monitoring. They need, as I said, a long construct fixation. You can't just think that a small, this is a big problem. You can't really fix a big problem with a small operation. You have to do a big construct and big fixation and then line up their spine. This is the last thing, disc replacement. What I believe in disc replacement, look, unfortunately disc replacement, when the spine have a problem, degeneration, the natural history for the spine, they try to fuse, and they have autofusion, if you look. So if you try to do disc replacement, it's something like you're swimming against the current, or you're swimming against the storm. You're trying to change the natural history, which is a bit difficult. However, if you look, the spine have a 3 joint. The disc here, the front, and they have the facet joint at the back, 2 on each side. So it's very rarely to have arthritis only in the disc with the facet normal, as I said. So then you put a disc replacement at the front, all fine and good. But then what happened to the back? They still arthritis and they're still moving. So the patient, you make sure that this operation sometime to make sure the patient's still in pain for a while, because the disc is not good. Well, if you fuse them, at least you get rid of the pain. However, there is indication for that one. If really the facets are okay, the young patient, mainly the cervical more than the lumbar, because the cervical is less load compared to the lumbar spine, and you do disc replacement, they function. Younger patient with one disease, facet is okay. They still, and if they fail, you could convert them to fusion. And that's all.
So I have to present on behalf of my colleague Mustafa Al-Tahir. Unfortunately, he couldn't attend today because he had a family emergency yesterday evening, and he even had to leave half the way through his list, so it is unfortunate. But Mustafa is, I talk about the Lion King and the animal kingdom actually, and he's Simba, basically. He's going to be the Lion King very soon, hopefully. He's very talented. Mustafa is young. I've known him since he was an intern. He was my intern in Liverpool when I first finished training, and I could see a spark in his eyes. And he's very skilled surgeon. He's Australian trained. He went to Fairfield High and came to Australia at a very young age with his family, not dissimilar to many of the Iraqis, and he managed to go through the training in Australia, and then he did 3 fellowships, 2 of them in Sydney, one with us, one with foot and ankle surgeon in the eastern suburbs, and then he did a fellowship in Switzerland. He's a very talented limb reconstruction surgeon. He has special interest in foot and ankle surgery, and he's the brain in our unit, basically. He does a lot of the engineering work with our engineers. So I will be giving his talk, if it's all right. Okay, so we're talking about ankle problems. 90% of ankle arthritis is secondary to trauma. And it starts very simple with ankle sprains. You twist your ankle, you ignore it, You go to the GP, you go to the physio, and you strap it, and then it gets better, and then it doesn't feel as stable, and then you twist it again, and it hurts more, and then it gets better, and then you twist it again, it hurts more, and you keep ignoring it until you start having constant pain, and that's when the problem hit. The ankle is a very, very complex joint. You have the knee is like four times the size of the ankle, while the ankle is tiny. It's a small territory, small area where the talus articulate with the tibia, and it's like a dome shape or a rectangular shape joint that is highly constrained from the bony structure, has very little small amount of cartilage, and has ligaments on the inner side and the outer side of the ankle that are extremely vital. Unfortunately, it can get affected very heavily by our collagen disorder and by the way we are. So if you are flexible, if you can hyperextend your knees and you're double jointed, you are prone to have ankle injury. It's very common. The cartilage in the ankle is half of the cartilage in the knee, but it's more robust and more sturdy. But when it gets injured, it doesn't recover as much. So it is very common that when you get a twisting injury to the ankle, you injure the cartilage, and that cartilage injury becomes permanent. Ankle sprains are extremely common. It's pretty much the most common injury a person have in their sporting time. And a lot of the time when you get a fracture, you get cartilage injury. The fracture heals very well. It can heal anatomical, but the cartilage injury remain and cause problems, and it goes downhill to develop arthritis. So it's very easy to assess an ankle injury. You just check a range of movement, and you just move the ankle, and you see how stable it is. Look at the elbow of the patient, see if they extend their elbow, look at their fingers, if they hyperextend, then you raise the index of suspicion that these people could have a permanent ligament sprain. It's usually the ATFL, the CAL, or the deltoid ligament that can be sprained. And if it's a chronic sprain of these ligaments, then that leads to long-term arthritis. If you have the tibiofibular ligament strained or ruptured, then that's a syndesmotic injury. And if that gets missed, then you get sued, because that leads to very rapid acceleration of arthritis. And patient within 3 months, they get bad problems. So you need to be very careful not to miss a syndesmotic injury in an ankle. And then you look at the alignment. If you look at the patient from the back and their heel is twisting outward, and if they have flat foot, a lot of people have flat foot. If it becomes painful flat foot, that's a major problem, okay? That needs to be addressed. Before starting to do foot and ankle surgery, we used to ignore every single flat foot comes through the door. But Mustafa has taught us a lot about his experience in Switzerland and the way the Europeans are moving and the way science is evolving with foot and ankle management of deformities, and a lot of arthritic changes can be reversed and can be prevented, basically. And you can see this is a classic appearance of an ankle arthritis that could have been prevented just by correcting the deformity. And it's like anything. If you plumb line and everything is going in the line of in the geometry of the mechanical axis, it should wear evenly and it should last longer time, and it shouldn't lead to uneven wear and arthritis. And if it get caught early and you diagnose it in the early stages before permanent damage occurs, the solution is simple, which is just by reconstructive surgery and just tightening or reconstructing these ligaments. And it's a keyhole surgery that you can avoid a major problem later on down the track. And obviously other measures that you can do for preventing progression of the disease, like weight loss, physiotherapy, strengthening exercises, overcoming the problems that these patients suffer from, then you can do deformity correction. There are a lot of things that you can do by correcting the deformity if it's a flexible deformity. You can see this. This case, for example, has a chronic deltoid instability, and the ankle is twisted, and by just reconstructing the ligaments, you can put the foot underneath the ankle and make it straight, and as a result of that, you can change the biomechanics of this ankle and extend their lifetime with their ankle without doing an ankle replacement. It looks horrible, doesn't it? But funny enough, that salvage this ankle and prevent this patient from having an ankle replacement or ankle fusion or even amputation later on. Arthrodesis is the most common treatment for ankle arthritis in Australia, and that's because people don't know better. And as limb reconstruction surgeons, especially in our unit, we say amputation is better than arthrodesis, because arthrodesis is a major, these joints are designed to move, okay? Yes, you can fuse the ankle and the pain will go away, but you transmit the forces to other joints that are moving and you create a problem elsewhere. And it's similar to the spine. You fuse one segment, you transfer it to the level above, to the level below. It's exactly the same with the foot and ankle joint. Joints are not designed to be fused. So if you can salvage the joint, please do so. If you can replace the joint, if it's terminal arthritis, that's a better solution. But fusing the joint is the last thing. And there are certain indications for joint fusion, but they are narrower and narrower now with the advancement of the treatment that we have. And you can see here, ankle replacement had bad name in the past, and that's because people didn't understand how ankle replacement worked. And it's similar to hip replacement when it started, similar to knee replacement when it started, and now with better understanding of how the foot and ankle biomechanics work, if you treat the ankle as just the ankle joint that is arthritic and you replace it in its condition without correcting the deformity, you'll end up with a disaster. But if you correct the deformity around the ankle, then replace the joint, you will have very happy patient that has very long-lasting ankle replacement that can survive many, many years. And the technologies that we use is, as I mentioned, we heavily rely on 3D printing and analysis of the images that we get, and we rely on communication with the engineering department in order to build up the precision tools to make us apply and implement the procedure and the implant in a very accurate position. And these are classic jigs that we use for ankle replacement in order to position the joint in a very accurate place. And you can see, for example, this is a classic picture where the patient had a subtalar shift, like a heel shift, in order to get the plumb line down through the mechanical axis in order for the forces to be applied on the ankle joint evenly without compromise. Because the last thing you want is to have something like this, where this patient has been operated on, had an ankle replacement without correcting the malalignment and ending up with loose ankle, and then we had to come back and then revise it into more proper alignment and fix the deformity. And we have developed solutions for ankle deficiency as well. I mean, I get accused that I just want to chop off legs. As a matter of fact, I try to save legs more than anybody else. So we have this technology now where even if there is a complete talar necrosis, where the patient, the talus has vaporized and disappeared, and we can replace parts with 3D printing, and we have the technology. And you can see this patient had an ankle replacement somewhere in Melbourne, and unfortunately the talus become necrotic and everything sunk. So what we did, we put a cement spacer in the place as a stain surgery, built up the height, and then manufactured a 3D printed implant for this patient. You can see this is the design process that we go through, where the engineers go through the processes, and we build models for the patient, and have the replacement design. This is all done by Mustafa. Basically, amazingly, he stays awake in my offices in Ride with the engineers till 4 or 5 a.m. in the morning, and building these designs. And you can see that building a talus, and then we can implement it. And he does make us look good, basically, because you can see the results. We build an ankle without. This patient came to us asking for an amputation, but we can salvage him, and we build an ankle for this patient. Basically, that's another example where the talus was spat out in the street, basically from a dislocation, and had an ankle. Had a talus replacement somewhere else, and then we just changed that and failed, unfortunately, and we built a new design and put the new ankle replacement in this patient, and it worked very well. So there are solutions now with the advancement of engineering technologies to provide better solutions for foot and ankle surgery than we ever had, and the aim is to relieve pain, restore mobility, and correct the mechanical malalignment. Thank you very much.
So can I ask Dr. Munjid, Dr. Yasser, and Dr. Ali, please, to come to the panel, and we're going to have 15 minutes of questions and answers.
I have a question to Dr. Munjid and to Dr. Ali. Dr. Munjid, kids with tibial torsions, there is an age where we need to refer, and where is an age we can say to wait. And for Dr. Ali, scan showing central canal stenosis, is that any significant to refer to a surgeon?
Yeah, so for rotational deformity, for children, I would wait until they are coming toward puberty. I mean, depends. If you have pure rotational deformity without angular deformity, then I would wait till their physis coming to close, because you don't want to affect the physis. If any derotation, if you do it at a younger age, you need to put a plate, and that will be harder because they will be in a wheelchair. But ideally, you put nails in them, so you want them you want their growth plate to stop. If they have angular deformity, then they need to be referred much earlier, because you can do with 8 plates where you can do growth arrest or temporary growth control for their bone as they are growing. So utilize their growth potential to correct them, rather than cut them and correct them. So ideally, the referral depends on what deformity they have. With any angulation, refer early. With rotation, purely, you can sit on them a little bit.
I think there's a second. The thing is, with the spinal stenosis, it's more of treating the patient than the scan. So it depends if the patient is symptomatic. Like normally with the spinal canal stenosis, the symptoms is more of a neurogenital education. So whenever he walk, he have a calf pain. Whenever he sit for a few minutes, the pain goes away, and then he keep going. So the strips become multiple steps. So this is indication of referring, because this is a symptomatic problem, and it tends to progress with time. The problem with the scan, you know, that we have a lot of. All of us will have some spinal stenosis around there, but if they are not asymptomatic, then I think we just leave it and watch it. Even if they're symptomatic, the first treatment with this patient is to get them into, especially if they have comorbid, like they have a lot of diseases and they have a big list of medication. So those patients give them epidural injection and give them hydrotherapy and see how they goes. If they're still symptomatic after that one, then they may go surgery. Otherwise, I think I just watch.
I've got a question for Dr. Yasser. You talked about developmental dysplasia of the hip, and you mentioned ultrasound scan. What's the age when you think that ultrasound scan is not very good imaging and we should do maybe an X-ray? What's the cutoff age?
So the real use is in the screening phase, so postpartum. So within 2 months it's pretty useful. After 6 months there's very little role for ultrasound because you start to get ossification of the center of the hip, so you're better off using X-rays beyond that.
So 6 months is the cutoff?
Right, so mostly it's used for initial screening. So after birth there is usually a pediatric screen. If a newborn child is noticed to have a clicky hip, that's when you do an ultrasound. Potentially for the first 6 to 8 weeks afterwards you can follow up the result of that with ultrasounds. But let's say a child is now 6 months, then I will just head straight towards having an X-ray.
So would you still do an ultrasound scan if the bowel or non-lining tests are negative, but you see some bit of a difference, asymmetry in the skin crease?
Yes, I would, because the downside of missing a dislocated hip or a dysplastic hip is high, especially in the early period of development where it's quite salvageable with simple measures like splinting, like spikers. So yeah, I would.
And with the, you also talked about liberal tear. That's a little bit sometimes difficult to find even on MRI scans, is that right?
Well, no, MRI now is like looking at a TV in 4K ultra high definition. You see stuff that you don't know what to do with. There's a lot of incidental stuff, and the skill now is not picking up those things, it's deciding when to ignore them.
Sorry, one last question. I can guarantee you that more than 20% of people in this room have labral tear. So labral tear is not an indication for surgery. And we had, Yasser may agree with me here, because we went through a spike where every labral tear gets surgery. And there was a massive spike of hip arthroscopies in Australia. And now, I'm a hip scopist, and I can tell you I do less than one hip arthroscopy every 2 months nowadays, because you need to pick your patients. And the majority of hip scopes are indicated not for a labral tear, it's for femoral stamen big. And the labral tear is like a meniscal injury that is stable.
Sorry,
I deliberately left off the surgery for labral tears because of that exact same reason. So 10 years ago was the next big thing, and it was going to be a miracle operation, and it didn't pan out that way. And really the indications are limited.
One more question for the answer. Impingement, hip impingement. What's the best imaging? X-ray? Would you pick it on X-ray or CT?
Again, it's X-rays will show you when the hip is out of round, so where you have a bump. And again, going back to hip arthroscopy, that's the bit that's most useful is to shave off that bump, and that's a reasonably predictable procedure. And once you've made the diagnosis with that X-ray, then really the MRI, the use of MRI is more for the surgeon to have a roadmap for what will they do and will they mark surgery or not. For example, if you have significant chondropathy that you can't appreciate on an X-ray, but you can tell on an MRI scan, that may persuade you against surgery. Right? So I would say as a screening test, as a general practice type of test, I would just go with a series of X-rays, which is anterior posterior view, lateral view, perhaps add a semi-lateral or a done view, which is done in flexion. Most radiology places will be able to do that for you. If they report a significant bump, then I would refer on, and then perhaps MRI should be done by the surgeon.
Sorry, one last one. I've got 2 minute questions. Sorry about that. One last question to Dr. Ali. This pouch, would they heal like if you just send them to see a physiotherapist and would they heal?
This culture, if you talk about radiology, they still abnormal. But if you talk about symptomology of the patient, they would heal. So if the patient comes to you with usually present with a disc culture, they have radiculopathy. So this radiculopathy, you give them injection, you give them hydrotherapy. If they symptomatically improve, then I will not worry getting the MRI again, because it doesn't change my measure. I will not let someone who's asymptomatic for any further treatment. So it doesn't really change. However, when the annulus they happen, because the annulus, you know, the disc, if you look at the disc in cross-section, the annulus fibrosses are the periphery and inside the nucleus bulbosus. So what happened, first, if you ask any patient with a disc pain, with a disc problem, he will tell you, I lift something, I have back pain to start with. This is where the annulus happened, there in the annulus, back pain. Then after 2 or 3 days, I start to have pain going down the leg. This is when the nucleus herniated from the defect in the annulus, which is a weak point. So even if they heal, they will never heal as strong fibers as the annulus. So they heal with the scar tissue. And this is the problem, whenever they lift something, whenever they function, then they will have a herniation. It's a weak point. So he improved. Unfortunately, I see it all the time. They improve, they take time off work, 6 weeks, to get physio, hydro, go to the water, do the things, and then they get better. Then they go to work, and after, before you know it, like after 3 months, they have the same symptoms. And no one could afford, especially young people, that every time, you can't employ someone that every time you take 6 weeks to recover from a disc. That's why I saw when they have recurrence, then you consider surgical option. Because this is more of a permanent solution to get them up and going.
Thank you. Dr. Amir?
Thank you. So my question to Dr. Munjid. I would like to ask about your opinion of OA, the risk of OA after the ligament reconstruction, knee ligaments. Especially if we compare it with non-surgical treatment. Especially there's a research from the University of Melbourne, and they found that there's a good result if we treat the ligaments by rehabilitation in the surgery. And they found the MRI findings really good, and they think that the risk of OA in future will be less.
That's a very, very good question, actually, because that's exactly what I tell my patients. There is no evidence to show that ACL reconstruction or, as per matter of concern, PCL reconstruction would prevent arthritis. As a matter of fact, the sequelae of events, the minute you rupture your ACL or PCL, you injure the meniscus, that's arthritis kicking in, whether you're reconstructed or not. The only reason in my practice for me to do an ACL or a PCL reconstruction if the patient manifests instability. It's not to prevent arthritis. If the patient feels unstable, then and they want to go up and down ladders and they want to be highly active and they can't run and do the pivoting and shifting activity they want to do, that's when I operate on them. But it is wrong to say that this will prevent arthritis, because no matter what you do, arthritis will happen to these patients. So the indication for ACL reconstruction is for instability only. I don't know. Yes, sir.
Yeah, the indication for surgery is not to prevent arthritis, it's for stability. So if you have a tradesperson out in the West who can't go up and down ladders, well, it's a no-brainer, they're going to need an ACL reconstruction. The best that you can deduce from ACL reconstructive surgery is you may have protective mechanism to the secondary stabilizers, which are the meniscus, so to prevent further damage over time to that. But whether you do ACL reconstruction or not doesn't really change the natural history.
Thank you.
Dr. Ahmad.
Just quickly, in a general practice of what's your first imaging for any of the joints, and what's the gold standard imaging? You know, a lot of time, patient came to a specialist for an MRI because the general practitioner can't. So for all of you, what's the first imaging you prefer for your joint, and what's the gold standard at the best? And then one just for our general practitioner colleague, for the avascular necrosis that Dr. Yasser mentioned. We have some medical risk factors that you follow up. People with chronic pancreatitis, people with liver transplant, and people on bisphenol. It's widely used, they should be monitored for avascular necrosis.
Thank you, Dr. Ahmed. I would say in orthopedic teaching, a series of x-rays in at least 2 orthogonal views, so 90 degrees to each other, is an extension of our examination. I would discourage from high-powered investigations like MRI. I think they produce more confusion than use in general practice setting. We see a lot of degenerative meniscal tears and things like that referred with an MRI as the first port of call when it comes to investigations. And then I tend to work backwards, so send a patient for an X-ray and they've got near bone-on-bone arthritis. So in fact, there was very little point of a $500 spent on an MRI scan. And the other thing I would discourage is repetitive use of ultrasound. I see a lot of ultrasound in knee and hip, and it is very limited in what it can offer you. And it will tell you there's fluid, and if you do an examination of, especially a knee, where it's more obvious, you'll see the fluid. And that's really about it. And I think everything beyond that is more a subspecialty type investigation. Unless you consider about tumors or something like that, where you look at a CT scan or an MRI scan for that particular reason. But other than that, I would just give them to.
Yeah, I agree with you, sir. I mean, X-ray is the gold standard, and as a limb reconstruction surgeon, I do hip and knee surgery, and I always do long leg standing X-ray or an EF scan. It's important to see the alignment, and especially if you have minimal changes. But X-ray is definitely what we need. MRI scan, I would discourage anyone from doing an MRI scan as a first line, and try to avoid using ultrasound, please, unless there is specific indication for it. Ultrasound is only useful in very, very specific, limited indications, extremely limited indications.
Yeah, look, I think this one is a little bit different. So if you have a patient that have a radicular pain or nerve pain or weakness, I think the only investigation really is the MRI, because X-ray doesn't help. For sure, I don't use them, I don't remember. The only X-ray I look at the X-ray of the hip to see if they have arthritis if you're worried. CT scan, radiation without benefit, because anyway, when you send them to really, I would not look at the CT scan, to be honest with you. I just send them for MRI if they have a neurology, because I want to see the detail over there, where the compression is. I can't really take patient to theater or consider surgical option. So you're giving them radiation, which is for an investigation, which is not useful. However, I understand there is a bit of charge with the GP. I don't know if some of the patient will give the GP order the MRI to cost the patient a bit out of pocket or something. So that's fine. Then don't really do any test. I'll just send it to me. I could order the MRI.
Question to Dr. Ali. Often we see those patients with the mothers, like teenagers, about scoliosis. So what's the best approach for that? And sometimes we send an X-ray and we come back with Aokaby angle degree, like what's the angle definition, and how do we approach those patients, and what's the ultimate?
Yeah, so look, the definition of scoliosis is a cup angle of more than 7 degrees. It used to be 9 degrees, 7 degrees. So before you say there is a list for scoliosis, it has to be more than. So often you see some patient have a few degrees. I think it's just a normal, like 4 or 5 degrees. I would ignore that one. But if it's more than 9 degrees, depending on their age, what they do. If the child, for example, 13 years old or young, then you send him to the children's hospital or a pediatric spine surgeon. If the child, I would say 14 or 15, and the cup, even 14, and the cup ankle is not big, because no one, you know, the treatment of scoliosis, if the scoliosis is less than 25 degrees, we treat them with nothing. Between 25 to 40 and 45 degrees, you brace them. And if they are more than 45 degrees, you operate, because those people, we know that they will progress 1 degree a year, and if they are 45 degrees, then they will go big. So if the angle less than the angle high, and they are like young, then send them to pediatric, and if they are old, then you send them to a spine, like a spine surgeon, adult spine surgeon.
Thanks, Dr. Ali. The last question?
The last question was to Dr. Munjid.
Oh, he's gone.
Regarding the replacement of the talus, artificial talus, you are mobilizing. You are mobilizing or retaining the position of the talus with the calcaneum and navicular. So roughly this is a triple arthrodesis.
Correct.
So how much is it going to affect the right span of the ankle?
Yeah, so this is, so these are special indications when you have total talar failure. So if you have avascular necrosis of the talus where you can't utilize the talus, or if you have conditions where the talus is, you have multiple revision surgeries in the past where the talus have no bone substance, so you have to bypass that to the talar navicular joint and the talar calcaneal joint or subtalar joint. The main joint in this area is the ankle joint, the main mobility. The rest of the joints around that area have very little movement. So transmitting the force to these joints is not as damaging as if you fuse the ankle itself. That's your question. But when we do an ankle replacement purely with ankle arthritis, we don't fix the subtalar joint or the talar navicular joint. We leave them free.
So do you advise ankle replacement patients have arthrodesis for, you know, in the third world there's a lot of polio and they are treating people with arthrodesis? Do you advise this or?
It depends. Again, I see them here actually because a lot of them are migrant and they come to see us here. So if they had the triple arthrodesis, then yes. Definitely, if there is movement in the ankle, but if they don't have any ankle function, then then it is a difficult problem to treat. And I've done a few ankle replacements on polio patients. It's much more tricky because if there is no power that operate this ankle, then it becomes useless. Okay, so you need some power to operate that ankle. That's very important.
Thank you very much for the questions. Thank you, Dr. Yasser and Dr. Ali. So we will be breaking for lunch. Just before that, Dr. Ahmad will...
Just to mention that all these sessions will be recorded and they will be on Facebook, on the YouTube channel that we have, the organization or association YouTube channels and other. So the network for this will be wide, very wide. Not only that. Thank you very much.
Okay. Good afternoon, everyone. My name is Atin. I'm the gastroenterology advanced trainee at Macquarie Uni Hospital, and I'll be the MC for this afternoon. So thank you for our gynecology and orthopedic colleagues for their presentations, great presentations and really informative. I just want to hope that everyone enjoyed their lunch, and now it's time to talk about obesity and how to manage obesity. The moderator for this session will be Associate Professor Muhammad Jaiba from Wollongong, and he will present and introduce all the other speakers. Let's all welcome Associate Professor Muhammad Jaiba.
Thank you, Artin. I thank everyone for such a unique opportunity for us to be here today. We feel all privileged. In addition to seeing all of you, which is an advantage, I saw a good number of my schoolmates, and that made the day very special. So you made my day. Thank you very much. I have been more than 15 years in the field of bariatric surgery, And when I started, I saw it as interesting. But shortly after, I found lots of myths that made me ethically committed to debunk, which created some enemies, which made my life more interesting. So today we'll take you over the next 2 hours to hear the unusual from hopefully usual people over the next 2 hours. First speaker is a Macquarie product. He's one of our highly skilled senior specialists, Dr. Majid Al-Aboud. Dr. Majid Al-Aboud, after he finished his graduation in Iraq and internal medicine in Kufa, came to Macquarie to do a doctorate in endocrinology, and he achieved the excellence mark in it. After that, he established a huge practice. Now he is in Macquarie Hospital. He lectures as well in James Cook University, University of Notre Dame, and he is actually the president of the Middle East chapter, Middle East and North Africa Congress of Obesity, and he co-authored as well the Iraqi Expert Consensus Statement on Management of Obesity, author and co-author and reviewer of multiple journals about bariatric and endocrinology. We're privileged to have him, and he will highlight the medical part of obesity. Is it alone or part of metabolic syndrome? And what are the medical treatment for obesity before we move on? Dr. Majid, please.
So, ladies and gentlemen, my colleagues, good afternoon. Thank you, Dr. Muhannad, for the nice introduction. I have the privilege to start this session talking about a very important disease affecting the life of millions of people around the world, causing hundreds of complications, including reduced life expectancy, which is obesity. So this is an overview of my presentation. I will start with definition, and then we'll finish up with the current medication and the future trials. The WHO defines obesity as abnormal and excessive accumulation of fat in our body that may impair health. And we have many measures to define obesity, but the most commonly used is body mass index, or BMI. And we can get BMI easily by dividing our body weight in kilograms over our height in square meter, and we'll get a number. If that number is 30 and above, then this is obesity. And we use this number again to subclassify obesity into 3 subclasses, class 1 up to 3. If it is more than 40, then this is morbid obesity, or what we call a class 3 or severe obesity. Well, recognition of obesity as a chronic disease causing complications rather than a risk factor for other diseases is very crucial to push forward for the achievement of good management of people with obesity, especially here in Australia. I believe Australia so far hasn't considered obesity as a chronic disease. Over the past decade, many organizations and guidelines have recognized obesity as a chronic disease, such as the World Obesity Federation, FDA, and the European Medical Association. If we look at the map, obesity map over the world, you can see easily the Middle East and North Africa region, we call it MENA, has the highest prevalence of obesity. Countries like Libya, Saudi Arabia, Bahrain, Qatar, UAE have the higher prevalence of obesity. The darker the color, the higher the prevalence. And it looks like Australia is not doing better. And this is a very nicely conducted study by a researcher from Monash University 5 years ago, published in one of the journals. It shows that more than 1/4 of the Australians are suffering from obesity and its complication, including NAFLD. 60% of people who have obesity will have NAFLD. And as you know, non-alcoholic fatty liver disease is a big risk factor for liver cirrhosis and even hepatocellular carcinoma. And if we look closer to see the state and gender distribution of obesity, we can see women from Southern Australia and men from Tasmania have the highest prevalence of obesity, but overall the prevalence is around 27 to 28%. I'm talking about obesity, not obesity and overweight. I assume that more than 60 maybe % of Australians are either obese or overweight. Well, there are the etiology of obesity is multifactorial, but it's simply a result from the disruption of the homeostasis between energy intake and energy expenditure. But genetic and epigenetics play an important role. Some people have leptin deficiency, POMC deficiency. A very important hormone, leptin, that is secreted from the adipose tissue. This is the good hormone because it helps us to feel full and improve our satiety. On the other hand, we have bad hormones like the ghrelin, which makes us feel hunger, and other hormones that are secreted from the gastrointestinal tract, myokines from the muscles, environmental factors, where we live, physical activities, smoking cessation, all play a role in the prevalence of obesity. And a very important thing is the hedonic response. You all agree with me that when we feel depressed or sad, we will rush to eat because eating will help us to feel happy because there will be release of endorphins. So hedonic input is very important as well. The problem is the high energy food is more palatable but less satiating, with the low energy food is more satiating but less palatable. So the junk food is always, we like it because it's very palatable, and it looks like the bottom line seems to be, if there is food, our tendency is to eat it. And a good proof of that is what happened 15 minutes ago when we had our lunch. And there are hundreds of complications of obesity. Believe me, no single organ or system in our body won't be affected by obesity. And the last but not the least is the COVID-19. And we all agree that obesity is resulted in high mortality in people with COVID-19. It's not just that. Unfortunately, life expectancy decreases as BMI increases. For people with a BMI of 40 and above, which is morbid obesity, it looks like the chance of reaching the age of 70 is just 50%. But the good news, we need to lose as less as 5 to 15% of body weight in order to achieve remission from many diseases like type 2 diabetes and polycystic ovary syndrome. There are many guidelines for the management of obesity, but there is semi-consensus on the 3 pillars of treatment of obesity. This guideline from the Endocrine Society in 2015, the fundamental always is to start lifestyle, which is diet and exercise, with behavioral therapy, and then we consider pharmacotherapy whenever there is a BMI of 30 and above or 27 and above plus comorbidities. And by comorbidities we mean dyslipidemia, type 2 diabetes, hypertension, and obstructive sleep apnea. And bariatric surgery, of course, is indicated whenever the BMI is above 40 or above 35 with comorbidities. However, recently many guidelines reduced these numbers further to indicate bariatric surgery even at a lower BMI. So I'm going to speak about behavior and diet first. So diet, medical nutritional therapy, physical activity, and behavioral therapy are the fundamentals of treatment of obesity. We need to set realistic goals for our patients. We need to accept steady, incremental progress toward our goal, and then to focus on behaviors such as improving their physical activity and limiting their physical inactivity time. And the goals should be divided into short terms, and we should accept like 5 to 10% weight loss over the first 6 months. That's very realistic. And then in the interim, we should help them to maintain that body weight, and later on, after a long term, then we might consider further weight loss. But we should assure our patients that we are not stopping them from losing more weight if they would like to. Talking about physical activity, we need to have at least 3 sessions per week of muscle exercises, weight-bearing exercises. On top of that, 5 sessions per week of aerobic exercise, or what we call the cardio. Each session should be for 30 minutes. All of that on top of the everyday activity, and we should limit our physical inactivity to the minimum, like sitting watching TV or replying to the social media. These are important points that might help our colleague general physician when they approach a patient with obesity. Exercise is great for overall health, but it's not a great way to lose weight actually. It looks like exercise helpful for weight maintenance, weight loss maintenance, rather than inducing weight loss initially. There are many diets. There is no specific diet better than other. Whatever suits the patient should be fine. And there is no one diet strategy appears to be superior to another. Now I'm going to talk about the pharmacotherapy. So far, there are 6 medications approved by the FDA for treatment of obesity. And the average weight loss with these medications is between 5 to 14%. And we should make it very clear to our patient that they should expect weight loss to happen after 3 to 5 months. It's not immediate. Unfortunately, insurance don't cover it, so cost is a big issue. And these medications only work as long as patients are taking them. So once they stop taking medication, likely they will regain their weight. This is the table of the 6 available medications. Phentermine or Duramin, which is available in Australia as well, is the least expensive one. It will result in around 5% body weight loss. And then Orlistat or Xenical is one of the oldest medication, a lipase inhibitor. It is the safest of all medications, but again, with minimal effect, like 5% of body weight loss at the end of the first year. And then we have the combination of phentermine and topiramate, which we call it Xymia. It is the second most effective medication. It will result in 10% body weight loss. I'm not quite sure it's available in Australia or not, but for sure Contrave is available now in Australia, the combination of naltrexone and paprobion, but we should avoid it in people with suicidal ideation or affective disorder or mood disorder. And then we have liraglutide, the 3 milligram, which is the GLP-1 receptor agonist. And here I want to emphasize the importance of that liraglutide. The 3 milligram is called Saxenda. So it's not Victoza. Victoza is not indicated for weight loss. Victoza is a medication approved for diabetes. It is liraglutide, but it's 1.8 maximum milligram, which is not helpful for obesity treatment. We need 3 milligram dose in order to achieve weight loss initiation. And then most recently we have the semaglutide. The semaglutide is the once weekly injection. We call it Wegovy. Again, there is difference between Wegovy, semaglutide 2.4 milligram, which is indicated for obesity, and the Ozempic, which is only 1 milligram maximum dose and is indicated for diabetes, not obesity. But I see many doctors use it for obesity treatment, I mean the Ozempic. So far, the most effective medication for medical medication, pharmacotherapy, is the semaglutide Wegovy 2.4 milligram once weekly injection. It can result up to 14% weight loss. The story is not different from Europe. They have the same medication. On top of that, they have setmelanotide, which is once daily injection, but unfortunately this treatment is not indicated for every obesity. It's just only for genetic obesity, specifically speaking the POMC deficiency syndrome. And then we have the metroliptin. Again, once daily injection is indicated for leptin deficiency. The problem with the metroliptin and setmelanotide, each injection costs around $3,000, one injection. In the upcoming slides, I'm going to show the evidence behind each of one of these medications. So I'll start one of the old medications. This study was published in 1998. As you can see, at the end of the first year, there was 6.1% reduction in body weight. And the scale study, the famous study regarding Saxenda, the liraglutide 3 milligram, at the end of the first year, there was around 8% reduction in body weight. It's not very impressive. And then we have the combination of paprobion and naltrexone, what we call it Contrave, which results in 11.5% reduction. This is available in Australia. The second most powerful medication for obesity, which is oral, is the Xyme, which is combination of phentermine and topiramate. As you can see here, at the end of the 56 weeks of treatment, 12.4% body reduction, which is a big result actually. And of course, the most powerful medication so far is the Wegovy, the semaglutide 2.4%. As you can see, 15 to 16% reduction at the end of the 68 weeks of treatment of once weekly injection with semaglutide. And this child, when he was 3 years old with a leptin deficiency, his life has been changed now to become this 7 years old boy after starting treatment with the metroleptin, the once daily injection leptin agonist, human leptin agonist. And this is the study regarding the setmelanotide. Again, it's very effective medication, but for certain people with genetic obesity. And now we have new medications. One of them is the tirzepatide. Tirzepatide is a combination of GLP-1 receptor agonist, glucagon-like peptide 1, and GIP, gastric inhibitory peptide receptor. So it is a dual agonist. It has been approved for type 2 diabetes, but now there is ongoing trial to approve it for treatment of obesity. And the results are very impressive. 22.5% reduction in body weight after 72 weeks of treatment. And we have another GLP-1 receptor agonist called cagrilintide, which is very effective again under trial. With the compared to Saxenda, there was 10.8 reduction in body weight. But the problem is not with weight loss. Actually, the problem is with the weight regain, because it looks like obesity is a chronic, relapsing, remitting disease. I believe many of you try to lose weight, and after a couple of years, we regain our weight. So this is the main problem. Why is that? Because our body will fight any weight loss. It has been proven by studies that after a few years of attempting to lose weight, the good hormones, the satiety hormones, will be reduced by 65%, the leptin. On the other hand, the bad hormones like ghrelin will increase in our body. And our brain will deal with the issue as a famine. So this is our physiology. We are doing diet, but our brain tells us that you are not doing good because you are passing through famine. This is the reality, but this is the perception. If we now have a look on our journey in pharmacotherapy for obesity, which started in the year 1995 with the phentermine and the orlistat, with only 5% reduction in body weight. Until now, in 2023, 4, 5, we will have maybe combination of semaglutide and cagrilintide in phase 2, which will result in around 25% body weight loss. I think we've made a big achievement. And the gap between medical treatment and bariatric surgery is getting narrower and narrower. So to summarize my presentation, obesity is a very dangerous disease. We should consider it as a chronic disease rather than a risk factor for other diseases. And it results in hundreds of complications. It might reduce life expectancy, and it results from dysregulation of a number of hormones in our body. the problem is not only in achieving weight loss, but the weight regain after that. But the good news, we have now a number of beneficial medications that even can help people to lose up to 25% of their body weight. And thank you. هذا فتنس 24 hour بس يستخدم مصعد الكهرباء.
Thank you very much. Very concise and to the point. And please, if we have more questions, then we can perhaps collect them to the end. Interestingly, in this session, all speakers are very senior except myself. So presenting the next speaker is both a responsibility and a privilege. Professor Ahmad Alrubaie is an eminent senior gastroenterologist, finished training, subspecialized training with me at hospital. Then he jumped to Japan to specialize in therapeutic and diagnostic endoscopies, especially his area of interest in small bowel. That's why he's running the highest series of practice in Sydney. Not only that, he decided to go to Madrid after that. That's when he mastered the endoscopic management of bariatric surgery and became a figure as well in that. He now practices in Bankstown Hospital, Lidcombe, and Macquarie University Hospital. He's a professor who lectures in Macquarie University and University of New South Wales. He's also an examiner of the Royal Australasian College of Physicians. And in addition to all of that, he has significant extraclinical commitments, which always made me feel bad because I'm trying to catch up with him, and I always blame myself as to why. And after progressive thinking about the reason for his brilliance, I found the reason. His day is not 24 hours. It's at least 36 hours. So I hope I passed. Professor Alrubaie, please. Exactly.
Thank you, Dr. Mohammed. Thank you. You are one of our senior upper GI surgeons, Australia-wide and New South Wales. Thank you very much for the introduction. I will present actually the gap missed in the pyramid of Dr. Majid. Dr. Majid, the pyramid included all measures except the endoscopic, and I will convince him today that next time this slide should add okay. No, but I thought as a physician you will be biased to a physician like you. Well, you're biased towards now. Dr. Majid explained that we are dealing with a global problem. It's a pandemic, in fact. But the interesting thing is this pandemic is that we thought that only rich countries were troubled with this. But now it is not. It is even developing and poor countries are also troubled. Even countries in Africa or in Asia. Because it's not about diet, it's about the metabolic syndrome in general. So it's a global problem. I think the figures we have in Australia are very worrying. Now almost 2/3 of Australians either overweight or obese. And in 2025, this percentage is expected to increase to between 75 and some statistic mention 80%. Not obese, obese and overweight. The worrying thing also is that currently 1 in 4 of the children and teenage between 5 and 19, they are either obese or overweight. In 2025, this ratio will increase to 1/3. Really worrying thing. Dr. Majid explained the burden of it in the disease causation, and it's the second contributor to the causes of diseases of all type, of all systems. The burden financially is huge, around $90 billion in the 10 years expand between 2015 and 2025. Now, I will start with this. Dr. Majid mentioned it, and I consider this as the most important slide in my presentation. Understanding obesity as chronic disease wasn't a simple thing and wasn't a principled thing. This recognition, even by the WHO, occurred in 1997, by the American Medical Association in 2013, by the American Center for Disease Control even a bit later. And interestingly, in Australia, we're still not describing obesity as chronic disease. We describe it here, as per the Australian Medical Association, as a disease status where there is multiple pathophysiological disorders which need intervention on different levels, which is not enough. Now, why this definition is important? This definition actually formalizes our insight into the problem, the patient insight, and also the background for any intervention. Chronic disease means there is no cure, regardless to the measure, regardless to the intervention, surgical, endoscopic, or medical. There is no cure. There is no cure for diabetes. You can control diabetes, but it continues as a disease. That's why one modality is not enough, one measure is not enough. I think this is very important to realize, particularly for patients themselves. Now, Doctor mentioned the general measures and the pharmacotherapy ones, including the big guns they start to use with a very impressive reports. And we know the spectrum of surgery, and our colleagues will cover this. Now, I would like to mention that the combination of general measures plus the medication there are very modest in their weight reduction, particularly after stopping it. So they are modest, they are not enough. The meaningful weight drop should be more than 10%. Otherwise, measures wouldn't be. And this is the maintained one after the intervention. Not only that, but this, as Dr. Ahmad mentioned, it is poorly sustainable. Once you stop it, things will reverse back. Now, talking about surgery. Surgery is very effective, and on this line, it is the most efficient measure in controlling weight. And you can see the numbers are impressive. Say for the sleeve, it's the total body weight loss is around 25%. Dr. Muhammad and Dr. Duraid might mention numbers other than this, but this is the one I get. And for the bypass, they are even more, 30%. But surgery is a high-risk procedure. It's not minimally invasive. It has its own mortality, morbidities, both short-term and long-term, and it has its own cost. I'm not against surgery, but I should mention that this is a change in the body anatomy. We know a lot about it, but we need to know more about it. That's why there should be some transition in between the general drugs measures and the surgery, where a minimally invasive procedure would be the answer. Now, where we use endoscopic or bariatric endoscopy, there are 4 main indications. The first one is in overweight patients with a poorly controlled diabetes, dyslipidemia, or metabolic syndrome in general. It is very well indicated. And NAFLD, or non-alcohol fatty liver disease, or non-alcohol fatty steatohepatitis, the NASH, there's a good evidence that endoscopic intervention is enough to either reverse it or slow it down. Now, the second indication is patients who are not fit for the surgical correction, those with a variety of comorbidities or other things which make the intervention risky. The third indication as bridging procedure for the surgery to minimize its risk of the anesthesia. You know, obesity is a high risk for anesthetist. It's a high risk for peri-operative and post-operative complications. That's why having a bridging procedure to drop the weight will minimize the morbidities and mortalities associated with the surgery. The fourth indication is we are involved in managing the complications of the surgical interventions. There are complications, like any surgery. So one of the common them is the gastroesophageal reflux disease. The patient comes to us. They don't go back to the surgeon, except occasionally. The associated deficiencies, and Dr. Durain will talk about these deficiencies in detail. More importantly, we deal with the complications of the surgery which involve the anastomosis. Say, one of the complications is the anastomosis leakage and fistula, which usually need a surgical intervention, but endoscopically we can do a lot. We can put a stent. Don't know what's happening.
Just press the same one.
Okay. I thought I can use the pointer. So we can use a fully covered stent to close the leakage or anastomosis. We can use over the scope clip, this visco there, to close anastomosis. We can use the endoscopic vacuum therapy to close. This is very important. There's a risk of stricturing of the anastomosis, which end with obstructive symptoms there, but we can do simply an endoscopic dilatation. So we can deal with the anastomosis complication. Now there are a variety of endoscopic treatment. The most important point in this, don't worry about technicality, is that all of them, the efficiency, the efficacy of them, depend on the intensity and duration of the lifestyle modification, diet, behavioral, and other interventions, exercise. So in all of them, there should be an intense lifestyle modification over the first year, and then a lower level of lifestyle modification going on for the rest of their life. So in the first year, there's a lot of things to be done. That's why most of these interventions, whether it is the ESG or the balloons, there is a multidisciplinary team working on the patient. And usually the package came with a follow-up by a multidisciplinary team, which include a psychologist, exercise physiotherapist, and a dietitian, in addition to a GP, bariatric GP. And we're lucky to have Dr. Nada here, who's going to comment on the role of GP in the bariatric treatment. So that's for the first 12 months. Following that, then it is the regular follow-up, which can be with a dietitian or... Now, the most commonly used endoscopic treatment is the space-occupying devices, which usually involve the stomach. The first balloon was established in 1985, very primitive one, and the ones follow that, early 90s, with a lot of complications. But we start dealing with more advanced balloons. Now for the insertion, all of the balloons, except the oral one, this is an endoscopic procedure. The patient is intubated, so sedation is not enough, fully intubated. Then it is deployed, the balloon is deployed, and with that there is a few medication we use, including the steroids, including the antiemetics and the antispasmodic agent given at the procedure. So that's the insertion of most of them, and we have at least 2 of the orally swallowed capsule. I'll talk about them later. Now there are a variety of ones. The endoscopically inserted are, the most common one is the Orbira, SPATS, the reshaped intragastric 2 balloons, and we have the transpyloric shuttle. All these are inserted endoscopically with the same method. Now the orally introduced are 2. The O balloon, this is a capsule the patient swallow, and it's connected to a little catheter, which is used to inflate the balloon during the procedure. And it's either one balloon or three are deployed or swallowed by the patient over these weeks, depending on the loss. So according to the loss of weight, he can have one only throughout the period of 3 to 6 months, or 2 or 3. So these are the orally swallowed, but the removal is endoscopically. So it's deflated, ruptured, and then pulled out with a special forceps. The second oral balloon is the ellipse balloon, and this is even widely used. This one is orally swallowed, and it is naturally excreted. There is a valve. It's a time-activated release valve opened to release the content, and then it's excreted like any waste. So there is no need for endoscopic intervention for this one. Rarely we use this. This is a more invasive, still minimally invasive. For people who knows about the pig feeding there, this is like the pig. So this is a balloon introduced through an opening, and we do an endoscopy to pull it down and then inflate it from outside. But this is probably rarely used, although there are some numbers which encourage using it, but it's rarely used. So here in Australia, it's not used. Now, the mechanism of intragastric balloons, it is very clear. They with their restrictive effect, because the stomach would be smaller. Secondly, they slow down the gastric transit time, and there is a heaviness there. So for all these, there is yearly unsustained satiety. While this is the mechanism of it. In addition to a very important effect, this is the punitive effect of the balloon. Once he starts overfeeding, he will pay the price. Will be vomiting, have reflux, have pain, and have a lot of feeling of fullness. So he tried to avoid. Likewise, when for bad food, for example, for oily food, if he have it, he will have significant symptoms. That's why behaviorally, over 6 to 12 months, he will learn that these foods can bring up symptoms. Now, the patient selection, not everyone is suitable, but generally speaking, we talk about less than 70, a BMI of more than 27, and must is to eradicate the H. pylori. So he should be tested for the Helicobacter eradication. The reason why, there is a risk of ulcer, and with the presence of H. pylori, this risk is increased and can end with perforation. Now, the contraindication, most of them anatomical, so big hernia, stricture of the esophagus, surgery, gastric surgery in the past, in addition to vascular lesion. We have some vascular lesion which involve the antrum of the stomach. We call it GAVE, the gastric antrum vascular ectasia, which is called watermelon. This involves the antrum. They can bleed under the effect of the balloon, and they recur back. So we can't say ablate them and then have the balloon for 6 months, because they can recur back. So they can bleed. Also, if they need NSAID regularly, this is a risk factor, and obviously in pregnancy and breastfeeding, it is contraindicated. So the most widely used balloons are the Orbira, which is the first one. It's a fixed volume for 6 months. Fixed volume means it's not adjusted. From the time of inflation, it's the same volume. And that's why I wouldn't go into the details. That's why probably it has a reasonable outcome. So weight loss of 12 to 15% at 12 months, with the excess weight loss of about 27%. Now, in addition to the weight loss, it has impressive metabolic effect, both on the dyslipidemia and for the hepatic steatosis, and also on the on the mental status. So the PEG depression score improved significantly. This is a score for depression. And I think it is the whole thing, the weight reduction, etc., which is a depressing thing, in obesity there. Now I will pass all these and come to SPAT. SPAT is more recent, and SPAT is a variable, adjustable balloon. So we start usually between 400 to 600, and then we can adjust the volume depending on the loss, on the weight loss. If there is limited weight loss, we increase. We bring the patient to another scope and increase the volume to 700, for example. That's on one side. So that's why it is considered as more effective than others. So the total body weight loss is between 17 and 19%. Now the advantage of this is that some people, they can't tolerate the Orbira with the fixed size. So we bring them to aspirate some of the volume and decrease the volume. That's why from the compliance, the patient are more compliant with this one because there are less symptoms, particularly vomiting, etc. But this is with the price of gas ulceration. I'll pass this. Now, in terms of the complication tolerance, the SPAT is more tolerated than the Orbira. Ulcers much higher in the SPAT. That's why we put them on PPI on regular basis from the time, even if they don't have H. pylori or if they don't have history of peptic ulcer disease. Perforation rate is similar in both of them. The main cause of perforation is mainly deep ulcer, which is unexpected or ignored. Sometimes the patient have pain and then treated conservatively without doing the scope and check the ulcer and deflated. So it's virtually very rare. Migration, the balloon can pass the pylorus going to the small bowel, in which case it can cause small bowel obstruction. Death, it's reported to be less than 1 in 10,000, much less than 1. So between that's the American statistic. Between the 2015 and 2020, there were only 12 mortality, with millions of them used there. Now, this one is reported to have a modest weight reduction in the region of 11 to 13%, which is orally swallowed. The result of this is more impressive by numbers. So they talk about 14%, but the Australian experience is not encouraging for this one. That's why it's run out of favor. Although people think it is simple, just swallow it and that's it. In fact, there's not much difference except there is less endoscopy. So the difference is that we have less endoscopy for the insertion. The patient can swallow. This is the only convenient thing for the patient and for the cost. But otherwise, it's not superior to others. It's not like commercial. If you go to commercial ads about it, they talk a lot about it, but this is not true. Now, for the symptoms, I'll pass. The first week, they can have repeated vomiting, dry retching, reflux, cramps, abdominal cramps, constipation. They can have these things there. But if they extend more than 1 week, then there might be something wrong. The patient should be reviewed to check if there is problem with the balloon. We treat them mainly and conservatively. So nil by mouth for around 36 hours, and we bring the patient the next day to an infusion center to have a hydration, to have his requirement of daily hydration. And then we have a prolonged fluid diet between more than a week. Now there's good experience with this to limit those symptoms and the failure of the balloon, and also gradually building up their solid diet. These are the measures. We use all the available pharmacological agents, and their nausea and vomiting sometimes intractable, and multiple antiemetic agents should be used at the same time. Cramps is all symptomatic treatment. I talked about the punitive symptoms. Whenever there is either overeating or rapid eating or some food items with fat, there are symptoms. And it has some positive impact actually on their behavioral thing there. The common system is the belching. And the reason for that is that there is a gastric stasis, because we said there is a delayed gastric emptying, and this can release a lot of sulfurous substance in addition to the chlorhydria and the effect of the PPI, which is required because there will be no acid there, and this predisposed to this process. Diarrhea is most likely related to the gastrocolic reflux. There's a reflex between the stomach and the bowel. So when we eat, the stomach centrally sends information to the bowel to start preparing. That's why it prepares itself by passing the motion. So this is more active, this reflex, and also because of the small bowel overgrowth, the SIBO. Vomiting, if the vomiting persists, this means there might be something wrong. That's why it should be reviewed by the patient. Abdominal pain is a common thing there. The complications. Complications, these are uncommon complications. The peptic ulcer disease, balloon leakage is not a major complication because all it means it's failed. That's why it's usually colored with some substance that the patient starts noticing when he goes to the toilet. Usually a bluish substance. The saline usually colored. So if the patient starts seeing this, he will have this one. The small bowel obstruction, as I said, mainly related to migration of the balloon. Rare complication, the hyperinflation is not understandable why the balloon gets bigger, and usually they have more vomiting. The gastric outlet obstruction, the balloon ideally should be at the distal end of the body. It shouldn't be in the antrum where the pylorus, and it shouldn't be in the fundus. So when we place it, it should be midway. If it is in the fundus, then there will be no much delay. Usually things in the fundus can accumulate and can build up more. If it is in the antrum distally, it can cause obstruction. It can cause obstruction, gastric outlet obstruction with repeated vomiting. And usually this is easy to treat. It's just manipulating the balloon is enough to push it away there. Perforation, mostly related to previous gastric surgery, so it's not on a normal stomach and in elderly people, so it's not common at all. The removal, we do it under intubation, except for the ones. For the Orbira, we puncture it and then we drop it, we pull it through a forceps. For the spats, there is a catheter which we attach to the balloon and then aspirate the content and then pull it. So it's a very straightforward procedure. Now the restrictive, دكتور كم دقيقة بعد الزحمة؟ أنا ما أريد آخذ.
احنا انت مفتوح.
لا أنا ما مفتوح. أنا راح لا عفوا دكتور. الريستريكتيف procedure هي راح أمر كلش بسرعة هنا. This is to I think this is very important. This is to limit the size of the stomach, and there are a variety of techniques, but the most widely used is the endoscopic sleeve gastrostomy, right? So it is we attach this device to the tip of the skull, and we try to do all the suturing through this extra device. So it's not very difficult. All right, and it's based on the full thickness suturing. So with this device, we can have a full thickness suturing, like the suture for the surgery from outside. The whole idea is to reduce gastric capacity by more than 3/4. And this you might say, if the stomach is small, why there is a delay? So the suture line, which passes through the great curve, is made in a way which have the vertical diameter is more, which means it accommodates more of it rather than. So there is always a delay of the gastric emptying. It is around 60-minute procedure with the patient intubated, but the patient discharged on the same day. It's like endoscopy, like colonoscopy, less than 1% risk of major complication. So this is the stomach, and we're talking here about, this is the greater curve. The line of suturing is on this one. You can see by this movement, the mucosa, the full wall can be grasped there to put the suture. This is the suture, and we end with a tubular stomach. So if you confirm, this is the initial photo of the area, and so you end with the tubular stomach. Now, the outcome is 14 to 16% in 6 months. In 24 months, around 20%. Now, I should say that this number is an initial number. Now, there is some modification of this procedure. So, where the line, the suture line here, argon plasma coagulation is used to cause scarring and to cause extra benefit in this one, and the number are better than this one. But at 2 years, 20% loss, and the most important thing is the sustainability. So you can see at 5 years, it's 15%. At 5 years after this procedure, compared with the, I think Dr. Mohamed and Dr. Dorid might argue against this, but the number I got is this, 20% in 5 years, the laparoscopic sleeve gastrectomy. Recently, probably a few months ago, there was a big meta-analysis which mentioned at 10 years, we still have 13% total body loss. That with a very relaxed lifestyle modification. Now, we said only obese patient. So overweight, this is not indicated, right? So obese patient only, or those who decline bariatric surgery, but there are quite few contraindication, family history of malignancy, peptic ulcer disease, H. pylori, active H. pylori, gastric surveillance. We have some changes in the stomach which need every 2-3 years, we repeat the gastroscopy. These are the atrophic gastritis and the intestinal metaplasia because they are precursors of either adenocarcinoma or lymphoma of the stomach. People with organ failure, that's very understandable. People who need anticoagulation in addition to pregnancy. Now, I'll pass through this. There's no, to my knowledge, I don't know whether Dr. Mohamed had, there are no randomized controlled trial comparing head-to-head the endoscopic sleeve gastrostomy and the laparoscopic sleeve gastrectomy. But there is a meta-analysis here, and I will go through, just try, okay.
So there is one in Mexico,
yeah.
And in Brazil, the guy, he managed to do the studies, and he's one of the inventor of the endoscopic. And they
do you have numbers? I don't have numbers, yeah, but this is recent because I have a recent meta-analysis. These are all were retrospective. They were not prospective, no. They were all.
It's not randomized. It's very difficult to randomize patients.
Yeah, that's why there is no randomized, and all these data about retrospective measures there. So these are what we get. The laparoscopic sleeve gastrectomy is 29% total body weight reduction versus 17.6, but this is superior to the lab, superior to your lab banding there. So the endoscopic sleeve is superior to the lab use there. That's in terms of success. Now, I should say here that also when I went to Madrid with Lopez, who's the biggest name in the ESG, he was using Saxenda. I'm talking about 2019, long time before even all these progress. He was using it in combination with this. That's why his numbers were better than the Mayo Clinic numbers there. So he, on top of this, he was using the Saxenda. So I imagine this number can be even improved further with this modality. But look at the morbidities. The laparoscopic sleeve gastrectomy is almost comparable with the lab banding, but in ESG, it is much less. That's one. Secondly, it is the only procedure, while others are not. And this means a lot. It means the cost, means the availability of resources. So you don't need much for this. You can do it anywhere, correct? So it is a measure where you can use it for mild to moderate obesity. Obviously, we're not talking about a BMI of more than 14. These measures were echoed in this very good systematic review and meta-analysis. And in this one in particular, which is the most recent one, this is from November last year, where more than 6,000 patients were included in both arms. So these numbers I mentioned were confirmed. That just to convince Dr. Majid that endoscopy can have a better. Now I'll pass through this because there are minor symptoms about that. Now the bypass devices are usually involved the small bowel, and it affects the absorption, it affects the metabolism from bile, and it can affect also the gut hormonal balance there. And there is some query about whether they will affect the microbiome. These are probably rarely used. We have a trial with this one here, with this one, and it seems it wasn't very encouraging. Sorry, just let me get okay. Yeah, أنا أخذت وقته راح أخلص. أنا أكو there is this modality which is not very. This is a funny type of losing weight where the patient we put the device and the patient goes 20 minutes after his dinner to evacuate, and there is some weight loss in this one. Lastly is the Botox. Dr. Salwan, the Botox everywhere. Interestingly, we use the Botox for gastroparesis because we inject it around the pylorus. And it was found that if this injection is around the pylorus, the antrum, and in the fundus, it can delay the gastric emptying and inhibit the ghrelin. It's not widely used. Thank you very much, and my apologies.
That was very impressive, excellent, and we have been heavily taken by physicians so far. And but I reassure you, surgeons are technicians too, so we can cut the stomach the size you want and hand the leftover back to you, if you like. I would have to introduce my colleague, Dr. Duraid Abbas, to present as a little bit of a change in the schedule. Dr. Abbas was indeed a Brisbane boy, so he finished all the training in Queensland in terms of his FRACS. But then he left the sunshine, decided to go to the cold Victoria, and did lots of subspecialties there, inclusive, not limited to, bariatric surgery, breast and oncoplastic reconstructive surgery, endoscopies. Then he's heavily practiced, especially in the field of bariatric surgery, a huge contributor, both nationally, internationally, and an international fellow of the American Society of Bariatric Surgery. He's also a senior lecturer in Deakin University and practices as well in Western Victoria area and other hospitals, other private hospitals. Dr. Duraid, please.
Well, thank you very much. I think I'm going to use microphone or... Look, I think my voice is loud enough, and everybody tell me that, even when I teach a student, I think I'm commanding personalities, they call me, and I don't understand what that means. But can I get my slide, please? We're going to talk just briefly, because my talk mainly about surgery and sleep, but I thought if I just, thank you very much, and thank you for the community and the committees who invited me all the way from Ballarat. I live in one of the coldest cities in Australia, where yesterday when I left in the morning it was minus 1.2 and it was frosty, and it's beautiful, but it's I like it because I like living in the country. It always reminds me of the rolling hills of New Zealand. You guys do that regularly, isn't it? We do that. I'm going to use my pointer. And I've got mine now. I came in well prepared. I was pointing regularly. Everybody use that, correct? Everybody tell their patient, please. But is that science? Is that we're supposed to be the leading scientists here? We are. We always, work on through evidence-based medicine. And evidence-based medicine does not add if we just tell them eat less and walk. Yes, it does work. From a raw data from Jenny Gregg and Watch Watchers, who they a lot used, what do you guys think? How many of Australian, from all comers, from Jenny Gregg and White Watchers, with an industry worth over $6 billion, how many of the patients or the people who will, a year later, will have achieved a weight loss? What's a percentage you think? 5%. 5% of 100 will lose the weight they desire. How many of those who went with the weight desire, of the 5%, will find out they maintained their weight 2 years later? Any number? Of the 5%? 1.6. Is that telling us that we are 9,996% of Australians are stupid, or we have a different physiology? All right. And this is the physiology we're talking about. Our body, well, the first lectures we learned in physiology is acid-base. Who remember that when we were in first or second year medicine in Baghdad? It was really interesting subject, and it's very commanding subject. Yet, we learned that it is 7.34 to 7.44. That's the answer we should answer in the exam. Yet, no one talk about how the body regulates its own metabolism. I'm not going to talk about in details. All my colleagues talked about it before, but this is it. And this is the problem. It's the hypothalamus. When a patient comes to me and asks me about weight loss and how come they eat and exercise is not working for them, and I talk about the set point or I talk about the hypothalamus, I ask them to hold their breath for 10 seconds. Hold your breath for 10 seconds, and after that you gasp. This is unintentionally. This is the hypothalamus. That is the center defending it. The body does not know that you want to lose. You want to hold your breath for 10 seconds or 15 seconds. Your body does not know that you're going to need to lose 10 to 15 to 20 kilograms. All they know is they have to regulate. They have to defend, and that's what they do. And they do it very well. Everybody we learned, and when I did my subspecialties in colorectal with bariatric and breast oncoplasty, maybe I'm crazy, spending 7 years in subspecialty, we always talked about double hit theories. That's how we change it from adenoma to carcinoma. But the reality is, we born with genetic. This is our genes. That's a predisposition. This is, we inherit that. You remember the photo of the guy on the cave with the meat? That's how we inherit. But then we've got the program, which is the environmental loading. All that in an obesogenic environment we trigger. So we've got these two with the physiology. So to add to, and the current now, this is from the American Metabolic Association of Bariatric Surgery, the definition is altered physiology. It's not just chronic relapsing condition disease, it's also altered physiology. And it's through altered physiology we have problems, and through set point, which is upregulate us. This is our beloved Americans, and I'm not biased against them. My in-laws lives there, so I can't do anything. But we inherit a lot of genes, and this is the modalities. I always show it and present it to the GP's meeting. This is the pathway. Australian endocrinologist, Diabetic Australia, accepted this pathway for the patient, and now we dropped it from, You know, we started to be even less than 30 to accept it, yet no one worked on that. No one. Endocrinologists Australia in 2018 in King College meetings agreed unanimously that this should be the pathway, with Diabetic Australia, with the Physician of Australians. All of them agree on this pathway, yet none of them implemented it. We still don't agree on that. We still don't want to talk about it because, I don't know, we practice evidence-based medicine. Anyway, this is how we started. When I was in medicine, it was very simple. You lose weight, it's either restricted food intake or malabsorptions. But what we understand now, and we have to inform ourselves, it's actually physiology. It is alter the brain. It's all now about signals, endocrine, neural, immune, and the signals to other tissues, which is pancreas and liver. This is actually where the problem has nothing to do with this. It is this. But we just learning, and as we learn, you have to be open-minded to accept it. This is how I do the sleeve gastrectomies. But is it for everyone? Of course it's not. The problem with the sleeve gastrectomy, as it's very simple operation, is giving the bariatric surgeon a bad name for some because of the complications happen in the beginning of the surgery. Because a lot of surgeons jump on the wagon, they said, well, let's make some money, do this operation, not knowing what patient selections come first, then the operation. You should do the right operation for the right patients. So, who I'll do it? I'll do it for younger patients, especially now we're going to push for adolescents. I'm talking about patients over age of 13, 14. This is the operation maybe good for them, and older age group. I don't discriminate. Over age of 75, I still do the operation. The eldest I've done is 78. I'm not reducing the risk of complication of medicine, of comorbidities, but it's a lifestyle, it's self-care. A lot of these patients, they don't need to go to nursing homes. They will be self-caring. Personal hygiene is very important. I do it as BMI over 60, and I do it for BMI less than 35 with no comorbidities, and most importantly, no reflux. Now, this is not good for the Iraqis. احنا نحب الباتشا يا شباب. الباتشا والدولماني كتلتني والفشل الذريع مع العراقيين طبعا يعني. بس الريزلت مالتي اعلى من 20%. بالبداية نقول انه احنا نعرف انه هي ما عندها ميتابوليك افكت، يعني هي ميكانيكال، هي اكثر شيء، بس عرفنا بعدين انه هي كلها about the signals. It's all about how you signal, and then we know it's the signal come from the incretin hormones, which is a group of hormones that is produced by the duodenum and proximal duodenum. And that was responsible for it. So that's, it's good results. There is no problem with that. But you need to be well trained in the upper GI area to perform this operation, because it can lead to a complication if you're not well trained in it. And how are you going to salvage yourself? And I think that is the problem of bariatric surgery. And I've been interviewed by a Lebanese radio station here in Sydney when George Wassouf's son died. And they say to me, why you think, well, we have the best doctors in the world in Lebanon, or they think they got the best, why we've got the bad results? And I said, well, first, your theater or the hospitals is run on generators. No one does that. No one operates when there's on generators, not on super elective surgery. So anyway, so there is a way. We found that it's better than gastric band. I don't know. I don't like gastric band. I stopped doing them more than 15 years now. I hated that operation. So what we do is exactly what Dr. Ahmad حكى، قال إنه نسوي tube أو banana shape 150 mils والمريض ينزل وزنه. Of course, mortality rate. Who thinks that's, how safe is bariatric surgery in Australia? In Australia, I'm not talking overseas. Compared to cesarean section, guys. Let's compare it to cesarean section, obstetrics.
Nobody died.
Okay. Well, the risk of death from, in Australia, risk of death from childbirth, normal delivery, 6.8% per 100,000. Cesarean section, 13.8. Bariatric surgery is 10 in 100,000. There is death, but it's less than cesarean sections. This is done by the Registry of Australia. So this is, we talk about the 30 days mortality. So it's one of the safest. People talk about minimally invasive. It is minimally invasive. 52, my patient, less than 23 hours in the hospital. So we're moving, where is منجد واحنا راح نروح نبلش ambulatory or day procedure surgery. Anyway, so this is what we do. This is how safe it is. Do we have complication? Yes, we do have complication. I tell people that I'm started with the registry, the Monash Bariatric Registry, from the inceptions. It's the biggest registry in the world, and we have it locally. No other societies produce similar result to our results. Yet, we still think it's a risky procedure when it is safer than cesarean. Anyway, I think, is that finished?
Getting there.
Well, but this one is not working, so I'm not sure whether, here we are.
Bypass?
So anyway, so this is very good. Patients stay one night. They return to work in 2-3 days. They need to learn how to eat and do things. What I'll do is, this is the complication, mainly bleeding, leak, stenosis. Possibly we need to know about the long-term effect as we're talking about, because as we have data now. This is the new kids in the market. This is what I do regularly, more than the Roux-en-Y. I think Roux-en-Y, I use it unless you are severe Barrett's disease. I don't do Roux. I do this one as a first line, because Roux, I use it as revision surgery for my. This is really good. Produce a fantastic result, especially if the patient has got diabetics or metabolic disease. It's very easy. It's a hybrid. Make a 2/3 of sleeve. Count 1.5 meters to 2 meters, depending on the BMI. Join, you should be okay. Most of my patients, as I say, 52% of them, they've been discharged on the same, within less than 23 hours. Here we are. That's, I found the بالنسبة للعراقيين هذا دواهم. مو صدام حسين. minimizer ring. احط المينيمايزر رينج وبعد ما يقدر ياكل لا باتشا ولا دولمه وياكل نص كباب. فيعني هذا والنتائج مالته فعلا يعني اكثر من 5%. My latest results from the registry, that's total body weight loss, I managed to reach 87% through my data. I follow up to now 84% of my patients 10 years. One of the leading follow-up clinic. I've got dedicated nurse who will call my patients on weekly basis, twice a week, so I can tell people what's my results. Late complication, vomiting is very common. This is what the problem with the ulcer, marginal ulcer. I invented a new technique. What I do is in this area I pull the omentum underneath. The ulcer is usually posteriorly, so I pull the omentum underneath and I stitch it, so that's prevent ulcer. Marginal ulcer, they think with perforation is 6.6 in the literatures. My result so far, touch wood, is only 1 before I started this technique. So let's hope. I've done more than 500 cases so far, just past the 500. GPs, your patient going to develop gallstones. All of these operations going to have gallstones, 1 in 3. We'll talk about later on about deficiencies. No vitamin K.
Can I introduce Dr. Thank you very much, Dr. Ray, for the excellent presentation. Now it's time to introduce our colleague, Associate Professor Mohammed Jaber. I should say first that probably for his field of surgery, he's in Wollongong. That's why he's not Sydney based. But I do practice in Barrel every 2 weeks here. And once he was introduced to me, I started sending my patients for the upper GI malignancies, cancer tumors. And it was very impressive for all of them. We talk about Barrel population, Anglo-Saxon population. So now Dr. Mohammed is one of the top upper GI surgeon in the area. He finished his FRICS in 2009 with training in New South Wales. He finished the ANZ Gastroesophageal Surgery Association 2-year fellowship in St. George Hospital in Sydney and Box Hill Hospital in Melbourne, involving benign and malignant gastroesophageal and pancreatico-hepatobiliary diseases, all bariatric surgery and laparoscopic surgery. 11 years so far as a head of upper GI and bariatric department or unit in Wollongong Hospital and Illawarra area, 4th highest center for pancreatic and esophageal resection, associate professor with Wollongong Hospital, Wollongong University, sorry, Wollongong University. Dr. Mohammed, thank you.
Thank you very much for the nice presentation. I'll try to be as good as you. I always like the idea of hybrid cars because they use some of the petrol to generate good energy and then they use it for free. So I always like this idea rather than a fully electric. I must say human body is exactly like a hybrid car. So human body is like a hybrid car with a gas and electric. The gas is the carbohydrate, which is available like cash, but it burns dirty. And the fat is the electric, which is concealed, but it burns clean. And really, it was fascinating to know that the mitochondria is hybrid indeed. Yes, it does have a policy for fat metabolism, but that policy is only available upon request. So the mitochondria, not that it doesn't know the policy, but actually it was spoiled by us eating wrongly. That has slowly changes efficacy and the way they work and the number and made them carbohydrate preferring. So we know that we're the best human if we don't eat, because interestingly to know that the body has more than 200 regulatory mechanisms to deal with scarcity and starvation. The body is good at keeping you alive, improving your longevity, unless you eat more. And that will lead the body to abundance, which we have zero mechanism to deal with. So it is us who deviate the body slowly by changing the gene expression while we are alive, by adopting the wrong dietary style. If you take the caveman model, for example, they were not perfect to be able to hunt every 3 hours to eat. They barely do it once. And by the way, they don't eat at night, because if they hunt at night, they have to share it with hyenas and tigers and lions, etc. And they may lose their lives, by the way. So they do not eat at night, and they don't eat too many meals during the day. Then the industrialization made all the changes. However, the body is still smart, and it makes sense. If we eat a little bit of a surplus, the body will store it in the center of gravity around the belly, glutes, upper thighs, etc., expecting that it will need it at some stage. That's when the body is happy to mobilize it. But not that when you keep the surplus on and on and on and on, and the body will lose it after that. So if we compare our reserve of carb, is no more than 2,000, 2,400 calories, but the reserves of fat in a regular weight person is something like 40,000 calories. All of those calories are concealed, but something has locked it, which we're coming to find out and unlock. That's why from now on, so we know that when we are 50 years and older, all of our mitochondria are deficient, less working, and they're preferring glucose as a regulatory mechanism. And 48% of us under the age of 40 have mitochondrial deficiency. So deficient, not working well, not willing to apply all the policies. This is government corruption. So that is a state of corruption in the mitochondria that has led to all of that. So what do we do next? Consult dietitians, good luck. You can consult dietitians. So, so the next few slides will just take us through the sad story of the mitochondria, how we can really do it. Lots of dietary, successful dietary regimes that, however, they all share one common factor. They're low in sugar. The devil is the sugar, not the fat indeed. And unfortunately, most of our dietitians are still stuck in that chapter of very low fat diet and multiple meals. They're pretty creatures, but they're brainwashed. So unfortunately, well, I think we're hopefully getting them improved. You see the most common two diets being used are the Aitken diets, high protein, and ketogenic diet, high fat. Interestingly to see the canola oil or whatever is a core substance in the Aitken diet, and that was introduced to us. They just added a sexy name to it, vegetable seed oils. But it is full of omega-6, which is definitely pro-inflammatory, versus the omega-3 in the olive oil, which is definitely anti-inflammatory. So a little bit more, because that is the core questions from all the patients, etc., what to eat if you don't want us to eat that. We know that the eggs have the highest bioavailability of protein in the blood. They reaches 48%. And it is a myth that the egg yolk has only fat. It is actually a mixture of fat and protein, and the egg white will not be fully absorbed without the help of the protein in the egg yolk. So as if God cannot put a bad in a good and expect us to differentiate it. But egg is only second best. What is the first best? Is mother's milk. Unfortunately, all of us are too old to utilize that. But the mother's milk has more than 50% of fat in it. See, even God chose for the newborns to use mother's milk. Why do we feed them milk formula different to that? And why do our adults don't eat high fat? So slowly you will discover that we have been really bamboozled by lots of industrial factors, and us, doctors, perhaps health professionals. Dairy products, are they good or bad? Milk is bad because it's high in sugar. Remember, adult cow does not drink milk, she drinks water. But wait a second, I have bones, calcium, etc. Sure, just have other dairy products where the bacteria work on them smartly and sucked all the sugar out of them. Is butter good? It's good, but the problem, you can't eat it with a spoon. You have to eat it with bread. So that's why maybe you can cook with it. And if you see all the meat, for example, 32 bioavailability protein. Processed protein and protein bars and gym proteins, only 16%. It's really not a good idea to consider you doing well drinking that. Back from the gym, just take 2 boiled eggs and you'll be all right. That will be better than a protein one. So we're not saying here that ketogenic diet is the only and is the must, but actually it answers lots of questions. By far, it is the best because it works hormonally. So all of this talk is not calories. We talk hormones, and that's what we teach. And we coming back to the mitochondria, you have to give lots of fat for the mitochondria to feel the change. And half of that is protein and very minimal carb. And as you can see, it spares muscle mass, it doesn't waste them, it does not reduce the metabolic rate. As more importantly, it improves cognitive function and endurance. How long have you been taught that the brain is an obligate glucose utilizer? What a fallacy. And let me rephrase it. There isn't carbohydrate requirement for a human body. There is not. There is definitely essential amino acids, there's essential fatty acids, but definitely not a carbohydrate requirement. So, back to the mitochondria. The mitochondria is spoiled by a guy who has been cramming it with lots of glucose secondary to us, eating more and more. It is the insulin. As if the talk here is hormonal. There's a hormone we need to reduce, which is the insulin, and one we need to push up, which is the growth hormone. The insulin hormone, either it crams lots of sugar but the mitochondria will reach a certain quota, can't take anymore. That's when the insulin converts the rest to fat. And guess what? The insulin as well blocks the nitric oxide, causing reduced relaxation of blood vessels. It's a growth factor causing vascular smooth proliferation. It causes hypertension. We have been all taught that hypertension is essential, and actually it's a myth. It is not essential. It's only the tip of the iceberg. Please check the insulin on your hypertensive patients. It is part of it. It is not essential whatsoever. So, to do with the mitochondria, it is not starving the patient. It's basically starving and torturing the mitochondria when they will say, all right, there is no sugar now, but don't worry, he will binge in the evening and we will have party again. So that's when you torture the mitochondria again and do intermittent fasting. So by and large, high-fat diet, let's call it, rather than ketogenic diet, followed by intermittent fasting is the best to make the change. And of course, it takes the mitochondria some time to learn a lesson and reach what we call mitochondrial fat adaptation, which is up to some, I would say, 3 to 6 weeks, when the person feels that he lost his sweet tooth and is very happy. He developed even a fat tooth now. He's happy to eat more fat, and he has enormous amount of energy, because the liver, even in the early stages of adaptation, will produce something like 2,000 calories from fat burning per day, which is enough. Yes, we have a disagreement with our other colleagues, and that based on the Australian Diabetes Medical Association, the American one. As we believe in early stages, type 2 diabetes is definitely a curable dietary disease. It is not a progressive disease unless, of course, it has reached very advanced stage. The goal of the treatment, they believe, is to control blood sugar, and who cares about blood sugar? The goal of treatment is to reduce insulin resistance by doing two things: no snacking and reduce carbohydrate, and slowly the resistance will reduce, and we don't have the trash. Blood sugar is something will come down by itself, and it is definitely written in the description of the oral hyperuricemia that the patient is instructed to eat multiple small meals full in carbohydrates, which is, to me, is absolutely a crime. The snacking is indeed a crime. Low carb diet, intermittent fasting is the way to go. Yes, weight loss will improve diabetes, but not only. Low carb diet will improve resistance and will make cure diabetes, actually. But it doesn't mean we don't deal with our endocrinologists. As a policy in our practice, I never stop an oral hypoglycemic agent from my patient. I never reduce the insulin, but my job is to reduce the patient weight and make them back to on between flags, eating high, fast, some protein, and then send them ready to the endocrinologist, hopefully to wean them from antihypertensive, anti-diabetic medications. Intermittent fasting, sure, it is, once again, so we learn now that insulin needs to be reduced, but how about the growth hormone? It is the hormone that will slim us. It is the one that will work on the fat and the overfat area, mobilize it. And it is exactly the same one that the boys buy for $600 to inject. But the condition here that will only be released if you fast 14 hours and beyond. It does not come up if you fast 10 hours only. So basically what we're trying to do here, it has a huge mental improvement effect. It has unlimited power at all, and we actually prescribe it for people with early dementia in combination with high-fat diet, and they all feel highly improved after a few weeks of treatment. We prescribe it to students. They achieve much better at university. people with significant sleep interruption anxiety, they achieve much better. So the key here actually is a fasting for 16 hours. So basically the journey here is an eating window of 8 hours and a fasting of 14 hours to start with, hopefully to jump to 16 hours. But it is different from the day-hour fasting we do, but it has to start early in the evening, preferably some 4 hours before sleep, and continue all the way down to some 9 a.m. So I always tell them, you got to respect the clock. 7 p.m. you brush teeth, nothing after. Water and zero-calorie fluid are allowed until 9 a.m. at least, and then slowly you push it to some 10 a.m., etc. During your eating window of 3 hours, you can eat anything but white and yellow and floury stuff. So that will make you eating loss of protein, loss of fat, etc., etc. And they see it very hard to follow to start with, and they like it. All is that, so we don't measure, body does not have a scale. We don't measure, we don't feed snacks, we don't tell them to eat 43 and 46 grams, etc., etc. The previous slide showed the ghrelin hormone, just one more. So people worried about the feeling of hunger. And I said, oh, just acknowledge it. I'm hungry, good, let's sit, I'm hungry, drink water. The good thing about the ghrelin hormone is very timid, only takes 2 hours, and then it goes down. I will come back in 2-3 more hours. So we don't need to react much to hunger, and if you just wait 2-3 hours, it will go down. That's why we don't support calorie restriction and multiple small meals, because it does not work hormonally. So the intermittent fasting does. The refeeding syndrome, weight regain is high. Ghrelin hormone will stay very high because you always starving. So ghrelin hormone will suffer from that. And metabolic rate will go down by 76 kilocalories per day, as the body will think that you are in a desert, so there's no food, so go to budget mode. Whereas with intermittent fasting, the effect is offset by the sympathetic stimulation, so you don't feel as metabolically suppressed. I'm an owl. So I do lots of our nurses and people who have night duties, etc. And what do? We have night duties. When I say, yeah, you have a night duty, that is a bonus and a doom. So the bonus that you will exercise and do stuff at night, and that will help you to reduce weight. But you don't have to eat. You can stop eating at 8 p.m. being overnight duty. However, the downside of that will keep your steroid, cortisone all the way up, because you're always sleep deprived, you're always stressed out, so that will not help us. If you can change it to daytime or etc. Some people come and insist that they're taught they are owls, they wake up at 1 a.m. One of the patients said, I'm an owl, wake up at 1 a.m. I said, I know why you wake up at 1 a.m., but what did you eat at 1 a.m.? He said, I just ate a couple of white toast with Vegemite. I said, I haven't seen in my life a vegetarian owl. At least have a piece of meat. So that is the summary. So the third thing, in addition to the fasting and dieting, is the exercise. As my colleagues mentioned, it is not a weight loss modality. It's an adjunct, but as a very important adjunct. So they have to exercise every day. And I always say, just like the 3 sisters, you have to do them every day, and that's my conclusion. So every day you have to exercise, every day you have to diet the way we want it, hormonally based, and you have to fast. If you don't do that, it's unlikely you lose weight to prepare you for weight loss surgery. We do all of that as a pre-operatively, because they have to lose some 10% of their total body weight before they qualify to come to the hospital. That is actually the end of the first presentation. I think I'm ongoing to the second presentation, which is, so that one I promised to be shorter than the other one. We spoke about, I'll skip some slides where my colleagues have been already through. There isn't too many contraindications to bariatric surgery, but there are some of the very important ones. And that is not common in practice. Significant impairment is one of the common ones that they go to refer to us, and we say if they can't comment, they cannot really come for an operation. Pre-op optimization, well spoken, I'm not repeating that, but I stress on at least 7 to 10% of the total body weight loss before the day of the operation. So when I see a patient, take me some 3 months before they come to the hospital. And that's what Duraid mentioned about mini gastric bypass. So I put in the same slide the other bypass, which is the Roux-en-Y gastric bypass. And you can clearly see here that in the mini gastric bypass, the pouch is long here, and there is only one loop. So why the pouch is long? Because so hopefully the bile, which is coming here, does not go to the esophagus. Whereas in a Roux-en-Y gastric bypass, the pouch is smaller because that limb has been divided and all the bile being diverted all the way down. So what do we conclude from that? It is the operation for severe reflux. So from now we need to understand the indications. If a patient comes with a severe reflux, regardless of the BMI, unfortunately there's no other options to them. They have to go for a Roux-en-Y gastric bypass primary. So whereas patients without a reflux, as Duraid mentioned, they can have mini bypass, they can have a sleeve depending on the age, BMI, presence or absence of diabetes, because a sleeve gastrectomy is not as robust, for example, as mini bypass, given the very high BMI. Two disadvantages you can see in the picture, and one advantage. The one advantage that they both bypass the duodenum. That's why lots of surgeons feel that no matter how long is the biliary limb or the alimentary limb, once you bypass the duodenum, a good weight loss will be hormonally achieved, which is true. However, the two disadvantages of that, as possibly mentioned before, number one, you have a gastric remnant which is neglected, difficult to monitor. So in countries like China, Japan, high risk of gastric cancer, you can't monitor them anymore. And what else? As Duraid mentioned, almost all of them will develop biliary disease and gallstones and CBD stones, and you can't reach the ampulla because you are diverted totally from it, which is another problem. That has led to the appearance of a third operation, which is the SASI procedure, which I have been doing for the last quite few years. The SASI procedure, the people say, number one, it is a sleeve and a bypass at the same time. So basically, we do a sleeve and we leave the lower end a little bit wide. So we bring a loop, we count rather than from the jejunum, from the cecum some 3 meters up, and we put it some 3 centimeters away from the pylorus. So as if then you have a sleeve with a basin with 2 drainages. And it is crucial that you do it anterior, right at the level of the pylorus. That's why we call it a bipartition operation. Otherwise it becomes a drainage operation and everything will go through that bypass. The benefit of that 1/3 of the fluid will go through the normal way and go through the slow process of all the way going up that will allow absorption of the nutrients, etc., and prevent deficiencies. And 2/3 of the food will go express all the way down to achieve the weight loss. It is specifically designed for heavy people of BMI 45 and beyond. I do it regularly in my practice in addition to the mini and Roux-en-Y. So indeed, Roux-en-Y primarily for severe reflux or a revision. Any operation before band or a sleeve, they should have a Roux-en-Y. They cannot have any other procedure. Mild GORD, possibly okay to have a SASI, but not a severe one. And it has significant benefits, and I can see very minimal side effect of that. SADI procedure, I only done handful, believe it or not, over the last few years, because it is similar to SASI. However, you have to cut the duodenum, so defeat the purpose. You disconnect it again from the duodenum, and it is risky because, like when we do laparoscopic total gastrectomy, you cut next to the CBD. I see it more risky than justified for our weight loss procedure. They believe sometimes it is a revisional after Roux-en-Y gastric bypass, but honestly, a patient who fails a Roux-en-Y gastric bypass must have personal factors, habit factors, dietary factors. Doing another deleteriously difficult procedure on him may not help him all in all. And the monitoring has been explained before. Complication, I think they have been explained by my colleagues. Bleeding or leak, very low, to be honest. I had one bleeding over the last 14 years and no leak. So it's not that common at all. The bleeding, the problem, they're very morbidly obese, it's difficult to tell clinically. Abdominal pain in any weight loss surgery, especially bypass, 3 differentials. Gallstones means ultrasound, or ulcers means a gastroscopy, or undifferentiated pain, laparoscopy, because the risk of internal hernias and gangrene are very high. So a high index of suspicion should be. Structures have been visited before by Professor Arrubaie. The weight regain is a problem, but I found most of the reason for the weight regain is not technical factors. It's basically patient factors, unfortunately. I agree with Duraid. I'm proud to say that I have never put a single band, but I remove bands every week. And they have that complication of almost that big stomach, that's one of my patients, or a chronically infected band, etc. We have to remove the band in an operation and wait 3 months to rest the patient. Then it's only a Roux-en-Y bypass as an option if the patient wishes. Last thing is the dumping syndrome. I see it infrequently, either early or late. All of us are familiar with dumping syndrome. People come and talk to you about that either early with the cramps and diarrhea, or late, and they have to lie like that with the sweating and palpitation. And we tell them to eat dry meals, not sugary, and no much liquids at all. So take home message, it's a successful operation, as Duraid mentioned, if we choose it for the right person, for the right indication. And usually the loss of comorbidities are very impressive. That is the end of my presentation. And so the next speaker is one of our GP colleagues, Dr. Nada Raouf. She's a general practitioner. She had her FRAC GP 2012 and a bariatric fellowship after that, and she is specialized interest in dealing with bariatric patients. She practices in my health medical center and city metabolic surgery. Thank you, Nada, and hopefully to give us the GP highlights of the problem.
Yes, thanks everyone. Thank you. Thanks everyone for the opportunity of talk. I had a very short notice yesterday, just joined yesterday, so I didn't prepare any slides, which I think it's good, so it's very quick. So Dr. Alrubaie want me to talk about what do we do as a role of bariatric medical practitioners. Not everyone knows what do we do in general. Oh, sorry. So usually we start with screening of our patients. We welcome the patient. We start to explore what's the reasons why they are here, what's the causes of their obesity, what's their expectations. Is it realistic expectations or not? What's their goals? A lot of them, they come, for example, they come age 25 years old, severe PCOS, infertility. She wants to lose weight very quickly and she wants to get pregnant in 6 months. Is that realistic? Of course not. Same thing, sometimes we get 14-year-old. He wants to lose weight, he's being bullied at school, he wants to lose weight quickly, he wants to do bariatric surgery and get back to the field and play soccer. Is that realistic? Maybe, maybe not. So we sit down with them, we explore why they are obese, what's the causes of that, is it lifestyle, is it diet, is it behavioral, is it genetic? Screening, obviously, so we start with pathology test, possible imaging if required, and then we guide them. What is the best way to help them to lose weight? Whether it's medical, of course, we start with obviously lifestyle modification because that's the gold standard in the success of weight loss journey. If they don't change their lifestyle, that means it's very difficult to succeed and maintain that weight loss because we all know obesity is a chronic, very relapsing medical condition. They lose weight, but they regain it back, and that's normal. So we tell them, this is not your fault, but this is the lifestyle of obesity in general, as diabetes and hypertension and heart disease. So first we talk about how do we change lifestyle. What's realistic? Are you going to join a gym? Are you going to exercise at home? Are you going to buy machines? I discuss all of that with them in details. How are you going to do it? What do you like to do as a change that you'll maintain it lifelong? Because that's important. We don't look at changing it for a year. We look at changing it for 10, 15, 30 years. And then we look at, okay, you're not ready, for example, for surgery, or your body mass index is not ready for surgery. Let's try with medications first. What medication can suit you? What's the side effect of this and that? finance? Do you have private insurance, or that can cover medications, or what's the cost of that medication? How long are we going to maintain it for? Because we do know that you can't use injection for a month, lose 50 kilos, and then stop it after that, because that's not going to happen. So we need to set goals and realistic expectations of what's happened. And then, of course, if the body mass index is very hard or they haven't managed to maintain that, then we look at probably surgical ways of weight loss, whether endoscopic or whether laparoscopic surgeries. And then we got them what's the indication of whether it's endoscopic, from balloon, side effects, realistic expectation, possible weight regain, and then bariatric, okay, body mass index of 50, well, possibly go straight away to surgery plus lifestyle modification. Yes, then maybe weight relapse, weight regain after years, we might look at medical ways then. And it's not wrong. So weight regain is possible, then we look at how we're going to manage it. So follow-up is very important. In our clinic, we follow them up. I tell them, I'm happy to see you guys up to 10, 15 years. As long as Medicare is available, we're happy to see you guys. And as long as well there is private health insurance that can cover. And then we look at possibilities. If they regain weight, what we're going to do after that? Do we go back into lifestyle modifications? Why did they regain? Maybe they stopped the gym. They stopped walking. Or they're going to start snacking again. As Dr. Jabiri mentioned, snacking is killing. And that's the problem of most Australian lifestyle. They have to have a morning tea. They have to have an afternoon tea. They have to have a breakfast. They have to have lunch. So it's basically continuous eating till bedtime, which is very wrong. So get them to understand something that they've been doing since the age of 2 and 3 years old. So we try to explain that what's right, what's wrong, and maybe trying something new, the intermittent fasting, keto diet, going back as well possibility to the shakes. So it's not a wrong thing. So sometimes after bariatric weight regain, we go back to VLCD shakes. It's very successful as well. Or with the help of medications, whether injectable, tablets, to help in weight loss, and as well with the help of our dietitian, psychologist, to keep counseling and make sure they understand the expectations of weight loss journey.
Excellent.
Yeah.
Thank you very much. Thank you. We are almost done. Our last speaker, again, is Ray to talk about nutritional deficiency, and that will be the last of our presentations. Thank you.
Thanks again. So I'm going to be, I promise I say 5 minutes. Is that exactly? Let's see.
Very generous, very generous.
All right. So guys, how are you thinking about surgeons and know a lot about nutrition and knows about mitochondria? You guys think this is really amazing. Hey, you guys impressed with us. I mean, you know, all right. So here we are. What do we think? We think we know that is for sure and we're 100% that nutrition. We know that post-bariatric surgery, everybody been told that post-bariatric surgery you'll be nutrition deficiency. Hello, look at that. 93% of people with obesities, vitamin D deficiencies, calciums, irons, all of that. That is not just, well, that's working, or, yeah. Look at that. It's all of that's happened before surgery, but after surgery, I'm 100% sure that, thanks mate, after surgery, we definitely have some nutritional deficiency. Why is that happening? Again, we need education. Patient come and see me, it takes them between 3 to 4 months before they will be on the theater table. It takes that long for educations and keep running and discuss with them because it's serious and they need to learn. It's all about learning how to walk again through that path of weight loss. It's not easy, it's not for everyone, it is for the right patient. Please remember that it is the operation for the right patient. So we've got that major, all of these people have problems, but this is before surgery. And we can see the deficiencies are significantly high. I consent my patient when I do sleep gastrectomy to about 10% deficiencies they'll have. Maybe they're going to be iron and calcium, but I've got now a company who's making for me a fiber which has increased calcium absorption by 30%, so I'm not countering problems with vitamin D and calcium, so it's working. They poop well. What they said, if you don't eat, you don't shit. If you don't shit, you die. Correct? So I'm making sure they shit. Sorry for the language. B12, we all know that's the basic questions from, is it second or third year medical school, pathology or somewhere? We remember that. And then we all talk about how they have a peripheral neuropathy. So far, I haven't exposed to that, so deficiency. My colleague had one, but he had about 500 cases more than me, so I'm not sure I'm on a pathway of or 1,200 cases. Maybe I will be on that path. Folate, hello, obstetrics. You guys love this. You know, spinal, neural problems. So yeah, this is after sleeve gastrectomy is got affected, but it's not really with bypass surgery. Iron is because we need the acids get coupled with the to absorb. So you need to monitor that, but you need to educate, and again educate. You tell them about the food, you tell them about how they select the food, what is the right food for them. Protein first, vegetable second, fruit, fat and carbohydrate. This is the way to go. Vitamin D, as I said, 90% always have, because the vitamin D really stored in the fat cells. So that's a fact for us. And so we need to go, because they will end up with bone pain, and our orthopods will not going to be happy with us. Calcium, osteopenia, that's osteoporosis and osteopenia, that's really problems, and maybe they will love us because they will end up doing joints, more replacement, and that's what they keep telling us. And that's minimal surgery. Is that one of the guy was doing minimal surgery on the ankle? So maybe that's a good one. I don't replace calcium, but I tell them what to drink and what to have, especially the milk with bene fiber, and they have protein into it. Vitamin A, we all know about night visions. I didn't know about these thickened conjunctiva. Possibly I was asleep on that lecture. But fetal space or hazy vision, that can happen. Vitamin E, the muscle weakness and the vision, again, they all coupled. Vitamin B, again, muscle problems, they cause that. But I will test it. I usually test all of these 1 year after surgery. I do them before surgery, and I do them 1 year after surgery. Copper, I had a patient. One patient, I know I was in my room watching her coming up the room, and she was struggling. All I remember from endocrine, many years I was a lecturer, I was talking about endo. He said, if you got proximal myopathy, think about copper. So I tested, it was not traceable after a bypass surgery. Also, she had a celiac disease and inflammatory bowel disease. I don't know which one comes first, but it was my luck. I diagnosed her when she's not able to. So I'm not bad at diagnosing, guys. I'm not ordering CTs for every patient. And this is our beloved, because everybody talk about bariatric surgery. They lose their hair, and they got some loss of appetite and some lower alertness level. But I give people with zinc because I believe in the wound healing for major laparotomy, which I haven't done for a while. Thank you very much for everyone. I think I finish in 5 minutes. Is that 5 minutes? And last, I get bonus.
Can we invite all the speakers to come to that area, please?
Ahmad Mahdi, Victoria. سؤال دكتور مهند. Intermittent fasting, and we talk about how to learn and educate the mitochondria. So is there any evidence base or any studies for those to prove successful? I mean, I know you did a lot of research on that, but can you tell us, is there any studies that support that intermittent fasting?
Yes, so with regard to the mitochondria, there are a plethora of studies to show that all mitochondria are deficient when we are 50 years and beyond, and 48% of them are deficient when we are up to 40 years old. And it is in these studies that they recommended that the best modality to push the mitochondria on is to stop all the carbohydrate. However, you have to put another fuel. And you can't put loss of protein because in these studies they found that unfortunately very, very high protein diet is proven pro-cancerous as well. So that is one point against the Aitken diet, for example. So they end up seeing that high fat diet, medium protein in a capacity of 1 gram per K per day is suitable to that. However, that does not replace the benefit of intermittent fasting. So the conclusion in these, they're all nutritional studies, very happy to provide the references or requests. But those are the nutritional studies show that the combination of intermittent fasting and high-fat diet is the best to wash the mitochondria. And what happens as if the intermittent fasting here will lead to a conclusion that there is significant scarcity of calories. So what will happen then after a while will start the autophagy and what we call the mitophagy, which is mitochondrial eat itself. And basically that will result that those cells will lose themselves and their mitochondria. When you go and eat again after prolonged fasting, the bone marrow will replace with a new set of mitochondria, but guess what? They are a new generation of mitochondria and they are fat adapted. So the loss of the mitochondria will be replaced if you continue on the same thing. That's why after a while people feel that even their stamina, durability, and their skin texture, etc., they all get better and definitely lead to more longevity. So that is the value of the study described.
Dr. Mohammed, shukran jazeelan for the insights about physiology and how people can lose weight. With keto diet, or me as a GP, just a little bit concerned about hypercholesterolemia. What do you think about that?
Yeah, so unfortunately that is it's not our fault or your fault. It is actually written in the books that we studied and in the books that our mentors studied. And that people, when they started blaming the cholesterol and advocating for the polyunsaturated oil, which is not in nature, by the way. Nature has either saturated or monounsaturated. Polyunsaturated is all the industrialized oil that's come from vegetable seeds. Why it was popular? Because it has zero cholesterol. That's why there was a heart sign next to it. All the evidence now, not now actually, over the last 30 years, now primarily from 1985 and until date, that the cholesterol is the poorest predictor of cardiovascular disease. Even actually, the low-density lipoprotein is the poorest predictor. What is the good predictor of the cholesterol is the high-density lipoprotein, which can only come if you consume lots of saturated fat. And the triglyceride. So that's why when I always want to see the triglyceride, and I want to see the HDL, and I want to see the ratio of the HDL to triglyceride. I don't care about the cholesterol. I do believe that some of us are more oily than others. And I personally discourage them from worrying about the cholesterol as far as they don't have family hypercholesterolemia and as far as the serum cholesterol value is less than 7.5. I don't care if it is 6 even. That will not make them having, say, if you take, for example, the Hindus group researchers. The Hindus group researchers, they are all vegetarian by religious belief and others, and they all eat similar to vegetarian diet with some protein. But they reported the highest cardiovascular disease in the world. So the Indians are good in technology and IT, but they are the first as well in cardiovascular disease. How did we get this comfort from? No one chased that. It's all written in a huge number of literatures. But they ate vegetarian. What's the problem? And that's because they ate zero cholesterol. So cholesterol is, I think, is the innocent guy that we have been blaming over the last 6 years.
It's interesting what you say, because the evidence shows that there is a strong link between how high LDL is and your future risk of cardiovascular disease.
Yes, so but however, if you dissect these literatures, actually they have not checked all the factors. So the risk of development, what are the other contaminating factors in these, and what is the mortality? Have a comment here?
So when you look at cardiovascular risk factors, you don't look at just cholesterol. You look at smoking, obesity, high blood pressure, cholesterol, yes, one thing, triglyceride, and genetics, family history, and all of that. So if you correct all of them, and only cholesterol is sitting between 5 and 6, it's actually not an indication to treat.
Sorry, you're talking about total cholesterol or LDL?
We're talking about the whole lipid profile. So when you go to the whole lipid profile, everything is elevated. And even with cardiovascular risk, so the patient is obese, BMI 45, he's a smoker, he's not physically active, and he's got family history of heart disease, and beside that, he's got diabetes, high blood pressure, cholesterol, triglyceride, everything is high. So when we try to correct all the cardiovascular risk factors, cholesterol, yes, can be a number, 5 or 6. Is it indicated to treat? No, because I will probably leave it. So generally, I usually leave it if we manage to talk about everything else as cardiovascular risk assessment.
Thank you. Just add one thing. With metabolic syndrome, the criteria doesn't include cholesterol or other even. It includes mainly the triglyceride and also the low HDL. So by the criteria, we go by the hypertension, central adiposity, the dyslipidemia, but this dyslipidemia is not universal in its effect. It includes mainly low HDL, low high density, and a high triglyceride. These are the worst things. And even in diabetes, actually, triglyceride level is what matters rather than the cholesterol level. This is part of the syndrome itself.
Sorry, just one more thing. Insulin and hypertension, I think Dr. Mohammed, you talked about it, or yes? So with that, you said if you see a patient like a new diagnosis of hypertension, maybe think about checking insulin. Are you talking about insulin resistance?
Well, indeed. So as if I just want to try to, when we teach it, we try to tell the registrars that don't ever think about hypertension as a standalone problem. And of course, if the patient has no other risk factor, slim as, and everything is normal, etc., then maybe he has a renal hypertension or even a minority of essential hypertension. But in general, if you think they have risk factor, it is indeed the insulin I would first suspect as a cause, because that will direct your thinking and management in a way you deal with it then as a syndrome rather than only giving him antihypertensive drugs to control the hypertension, which is only a symptom of a full group.
Sorry, I have two questions. First one is for Dr. Durai. This is actually a real patient who has tried multiple non-medical treatment for weight loss and then went into medical treatment, still no success. And she then had gastric sleeve and no weight loss and had bypass surgery. And she was lucky enough to survive my cesarean section, by the way, so she's alive. What is your next step after bypass and all of that, still no weight loss? What do you then do next?
Again, we always know there is, like insulin resistance, there is weight loss resistance subgroup. And again, and that's why in a hospital, in a public hospital setting, some people, they have to go through a lot of hurdles to jump before they can be qualified. I really don't know about your patients, so it's very difficult to guide, but whether there is an endocrinologist involved, because there are a group of people who actually suffer from hypolipidic, hypothyroidism. On top of that, they have lipedema, which is completely different than a normal obesities. And these people are really very difficult. When they come to me and I said, expect 15% weight loss. It's not much, it's as much as a balloon or as much as possibly Saxenda or the new Manjora, which is coming into the market. So you need to have the right patient for the right operations. Unfortunately, some of the patients, they go to a surgeon, and I have a lot of my colleagues, they see patients, telehealth with them, and within 2 or 3 days they have surgery. It is difficult. You need to have your team, and to be successful, you need to have really at least between 7 to 8 minimum I got 11 team members, and they all see the patient. Then we sit, and then we decided if the surgery is fit for them, and that's what the multidisciplinary is. It's very hard to discuss about a patient. Now, the other things I want to talk about, GPs, when you, every time you prescribe insulin to the patient, think about insulin resistance. Actually, you're increasing the insulin. How many of you give insulin and they start to decrease the level? You're always increasing it, correct? You never decrease it. So that's a problem. So please think about it. Also think about surgery. If your patient has not lost weight by any means within 6 to 12 months, and that's how the way is United States going, please refer them to discuss. Talk to them. And maintenance, I always use medication. So I'm now offering surgery, and maintenance is medication, which is going to be huge. But will take a time because surgery is the bad guy.
Sorry, and second question for Dr. Mohanad. The intermittent fasting seems to be very good and promising, but do you know if there is any long-term side effect or disadvantage of ongoing intermittent fasting?
Thank you. So if we think about human beings, I think every one of us can and should fast for 12 hours. So every one of us should not eat for 12 hours in the evening. But that is not intermittent fasting. That is, I will call it baseline normal. So everyone who fasted for some 16 hours with an eating window of 8 hours showed absolutely no complications. The only complications happened when people indulged in significant fasting, which is, we call it prolonged fasting, something like 48 hours and beyond. Unfortunately, that would sometimes cause significant acute shutdown in electrolytes, etc. So when they eat, they experience something similar to repeating syndrome, and they have to be careful how to replace it, etc. So I think if we talk about the bariatric intermittent fasting, which is up to even 18 hours, and I'm not aware of any complication having to that. It is absolutely safe, it's reproducible, and even if you leave it, you can come back to it and do the same and help with the same benefit. But prolonged fasting does have some minor side effects, so we need to select our patients for prolonged fasting. Talk about intermittent fasting, some people cannot do it. The best example is type 1 diabetics, for example. They have to be selected very carefully. Or, for example, people in a pregnant lady, for example, definitely cannot do it. Or young people, etc., people with other. So we study, we don't, it's not one size fits all. We study the patient, and sometimes we tell them that, unfortunately, not for you, for example.
It's very interesting topic. That's great. Thousands of questions, just to talk of time. I just want to ask Mr. Ahmad about the balloon. There are different balloons. Some of them can be swallowed by the patient, and this can last for 4 months, and that through the endoscopy. So, are there any opportunity to repeat this procedure after the 4 or 6 months? This is one thing. Another thing, some of the patients cannot have general anesthesia. Can we do the endoscopy and that? Sedation, light sedation, because when I was in term in Iraq, we do the gastroscopy just with the local like lignocaine spray and sedation. For example, I have a patient with the myasthenia gravis and morbidly obese, and we cannot do the general anesthesia.
Generally speaking, for the reinsertion of the balloon, there is a very good evidence that the gain is minimal. That applies to all of them, not only for the oral one, the ellipse or other. So when you put one and you gain some loss there, there's only minimal loss following that. It's in the region of 6 to 9% if you put another one. That's why it's not indicated. So it's not indicated. If one balloon failed after a decent period with the good management, with the multidisciplinary team, then something else should be considered. Like you go for ESG or laparoscopic. It's hard to do an interventional procedure without full anesthesia. because there is a very high risk of aspiration, very high risk. We handle it now, even other things. Say, the double balloon thoracoscopy, which I do in this hospital, we do intervention, but it's a must to have the intubation there. Procedure that takes 1.5 hour. So for this, whether it is ESG or whether it is a balloon, the intragastric balloon, anesthesia is a must. We can't do it without it. It's different. The gastroscopy you can do, you can do colonoscopy without sedation. In Japan, they do colonoscopy without sedation. But for this one, the intervention on the balloon, whether the insertion or withdrawal, even after deflated, it's done with the full intubation.
Thank you very much for your presentations. What about pediatric? What's the best option, especially overweight, not obese or morbidly obese, but overweight pediatrics? What's the best advice we can give?
Thank you, Dr. Basim. Actually, in pediatric, of course, the fundamental like in adults. So we start with lifestyle modification, is the best thing to do. Diet, exercise, behavioral therapy. And next step, we might try to use some of the anti-obesity medication. Now, for example, in the United States, the age limit for starting GLP-1 receptor agonist has been reduced from 18 years to up to 12, and maybe in the near future, maybe up to 10 years. So the same applies as an adult, but of course there is age limits for starting the pharmacotherapy. The majority of medication are not safe to be given in the pediatric age group. Though I'm not a pediatric endocrinologist, but this is what I got from the information. So fundamental is lifestyle changes, behavioral therapy. We might choose maybe the succinate GLP-1 receptor agonist if the child is 12 years and above. We might give a try. That's from the medical aspect.
What about that? The fasting. Fasting and diet.
Once again, so it's all about the commitment here. So let's say if they are 17, 18-year-old, as I mentioned in my presentation, we really educate our high school students as well to try it, because that is the best time to train their mentality of what is the best time to eat, the best time to rest, etc. University students is all good for them. I don't think there is any contraindication. What I would like to add about the pediatric age group, I prefer personally that these patients first heavily visit the endocrinologist and being significantly checked, and it has to be on multidisciplinary selection base rather than sort of solely GP surgeon referral, because there may be more than one endocrine process underlying that. Yeah.
Well, there is ASMBS now they just produced a statement about obesity in adolescents, which is indicated that they need to be monitored very closely by pediatrician, general pediatrician, endocrinologist, pediatric endocrinologist, and then after that, if all that's failed, in a multidisciplinary with dietitian, family involvement, find out why, and involvement in sports, important that is for sports to be involved, maybe a couple of different sports where the kids can find themselves, and then if they fail, then surgery, and as I say, sleeve gastrectomy is number one, especially if they finish their growth. So we're talking about 14, 15 years old. Now, certainly in Australia, we have about 75 patients in Royal Brisbane Hospital. When I was a registrar or when I was a fellow too, been performed up to now. I kept a record of 75 for the last 10, 15 years. But gee, it is very hard. It's very hard to take that child and take them to surgery. And the problem is, after a while, after 2-3 years, when you review them in the clinic, they don't remember what they had. They cannot, I mean, lovely, they lost weight, but they don't remember what operation they had. So it's very, very hard. And at the moment, it's stopped in Queensland for the last 3 years. So it's very, very delicate in Australia, very delicate. In America, they do them. Mexico, they do them. Other countries. Saudi Arabia, they did 3 years old.
I just have one last question. Just a question for Dr. Alrubaie, please, just about semaglutide. I noticed in the studies that you were quoting that it's meant to be dosed at 2.4 milligrams, I think, for weight loss. And in diabetes, I think you're using a lower dose than that. I get a lot of patients coming into ED on 0.25 milligrams, 1 milligrams with significant symptoms, and then I guess they quit the drug after that. Is there any efficacy in putting them on lower doses than the 2.4 milligrams, or is there just no evidence?
Yeah, so that's a very good question. We don't start with the 2.4 milligram immediately. We start slowly to limit the side effects. So we start the same thing, 0.25, then for 1 week, and then 0.5 milligram for another week. For a month, and then 0.5 milligram for a month, and then 1 milligram, and so on until we go to the maximum dose, which is 2.4, which is the approved dose for weight loss. However, some people, they are very sensitive to GLP-1 receptor agonists. There are many published data about significant weight loss even on a small dose of GLP-1 receptor agonists. But I'm talking about the regulatory body criteria. The FDA approved the 2.4 milligram, not the 1 milligram for obesity, because the clinical trial shows the effect of 2.4, not the 1 milligram on obesity. So if there are any side effects during the escalation of the dose, what we do usually ask our patient to go back to the previous dose and try again to escalate the dose again up titrate the dose. If the side effects develop again, then we ask them to just stick to the dose that is tolerable to them. Does that make sense?
Yes, thank you.
One more last question.
Sorry for the last question. If there is any trustworthy study about linking metabolic disease or diabetes or weight gain to what they call it, earthing or body charge, electrical charge, especially when there is any research about mitochondria or something. If there is any, anyone of you aware of any study linking these metabolic illnesses to the body charge, or discharging?
Unfortunately, I haven't done the best research on that, but I have been doing that over the last 2 years, and unfortunately, I did not reach any of that.
My question, because there's always a fixed parameter, a fixed thing, but there is independent or certain research that can be not included in certain things, which can make a breakthrough one day,
Just probably indirect response to your question, Doctor, is that now there is a huge work on the microbiome, both for the small bowel and the large bowel, in the etiology of obesity. That's in the root of the insulin resistance and the metabolic syndrome. And the Chinese, they have a huge work on diet in relation to this and in relation to some other illnesses like inflammatory bowel disease. And they do have large studies on diet during pregnancy. So adjusting diet during pregnancy to adjust the microbiome of the infant in relation to the development of inflammatory bowel disease and obesity. So there's a lot, we talk about some other evidence there. Yet there is a good evidence that now microbiome play a protocol, and by adjusting that, they can work on the root. All of us work on the features of it there, while this is actually working on the root of the problem. Thank you.
Okay, thank you very much, everyone. I think that brings us to the end of this session and the end of the whole conference. Thank you, everyone, for attending.
Just a quick remark. I would like to thank you all for tolerating us all this period of time. So when I was talking to the College of General Practitioners, they told us your program is very heavy, is very rich. So that's very hard. So thank you all. Thank you for our presenter. Thank you for the management committee. This is the first medical conference post-COVID, and we will have another medical conference in Melbourne. And that we're going to show it maybe in March or April, and we will start preparing this through our colleagues there. Thank you very much again. Thank you. There will be a dinner for those who are interested in attending. There will be a gathering dinner, and it's open for all attendees here, by the way. If you want, we have the address. The address is probably in Fairfield, it's a half an hour driving, so all of you are invited.